Yalla, connect now. Already there. Just connect. Connect. They already have already. Just connect the screen. Connect the phone. Connect the phone to the screen.
أنا أسوي مقدمة وانتقل البايوغراف. إيش رأيك؟ ما دام عندك أنت في التلفون. أحسن.
Assalamu alaikum. Good morning, everyone. Professor, Doctor, ladies and gentlemen, thank you and welcome in the third day of the SASMBS 8th conference in the Al-Khabar. We'll start our session today with Dr. Abdullah Al-Masoud. He completed his bariatric and metabolic surgery fellowship in Canada in 2012 with over decades of experience in bariatric and minimal invasive surgery. He's an active member in the society. I would like to welcome him, and
it is our great pleasure to welcome Dr. Abdullah, and he is going to talk about weight recurrence and recurrence of hiatal hernia after Roux-en-Y gastric bypass. Dr. Abdullah, the stage is yours, please. Thank you so much.
Bismillah wa salatu salam ala Rasulullah. Today I have an interesting case, a gentleman who had previously a Roux-en-Y bypass in 2007. It was known for him that he had an elementary limb of 1.5 meters, biliary limb of 1 meter, and the common channel was unknown, as usual. And he had a hiatal hernia repair by that time. His preoperative weight in 2007 was 150 kilograms with a BMI of 45, and he had a total weight loss of 54%, nadir of 68 kilos, 19 because of weight regain, and he had an elementary limb of 2.5 meters. So his mass index upon arrival was 43, weight of 140 kilos. So I started the case by doing a laparoscopy to this gentleman, and as Brolin in 1991. And the procedure is controversially accepted at this stage of surgery. A sharp dissection is carried out between liver capsule, trying to save the energy source from the it's feasible was an idea just to give the surgeon or to give time during the surgery. At this stage, a lateral dissection was carried out from the left. The field was a little bit narrowed. Here we can see the circular anastomosis and small pouch from the stomach is obvious. Again, the problem of inability to introduce the orogastric tube toward the anastomosis and further toward the negotiate the field and to understand the anatomy better. So we can see the giggling or the movement of orogastric tube at this moment, the surgical point of view of the esophagus, as well for the sake of crural repair. The edge of the sling of the left crust. The edge of the sling of the left crust was seen. I'm apologizing because the video editing was a little bit faster than usual. It was done by Al-Johara, my daughter.
Dr. Abdullah, 5 seconds. Please, can you conclude?
The video already, sure. Can you,
can you make it
I will
fast,
take
please,
it
because we are short of time.
So the chloroplasty was done with the Bledget repair in the horizontal mattress, and then identification of a common channel of 1.5 centimeter. 1.5 meters from the ileocecal valve. I found a candy cane that was elongated at one of the anastomoses that I have to resect, and doing a Brolin technique of elongated elementary limb of 4.5 meters and doing an anti-peristaltic fashion anastomosis and closure of the mesentery forwards. I don't have much of a follow-up to this patient. Till now it's 2 months period, and the patient already lost 10% of actual weight, which is 14 kilos. Thank you very much.
Thank you so much, Dr. Abdullah, for your talk. If there is any eager questions, or we'll go to the next speaker. So we'll go to the next speaker.
Salam. We would like to welcome Dr. Abdurrahman Nimeri. He will talk about the RAW and O interoperative consideration and how to manage it.
Good morning, everyone. So this is my disclosure slide. You saw it yesterday. So I'm going to speak about how does learning curve is different between at least OHGB and Roux-en-Y, show you importance of port placement, and then show you a complication of a Roux-en-O that we had. So if you compare sleeve, one anastomosis, and Roux-en-Y, one of them has only resection sleeve, one has resection with a long pouch, and you don't work below the colon. Then Roux-en-Y, you need to make a short pouch work above and below the colon. That's why it's a little, the risk is a little higher, and the learning curve is also more difficult. And there are many reasons why it's difficult, having to port placement, intracorporeal suturing, and so forth. So that's why in the study that was done, in the Swedish study, they showed that initially when you do internal hernia closure, there is actually more evidence of obstruction. So the video I want to show you, and for the sake of time, this is just how to place the ports. We start in the left upper quadrant, and then we place the camera and all the ports based on inside anatomy. I think that's the important thing, to choose where to put the camera. So the case what we're doing is you can just make sure the video starts. 58-year-old female, BMI is 55, had a band initially, then a band conversion to sleeve 2 years before she came to see us, and then we were planning a conversion of sleeve to bypass. She did not want to have SADI or duodenal switch, which is usually our recommendation for someone like her. Let's make sure that the video is running. So you will see initially in the video how we typically run the bowel. You have to go back and maybe just move the video very little. So hover on the video, yeah. And you can move it very little. No, less than that. No, way less than that. Way less. Yeah, that's good. So typically I'll show you how we make our, so this is how we usually run the bowel. Elevate the colon. We try to identify the ligament of Treitz, like that. And then what we do first is, once we run it, we transect. Then we leave the BP limb on the surgeon's left hand. And we make sure when we run the Roux limb, we run it in a counterclockwise, moving the tip of the Roux limb towards the left lower quadrant. So the tip of the Roux limb is far from the tip of the BP limb. So this is how we usually do, like this. So this is the most important step, is you flip the tip of the Roux limb far from the other side. So you always have the tip of the Roux limb on your right side, the tip of the BP limb on your left side. There's difficulty in the anatomy. In our case, so this is like one of our very, very good fellows working. You can see she is struggling with running the bowel. And then now when she's running the bowel, she's unable to get it to go the usual way. And typically, this is what should give you a hint that there's a problem. So at this stage, we are not concerned. She's running the bowel, having difficulty, but she's able to run it. Okay, now what's important, that arrow points to where the BP limb is. So she put the stitch in the Roux limb, and then you notice she picked the tip of the Roux limb, because usually this tip is on your left side, but because of the difficulty, the tip is sitting in front of her. So she took the bite here, and until this stage, I'm watching with her, assisting, holding the camera, did not notice anything. She made the JJ, and until this stage, did not notice anything. Closed the JJ enterotomy. And then when she was trying to close the defect, she made a comment to me that this mesentery looks way bigger than usual. You'll notice how the mesentery looks.
Dr. Abdurrahman, if you can conclude.
Yeah, we can stop if you want. I mean, the video is not finished, but if you want to stop, that's okay.
Thank you very much.
Yeah, sure, no problem.
Speaker, Dr. Abdullah Al-Utaibi, and he is going to speak about undue niacin fundoplication and RYGP in the same sitting. Dr. Abdullah, please start to stick to the time.
Thank you. Assalamu alaikum. Good morning. I am very happy to share with you an interesting case about conversion of niacin fundoplication to Roux-en-Y gastric bypass. To start with a short history, this is a 36-year-old male who has undergone niacin fundoplication in 2016. Patient gained weight and reached a BMI of 45. He requested to undergo a bariatric surgery. A preoperative workup was unremarkable. He was offered to undergo unwrapping and RYGP. To start with, this is an omental adhesolysis. And then releasing the liver from the lesser omentum, going upward till visualizing the fundoplication and reaching to the right crus. As you see here, dissecting the fundoplication from the right crus. And here anteriorly releasing the phrenoesophageal ligament. And also releasing the fundoplication from the left crus. We have to be very cautious in each step to avoid esophageal injury. And then going posteriorly retroesophageally at the level of the confluence of the crura to release also the fundoplication. Then we see, as we see here, almost completely released fundus. And then we start after that with a standard Roux-en-Y gastric bypass. And the shorter the pouch, the better the outcome in terms of GERD control in this patient and also to improve weight loss. And to be sure finally that there is no posterior attachment of the fundus and to create a tunnel. As you see, a small pouch. And then I decide to excise that fibrosed fundus and devascularized fundus. Is it worth saving? First of all, to minimize the risk of postoperative complication and also to improve weight loss.
1 minute.
Yeah, the rest is standard RYGP. Just I'm starting with the gastrojejunostomy first and keeping the loop up, and then doing jejunostomy. And I always prefer to close all mesenteric defects. Starting, this is enterotomy in the biliopancreatic limb, and keeping the loop up. Closing with the V-lock sutures.
Dr. Abdullah, can you conclude, please?
Yeah. Thank you so much. Any questions?
I would like to welcome Dr. Muhammad Al-Ghamdi. He will talk about the incidental RO during one anastomosis gastric bypass revision, how I solve it.
Assalamu alaikum. Good morning. It's my pleasure to be here to present a case of incidental RO while revising one anastomosis gastric bypass. Can you show the video? This is a 40 years old lady. She's a status post sleeve gastrectomy on 2017. Status post one anastomosis gastric bypass on 2021. She presented to our clinic complaining of symptoms of GERD, hiatal hernia, and bile reflux. So we decided to go for hiatal hernia repair and biliary limb diversion. Can you go to video? This is the hiatal hernia repair. We are trying to dissect the right crus. Then to identify the left crus. Here we are pushing the pleura away. And here is the esophagus fully mobilized. And we did the cruroplasty. This is the normal configuration of one anastomosis gastric bypass. In our case, it was twisted. So this is a reality. This is the efferent loop, and the other is the afferent loop. But intra-op, we assume the opposite. We did the enterotomy at the afferent lobe. Then we are trying to pull the efferent lobe to do the other enterotomy and to do the jejunostomy. And we assume it is efferent lobe, but in reality it is the afferent lobe. So we count about 50 to 60 cm. Then we did the jejunostomy, as you can see. Is it really efferent? So at this moment, we observe that there is something wrong, but we did not diagnose the patient yet intra-op. Is this internal hernia? We are not sure. When you have a raw NO configuration, you will have a bowel in the Patterson, as you can see here. This is a non-reducible bowel at the Patterson space. So at this time, we diagnose the patient intra-op with raw NO configuration. So how to fix it? When you encounter a raw NO, either you receive a complication from outside. How to fix it? We have to disconnect all the O loop, starting from the gastric pouch.
1 minute remaining.
Then you have to disconnect the biliary limb from the JJ. We start counting now from the DJ to make sure this is the afferent limb, or this is the biliary limb. Now we are disconnecting the biliary limb. Then we have to disconnect the common limb. But before, we have to mark the biliary limb.
Dr. Mohammed, if you can conclude.
We'll disconnect the common limb and we'll repeat all anastomosis. We'll have new gastrojejunostomy and new jejunojejunostomy. And we have to disconnect the mesentery of the
Thank you,
whole
Dr.
loop
Mohammed.
and to remove it as a specimen.
Our pleasure to introduce the next speakers, Dr. Abdul Wahab Shahrani. He's going to speak about the option to revise BBD for failure to thrive in the presence of a bypass stomach.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to talk today about our experience and small videos for the revision of biliopancreatic diversion. It's called Scobinaro surgeries. Sorry. Yeah, in general, Scobinaro, as you know, that it's introduced in '76 and has been modified by many surgeons. Because of sake of time, we'll be very quick to move to the videos immediately. This is the stages of Scobinaro, cholecystectomies, then after that distal gastrectomy and duodenal transection, and they modified the technique to make it with the stomach preserving. The issue for that is to keep a big stomach that the patient, they can eat, they can enjoy the food, but without benefit, because the common lip, it's only 50 centimeter, and they keep ensure to the patient to take high protein diet, but unfortunately, you know, the communities for the stuck to the diet is not that good. This is why we face this kind of complications. The second stage and third stage to make anastomosis, we'll talk about. In general, this is the picture for this classic Scobinaro with distal gastrectomy and removing the whole stomach, and to make a common limb only 50 centimeter. Why we are doing revisional? Because we face the extensive protein malnutrition and excessive weight loss, stool and gas intolerance, malabsorption, especially for the electrolytes and vitamins. So what we are doing either elongation of the common limb if the stomach distally removed. With the new modification, if you still preserving the stomach, we are doing a restoration of the intestinal continuity to make it to normalize anatomy. The last thing, intestinal limb shortening is very rare, and we never did it. We have a good experience with the cases. We did more than 500 cases for the last 10 years in our center, and we are planning to publish the experience near, inshallah. Case number 1, she's a 56 years old female, 11 years post BBD with distal preserving stomach. This is a good case because we have stomach, BMI is very high, and she had all the complication of Scobinaro. This is the step of procedure. Before, this is the common limb is only 50 centimeter, and we restored everything, all the anatomies, with decreasing the stomach size because the patient is morbid obese. Can you run the video, please? Yeah. So first of all, we are doing adenolysis. This is the distal stomach which is preserved. Then we are detaching the elementary limb from the proximal part of the stomach. at the area of anastomosis is not that healthy, so we resect the whole area of anastomosis. Now it's detached the alimentary limb from the proximal part of the stomach. Then we restore the anastomosis between the proximal and distal part of the stomach. After, when we resizing the stomach size, because they left like 500 ml of stomach, I mean the proximal pouch, then stomach to stomach anastomosis, gastrogastroenterostomosis. We are doing the anastomosis sometimes hand sewing and sometimes with for the sake of time using the staplers. Then we are going down, which called like Mercedes sign, 50 centimeter from the ileocecal valve to now the leak test has been done. If you can just make the video faster, please. Yeah, because this is the Mercedes sign, and we are detaching the elementary limb, biliary limb, and we are doing anastomosis. Okay, and can we move to last slide, please? Yeah. No. Can we move the? Can we skip the video, please? We'll move to the yes. Okay. Case number 2. This is the diagram because there is no distal stomach, so we are doing Roux-en-Y bypass. In 30 seconds, we can just see the area because the patient underwent of band, gastric band, then gastric band removal after that. So it was extensive adenomyolysis. She had a big hiatal hernia, so we repaired the hernias after the extensive adenomyolysis. Then we did the classic Roux-en-Y procedure. And because we lost some patients with the liver failure, selenium heart failure, and severe liver insufficiency.
Can you conclude, please?
And this is why the last things that's to say, restoration is not because we need to lose the weight. We need to maintain the excellent absorption. And many patients, we revise them, then we prepare them for liver transplant because of the severe complication of the surgery. Thank you so much.
Thank you so much. We'll go to the next speaker.
Happy to welcome Dr. Hafdi Ratroud to talk about the double candy cane, double interception in a patient with Roux-en-Y gastric bypass.
Assalamu alaikum. Thank you. So my case is it's an uncommon but simple case. Nothing to disclose. Our center's experiences. So it's a 6-year-old female who had a history of conversion of LSG to Roux-en-Y gastric bypass for weight regain almost 12 months back. Presented with repeated abdominal pain, nausea. However, she can eat and she can pass bowel motion. So we did an EGD that showed a candy cane of 3 centimeters and signs of enteritis. CT scan, as we can see, there is an interception in the roux limb, almost 60 to 70 centimeters after the gastrointestinal anastomosis. And on the coronal cut, we can see the candy cane with signs of enteritis. And then we can see another interception at the JJ anastomosis underneath in the coronal and axial cuts. So we give the patient, so she wasn't in an acute phase. She received antibiotics for 2 weeks. We repeated the CT scan afterwards. So the enteritis at the first candy cane, or the candy cane and the gastrojuge, was resolved. The resolution of the second JJ interception was also resolved. However, the roux limb interception maintained. So we elected to take the patient for diagnostic laparoscopy to see what's going on. Okay, we can start the video. So we start from the gastrojuge anastomosis. We start counting, going more distally. Like we mentioned, in the CT it was around 50 to 60 centimeters, and we face the first interception. the root limb or elementary limb intussusception. Okay, the video, I think it stopped. No way. Okay. So reduction of the intussusception. We make sure that there isn't any lesions, any masses that can explain this intussusception. So everything was well. And then we move on to our second intussusception site at the JJ anastomosis. So there wasn't any, but we discovered a very long candy cane at the site of the anastomosis, around 5 to 6 centimeters. As we can see, it's quite big, it's quite long. And anastomosis wasn't that big regarding the JJ, so. And then we moved on to the second candy cane at the gastrointestinal anastomosis with the signs of enteritis at the beginning, and we resected this part also. So our hypothesis, or what we think happened, that the gastrointestinal anastomosis candy cane, as we know, causes food accumulation and fermentation, causes bacterial overgrowth. That explains the enteritis of the patient. This will cause asynchronous peristalsis of the root limb or the elementary limb, causing the first intussusception. However, a presence of a JJ candy cane or a long JJ anastomosis can cause the JJ intussusception. Thank you.
Any question? Thank you, Dr. Hafni.
We'll move to the next speaker, Dr. Musa Zahrani. He's going to speak about managing an acute leak post an open VBG converted to raw IGB. Dr. Musa, please go ahead.
Thank you. Good morning, everyone. Today I will present a case of a VBG. It's actually two surgeries in one video. This is a 63 years old lady who did a bariatric surgery 20 years ago. We identified the surgery by CT, which was VBG. She has a severe dysphagia and reflux symptoms. Also, she had. Can you run the video? Yes. So we started our procedure with a plan to convert it to Roux-en-Y gastric bypass. So we separated the stomach from the liver all the way to the hiatus to identify the anatomy. The mesh was stuck to the pouch, and we created our anastomosis below the mesh because we thought it's very short or close to the esophagus. We did some adhesolysis and separation of mesh to eliminate any risk of stricture. This part, we thought to resect it, the vertical stable line, but we thought it's okay, it's draining well, so we didn't remove it. Then we created our gastrojejunal anastomosis. We noticed that the pouch wall was a little bit weak, so we reinforced with a couple of stitches. this is the reinforcing suturing. Can you fasten 30 seconds? We completed our Rowan-Y just in a normal fashion. Patient after 2 days became tachycardic, and we did CT. After 5 days, we saw collection, so we took her for emergency diagnostic laparoscopy. We found a collection, and we identified the source of leak, which was the gastrojejunal anastomosis. Our decision was to do a primary repair. We try to make sure that we take the biggest bite possible to maximize the possibility or the chance of healing. And we did reinforcement with augmental batching from both sides, greater and lesser, to cover the anastomosis site. And we MPO on TBN for almost 2 weeks. Then we repeated the CT, which showed collection, residual collection. But the patient was okay and tolerating after that liquid diet. And for that collection, we put a big tail to drain the collection. As you can see here, the collection. So total hospital stay was for 1 month, and patient was discharged in good condition. Thank you.
Thank you, Dr. Musa. Any questions? If no question, we'll move to the next speakers.
With a great pleasure, we would like to welcome Dr. Mohammed Bawahab to speak about back from the dead, bleeding post-bariatric surgery.
Good morning, everybody. Gonna be a short video. No disclosure for this talk. My patient is 45-year-old male Saudi, morbidly obese with a BMI 42.6, known uncontrolled hypertension for the last 20 years, uncontrolled diabetes with hemoglobin A1C 13 point something, chronic kidney disease with baseline creatinine 2.2, 2.4. Came to the clinic with the bound to wheelchair with above knee right leg amputation, left foot metatarsal amputation, secondary to ignored diabetic septic foot. And he is eager to lose weight. He's one of the family member that I operated in 5 or 6 of his brother and sisters. So an MDT were done, surgeon anesthesia, nephrologist, cardiologist, and he was postponed from surgery, pre-medicated for 2 weeks with antihypertensive, 3 medication, trying to get his hemoglobin A1C below 10. So after 2 weeks, he was cleared from anesthesia, cardiology, as well as diabetology and nephrology. Operated on Christmas Eve. Was a smooth surgery, around 35 minutes, just a sleeve gastrectomy with omentopexy and a pars plazida approach. 7 hours he went. It was uneventful surgery actually. 7 hours after that he went to where is the video? Sorry. Yeah. 7 hours after that I was called from the floor, or after 7 hours being in the floor, after he passed the recovery stage, I was called that the patient is arrested, and the code blue started for 14 minutes. Patient revived. I woke up again to the hospital. So when I was in the hospital, patient is already in ICU, and they're saying patient has a DKA. The first blood sugar on the glucometer was unrecordable, more than 600. Acidotic in ABG, so this starting treatment of diabetic ketoacidosis, insulin infusion. At that time, when he was back to ICU, fully intubated, his blood pressure on the screen with no inotropes, 220 over 160. So he was looking a bit pale to me, and I said, let's have an urgent ultrasound in the ICU. So in the ultrasound in the ICU, there is a mild to moderate collection of the blood or of the fluid. So I decided to take him back to the OR exploration. I found 2.5 liters of blood in the abdomen, suction irrigation. Then there was a bleeding at the mid-gastric portion of the sleeve stomach. Just a figure of 8 sutures were taken, control the bleeding back to the ICU, extubated next day. Now in terms of his level of consciousness post-arrest, patient completely back to his baseline, still in the hospital, getting recovered from the all the comorbidities that he has, and still in 3 oral antihypertensive medication. Imagine such patient who's been for the last 20 years non-hypertensive, no medication, non-diabetic, no medication, with all the consequences that he went through, the amputation and that thing. So the message from this, my home message from this video or this case, so always think about your surgery. Whenever there is a complication post-surgery, don't blame diabetes, don't blame hypertension, blame your surgery. Number one, you have to rule out all the complications that would happen from surgery, and luckily, alhamdulillah, the decision was taken on time, taken back to the OR and control after a long arrest. So I think this is the end of the video. I thought that you saw the spurter was a big spurter at the middle part of the stomach. I think that's the end of the case. If any questions, I'm welcome to answer questions. Maybe just have a minute or so to finish this video.
Thank you, Dr. Mohammed.
Thanks.
Any question, Dr. Haitham? He has a questions.
Mike here, please.
Hello. Thank you for your nice presentation and your message. I would like to ask you, do you regularly use clips, endo clips to do stapler line as much as this regularly, or is this special for this case? Because we, in my practice, if we suspect of bleeding, it's better suturing, especially if for sleeve gastrectomies. If patient needs a revisional surgery in the future, we learned that a patient had formerly sleeve in another center, and when we were performing a gastric bypass, the clip was surrounded by fibrotic tissue, and when we were trying to cut with stapler, it made a serosal damage. Do you regularly use these kind of clips?
I do them regularly, just over the overlap staple line, regularly, just for the mind piece.
Okay.
Thank you for that.
Just
Dr. Haitham, please
two rapid points. Number one, I think it is very important to look what happened between the when he went out from the recovery room till after 7 hours when he arrested, because there is a lack of, I think, either follow-up or observation by the medical team. This is number one. Number two, what is the cause of his arrest? I mean, patient had a blood pressure of 20 over 10, so he is not hypotensive. What is the cause of the cardiac arrest he got?
Going back to the recovery room records and to all the OR anesthesia sheet, patient was stable throughout the surgery and stable till the last minute that before he get transferred from recovery room to the ward. So I cannot blame the recovery. He stayed almost an hour in the recovery room. So what happened maybe an hour just before his arrest in the floor? Your second question, the cause of the arrest, bleeding, like the patient after the full resuscitation with what he received, noradrenaline and the atropine and the fluid during the resuscitation time, the first reading blood pressure was the 220. Regarding the cause of arrest is the bleeding.
Thank you very much, Professor Mohammed.
We'll move to the next last speaker, Dr. Hussein Al-Anazi. He's going to speak about when a sleeve thermal injury managed by OIGB gets another leak.
Thank you, Mr. Chairman, co-chairmans. Good morning, everybody. This is a case of a 36-year-old. Can you start the video, please? 36-year-old, BMI 39, with no comorbidity, no surgical history. The sleeve gastrectomy actually going smoothly, straightforward, no problems. But my assistant actually he tried to control the bleeding in the stapler line, as you see by spatula. Here he injected a methylene blue. So maybe he little bit jerky movement on the stapler line make the stable line is very weak. A week later, patient present to ER with abdominal pain, distension, fever, picture of sepsis. Start the video, please. Laparoscopic exploration showing there is a big hematoma as shown in the CT is more than 15 centimeter. We try to evacuate this hematoma. And we notice that there is a leak in the distal part of the stomach. So here we have many options that we can just primary repair or doing OGB or mini gastric bypass or RONY. We prefer to do for this patient mini gastric bypass. We just clamp just above the leak to check if there is any methylene blue, but only there is one side of leakage that it will show distal part of the stomach just at level of angularis. We use a stapler purple color, just proximal part, and on the excluded stomach we use the black stapler because it's very thick tissue. This is a big clotted hematoma infected. We take it out. Here we take 150 centimeter from DJ junction. We start our anastomosis by VLOC 20. Okay, after 3 days, patient present again with bile vomiting and the bile in the drain. So we shift the patient because he's tachycardic febrile, shift him again to the theater. Start video, please.
1 minute.
We put in our mind that the bile leakage from our either anastomosis or excluded stomach, but we face a GE junction leak at this level. So here we just move the pylorus and the antrum to check the stapler line. Everything was okay. Then we inject methylene blue, showing our anastomosis. Also, as you see here, no bile or methylene blue leakage. Then we checked in the GE junction there. Just move 10 seconds like this. Here we suture the defect by 20 V-lock. Then we take another layer with omental patch.
Can you conclude, please?
After that, patient discharged home after 5 days, removed drain, and follow up with us in the clinic. And that's it. Thank you.
Thank you so much, Dr. Abdullah. I think if there is any question, Dr. Hussein, thank you so much. There is no questions. We will conclude this sessions. So we'll move to the next session, inshallah. Thank you so much.
So yesterday we delayed the GOS session. It's the Bariatric Innovation session. It's an interesting session, and hopefully the chairman of GOS, Dr. Ahmed Darazi, will take over from now.
Good morning, everybody. I'm delighted to start. Sorry. Good morning, everybody. I'm delighted to start the first session. The GOS session. We're going to have Dr. Nadia Juma presenting single fire stabling in sleeve gastrectomy, the rationale.
So good morning, everyone. I'll be presenting on behalf of Dr. Fatiba Mahres. Today we're going to talk about single stable firing, our center experience. So what we want to propose when comparing single firing to multi-firing stabler, does it affect the early post-op nausea and vomiting or not? So this is our main question. As we all know, post-op nausea, vomiting, post-sleeve gastrectomy can reach up to 80%. So what can we do to minimize this or decrease it? There's some factors that could affect post-op nausea, vomiting, which is mainly female gender, the use of opioids. So how can we do to prevent this or at least decrease it? So our methodology, we reported the rate of post-op nausea, vomiting in compared to stablers. We had an immediate post-operative questionnaire before discharge as well as 1 week after when we saw them in the clinic. We included 4 cases that was operated by 4 different bariatric surgeons, and they had a similar background. As you can see here, this is the questionnaire that we used. So we asked the patients, usually we discharge them on the same day. So before discharge, we did this questionnaire, and then when we saw them in the clinic 1 week after. So we had a similar background characteristics, like the mean age was 35, the mean BMI was 40. They had a similar background. We only 1 diabetic and 1 pre-diabetic, and the rest was medically free. The operative time was 45 minutes, and the length of hospital stay was the same day discharge. We had 1 male and 3 females. We used the same post-operative protocol in terms of ondansetron or antiemetic that we give to the patients post-operatively, and the amount of gas was not exceeding usually 60 liters, which indicates a shorter operative time. So this is the risk factor that we make sure that it's most of our patients are similar with their female non-smokers or history of post-op nausea, vomiting pre-op. So interestingly, the post-op nausea vomiting scale was less in patients with single firing. As you can see here, it was absent, no nausea, no vomiting immediately post-op. And when we asked them in the clinic 1 week after, they only had like sometimes 1 or 2. which is promising actually. Okay, so we had already previously collected 2,000 patients from the multi-firing sleeve gastrectomy. So we took 4 patients from our population and we compared them to the single firing ones. We made sure that they have similar background, similar anesthetist, similar OR time, in order to see does it really affect the post-op nausea, vomiting, or it's not. And interestingly, it's actually affecting it. How can I go back? Yeah. Interestingly, it was actually affecting because those patients with a multi-firing, they had a more post-op nausea, vomiting in compared to the single firing ones. So all of this goes to the zigzag phenomena. So have you ever heard about zigzag phenomena? The fact that the sleeve gastrectomy has a zigzag, whether in the fundus or distally in the antrum, this might affect the nausea vomiting post-operatively. And that's why if you eliminate this and use only a single firing, this might improve your nausea vomiting post-operatively. This is one of our specimen. Actually, as you can see here, it has a straight line. There's no zigzag from the fundus all the way distally. So when you go back to the literature, there's no much papers about the Titans or the single firing staplers. However, there's one published from the US which actually also improves that it decreases the nausea, the post-operative nausea vomiting. Again, the main reason most likely is secondary to the zigzag phenomena elimination. So this is how the stapler works. Yesterday we've talked about it, I guess, but here, just briefly, you just take 1 centimeter approximately from the GE juncture, 3 centimeter from the incisura, and around 4 to 5 centimeter, and it has a different thickness all the way, and it fires distally to proximally. This is our trocar size. We usually do our sleeve gastrectomy using 3 trocars, and we also used it with this stapler. The difference that it has a 19 millimeter trocar that comes with the set, and you need to go a little bit more distally than your usual trocar side because the length of the staple, and it also depends on your abdominal cavity. So this is the video, as you can see here. We used the marker. Can we play the video, please? So we used the marker just to mark the area that I mentioned previously. Once you do that, you can just put your stapler. It's actually connected to a generator device that has an audible and tells the surgeon usually it's time to fire. The stapler now is like cutting or firing, or it's complete, and so on. And as you can see here, you can adjust your fundus accordingly, or even the whole stomach. Most likely, the stomachs will fit along all the way the staplers, and then you can just fire it. And as you can see here, this is how it looks post-operatively. A straight line, beautiful stomach, and that's it. And the benefit is the less post-op nausea vomiting. Thank you so much. Anybody has any questions? Thank you.
Thanks, Dr. Nada. We'll go for the second speaker. Mr. Mudar Osta from Medtronic, that he will speak about the future of surgery.
Perfect. Hi, everyone. Thank you for joining. On behalf of Medtronic, I want to say thank you for having us attend the Congress and for allowing us to support. My name is Mudar Usta. I am the Senior Manager for the Global Regions at Medtronic for Surgical Robotics. And today, I want to speak a bit about the future of surgery. So Medtronic, we recently came with the surgical robotic platform, Hugo. If you haven't had the chance to see Hugo, it's next door in the Congress room. And in the development of Hugo, the surgical robotic platform, we asked over the last decade to surgeons, what do you want to see in robotics? What do you like? And what could be improved? Over this feedback, we've managed to develop Hugo. And you can see here, it's an innovative solution. It's a modular platform and can be used in various different modalities. So you can use it as a standalone hybrid, a standalone laparoscopic system. You can use it as a hybrid platform, so you can use one arm only to perform a hybrid laparoscopic surgery. You can use 3 arms or you can use 4 arms, and it provides you with multi-quadrant access. We've developed an open console, so this is beneficial for training, education, and for everyone else in the room to be able to have communication with the lead surgeon. And some of the aspects, such as the foot pedals, ergonomic controllers, is familiar to other platforms, so the transition of skills is essentially seamless. Now, while we talk about the future of surgery and robotics, etc., these are very technical aspects, but the future of surgery is not in the technical aspects alone. What do I mean by this? A lot now is going towards the digitization and AI in surgery, and how this can support the future of surgery. Part of this platform is Touch Surgery Enterprise. So it's a technology by Medtronic, and essentially what it allows you to do is to record any and all procedure videos with unlimited storage, and it's housed in the cloud. The benefits of Touch Surgery from digital surgery at Medtronic is that, one, from the free app that anybody can download, so I encourage you to do that. It's on the App Store and the Android App Store as well. It allows you to essentially have all the training, all the steps for procedures, a library of indications, etc. And from that, you're allowed to essentially, excuse me, I'm going to reverse a little bit. The reason that Touch Surgery exists in the first place is that we saw variability in terms of training. So it was essentially founded by 2 surgeons, and when they compared surgical notes and how to do procedures, there was variability. We want to be able to remove that. So essentially, the platform provides this reduction in variability for standardization in surgery. The videos allow you to analyze the data that's provided through the Touch Surgery. So from the recordings, it allows you to review, it allows you to analyze, and this setup also provides you data analytics. One of the important aspects with any surgical recording is patient-sensitive information, and Medtronic has established a proprietary technology that removes all patient-sensitive information from the video before it's uploaded. An example of this, you can see when the camera is inside the patient, the system recognizes it's inside the abdomen. However, as soon as the camera is removed, in real time, everything is pixelized. Why? It removes all patient-sensitive information, ensuring GDPR compliance. And also, if the camera is removed from the patient, if the camera points at patient notes on the board, etc., or captures anyone's face, again, it's automatically anonymized before it's uploaded to the cloud. In the video recordings, what Touch Surgery allows you to do is, if you tell it what procedure you're doing, it automatically segments all of the different procedure steps. By automatically segmenting the procedure steps, it also times each of the individual procedure steps, and it can outline any outliers. So you see just on the 20th of April here, there's an orange match. It is recognized that this particular procedure has taken a longer time than usual, and it's highlighted it and it's flagged it. Also, each of the individual boxes, these are individual steps of this particular procedure, and it recognizes that the sequence of different steps has been altered. The way that it does this, if I play this video here, on the top left, you can see port insertion and gallbladder exposure. So this, for example, is a lap chole. And as we progress through the procedure, if you look at the top left of the video where it says port insertion, the system automatically recognizes when the dissection begins. And it changes it, and from this point on, it times this step of the procedure. Now we have various different procedures for laparoscopic, for robotic, and by doing this, it allows the surgeon to analyze any efficiencies, disefficiencies, and again, you see now it's changed to the ligation. This is automatically recognized. And that allows you to analyze either efficiencies of not only yourself, but if you choose to share the video or the video is shared with you by trainees, registrars, your residents, etc., or fellows, you can watch their procedure videos, support them to increase their efficiency, reduce variability in surgery. And a note here that all the video procedures that you've recorded are specific for yourself. No one else has access to them unless you decide to share it to them. So what does this allow you to have? A growing surgery of videos, a library of surgical videos. So if you have, for example, 100, 200, 300 procedure videos, it creates a unique hyperlink, and it's timed by the date and the time of the procedure. So again, there's no patient-sensitive information. The surgical instant replay, what does this mean? Within 60 seconds of finishing your procedure, you can view the entire video. You don't need to wait hours for an upload, hours for a download, etc. So even when you finish and you want to go and review your patient notes or write your patient notes, you can review the video instantly. Surgical decision support is, we talk about the future of surgery and what we have today. Touch surgery is available today, Hugo is available today, but where do we move in the digitization and AI of surgery? So this is an example of technology that's being worked on at the moment, and it's critical structure identification. What does this mean? A lot of you will be familiar with ICG. ICG is a molecule that binds to the hemoglobin in blood, and under a certain wavelength of light, it fluoresces. It allows you to see lymph nodes, it allows you to see vascularization, it allows you to see blood flow and perfusion. But what if we could identify structures without the injection of an outside molecule? So what we have here, and I'll play the video for you, is the system recognizes in real time critical structures and highlights them for you as a surgeon. What does that mean? If you're performing a surgery and even as you manipulate the tissue, the system recognizes these structures, highlights them for you to be able to be aware of them and just take precautions as you work around these particular things.
Two minutes.
And that's the presentation over. I'd be happy to answer any questions, or if you're available, please join us at the Hugo booth where you can see some of this technology in action.
Thank you so much for your presentation. We'll move to the next speaker. Give me a pleasure to introduce Dr. Abdurrahman Salim. He's going to speak about bipartition. Is the answer for recurrent weight regain after sleep? Dr. Abdurrahman, the floor is yours.
Bismillah ar-Rahman ar-Rahim wa salatu salam ala Rasulullah. Chairmen, colleagues, thank you for the invitation. Can I have the first slide, please? So till we get the first slides, that's okay, that's the second slide. So yeah, in the next few minutes we'll talk about bipartition. Bipartition actually was being introduced by Dr. Sergio Centero from Brazil, and there are two main concepts actually: that all the bowel be functioning in the digestive process, no excluded bowel, and delivering of the nutrients to the distal bowel so you can release the incretins that will induce the satiety. And that's his first publication actually in 2012. He reported about 1,000 cases. As you can see in the drawing, he do the sleeve gastrectomy, and then he hooks the distal 2-6 centimeter to the pyloric antrum, while the proximal bowel will be connected to the distal ileum. So the food will pass from the stomach direct to the distal ileum, and that's where release the incretin, while the proximal bowel will be partially functioning in the digestive process. The next move was, instead of raw wire reconstruction of the Dr. Centero, Wilfred Mu from, I think, Hong Kong, he took a loop and connected that loop, the distal 2-6 centimeter of ileum. He hooked it in a loop manner to the sleeve, the stomach. The second, or the first publication actually for loop sleeve ileostomy was from Dr. Mahdi from Sharqa, and he reported 50 cases, and he called it single anastomosis sleeve ileostomy, or SASI. Now the next modification actually was from Dr. Swayfi from El Minya in Egypt. Instead of hooking the distal 250 centimeter of the terminal ileum to the sleeve the stomach. He hooked the first third of the small bowel to the sleeve gastrectomy. The last modification was basically that Brown anastomosis. The distal 250 centimeter, he did side-to-side anastomosis, so he will avoid the biliary reflux. So all these are the 4 types of the bipartition, and all these types actually have shown a good metabolic and bariatric outcome. And all the reports here are, it's not moving. All these reports actually showed a good nutrition, and it's not moving. Yeah. Slides are not, yeah, okay. So this is, I'm just going to show a case actually. As I said, that all these reports or these types of bipartition was a primary. There was no revisional reports. And actually what's written regarding the revisional bipartition, just a couple of reports actually. So I'm reporting here a case as bipartition post-sleeve. This is a 37 years old female. She had sleeve gastrectomy about 10 years ago. She presented back to us with the weight regain. So that's her pre-op X-ray. As you can see that there is a large fundus and large residual pylorus. It's not working. The ladies, hello. It's not moving. Okay, can we run the? All right. So intraoperatively, actually, as you can see, that's here the sleeve the stomach, which was done 10 years ago. Basically the fundus was not untouched, so we dissected the fundus, and as well as the pyloric antrum was not untouched. It was just a resection of the body and the middle stomach actually. So we dissected the pylorus and we dissected the fundus, and then we resected the enlarged fundus. You can see here that the fundus is actually maintained. So we passed our bougie, and we did the section of the fundus. The point I'm trying to make here actually that if you are going to revise sleeve gastrectomy to bipartition, you have to have a well preserved pyloric antrum, which will work as a mechanical force to push the food into the 2 directions, into the proximal small bowel and to the duodenum, as well as to the distal small bowel. Now, after we did the resection of the fundus, we run the staple line, and then we run small bowel. We measure small bowel. It was like 7 meters here, and we did here 40-60. Like we connect the small bowel 2 to 3 meters from the DJ. That's here the gastrojejunostomy, and we close the gastrojejunostomy in 2 layers. And that's basically, after that we did, after we close the gastrojejunostomy, we do the methylene blue test, and after that we put a drain and we come out. That's her post-op contrast study, and it's, as you can see, that the flow going to the duodenum and is going to the distal bowel. And I think this is a main concern in this operation, that you have to get the bowel passing into the proximal bowel as well as to the distal bowel. Now, 1 year after her surgery, she lost like 56%. Unfortunately, she had a total thyroidectomy like a couple of weeks ago for papillary CA. It's not moving. Can you help me, please? It's not moving. Yeah. Okay. Between October 2017 and January 2024, we did like 88 cases. Yeah, that's their demography. Ladies. Can you move next slide, please? Hello. All right, these are the different. That's the different comorbidities, like 37% have diabetes. Next slide, please. Next slide. And these are the different actually primary, usually the compound proceeds and takes like 4 hours on average. That's the primary SASI, and as you can see that they are combined with hiatus hernia, or brown anastomosis and cholecystectomy. Next slide, please. As you can see here that we did SASI on previous sleep or previous VBG or previous banding.
2 minutes. 2 minutes.
I think this is an important part here, that our weight loss actually in revision was around 60–70% up to 6 years. The cure of diabetes was around 60%, and these are our comorbidities. And the important part actually, like I have 3 patients had cancers, and we have 3 revisions, and we have 2 mortalities. The worrisome actually is the bloating and the foul-smelling gas, and that's like 27%, and that's maybe because we don't have enough pylorus to push the fluid into the proximal bowel, which ends by having the SIBO or bacterial overgrowth in the proximal bowel. Next, please. That's the only report actually published on SAGI with the 1 year follow-up. Ours is about 6 years follow-up. I'm done. Just this machine is. Why bipartition? Actually, like it's a long list why we are using bipartition. I think the most important point here is.
Dr. Abdurrahman, can you conclude, please?
I'm concluding. خلاص. أمشي. The most important point on bipartition actually it works on the foregut and hindgut signaling. I would recommend it actually for diabetic patients, for compliant patients, for metabolic syndrome, and for super obesity, and for revision, if you have a good pyloric antrum. That's about. Thank you.
Thank you, Dr. Abdurrahman.
Thank you so much, Dr. Abdurrahman, for the fascinating talk.
Moving to the next speaker, bariatric surgery in artificial intelligence, AI augmented precision, prediction, and personalization, presented by Dr. Muhammad Fuller. Dr. Fuller. So please restrict the time. We have 8 minutes.
Assalamu alaikum. Good morning. Thank you, Mr. Chairman. Thank you, the organizing committee. So my name is Muhammad Fuller from Imam Abdul Rahman ibn Faisal University. I'll talk today about the era of artificial intelligence and how we can improve our bariatric surgery using the artificial intelligence. So Dr. Chris yesterday he spoke about the basics and the concepts of artificial intelligence. So it's not an AI, it's not ChatGPT. It started in 1950s when John McCarthy and his colleagues started to think how they can make machines learns. It evolves through times, and in 1970 Dr. Schwartz thought that computer science and artificial intelligence can augment our clinical practice and can somehow replace some of our intellectual functions. As you can see here, papers on artificial intelligence in surgery in general increasing through times, especially in the last 2 decades. And artificial intelligence is the ability to perform tasks and jobs that can use human intelligence and cognitive functions like visual perception, object and speech recognition, translation, and all these stuffs. And it evolves with time, starting from artificial intelligence to machine learning to deep learning and so on. It depends on supervised learning or unsupervised learning or reinforcement learning. And this is a general framework for artificial intelligence. It's included natural language model, machine learning, deep learning, and all these together can lead to generative AI or ChatGPT. There are almost 50 papers talked about artificial intelligence in bariatric surgery. Some of them are regarding the outcome prediction, complication predictions, resources utilization, and precision medicine, how to improve surgical training and generative AI capabilities. So the first research was on 2007 by Professor Weijie Li and his colleagues when they used AI to predict which type of surgery that can produce more weight loss. So they compared artificial intelligence, artificial neural network to linear regression, and they found that linear regression can only predict the type of procedures as a single factor that can predict the outcome. However, with using artificial intelligence, they can have more predictors like hemoglobin A1C and triglycerides. Another study used another algorithm called linear embedding, local linear embedding, and they found accuracy of 71% in predicting the weight loss. Another study, they used the AI model to produce what's called an online platform to predict weight loss after surgery. They found that area under curve is almost 0.8, and they found a lot of predisposing factors. Not only the weight loss, the AI can also predict comorbidity resolutions. In this study based on Scandinavian registry, they compared convolutional neural network to logistic regression to predict diabetic remission, and they compared these two existing scores, and they found that artificial intelligence model can give more accuracy, 0.8 area under curve, and they found that the continuous training can improve the AI and the accuracy. Another study incorporated clinical factors with genetic factors, and they studied a lot of variables, and they can conclude that not only the type of surgery, but there are a lot of variables that can predict the weight loss with accuracy reaching more than 74%. Another study by Professor Aminian from Cleveland Clinic, they studied retrospectively how can AI predict the long-term end organ complications in obese patient, diabetic and non-diabetic who underwent bariatric surgery and no bariatric surgery. They almost studied 26 variables, and they found they created an online risk score to predict this remission after bariatric surgery. Another study regarding the same comparing linear regression or logistic regression with 29 algorithms, and they found that most of algorithms have accuracy more than 90%. However, none of them has a good sensitivity. Most sensitive algorithm was the random forest algorithm. The AI also can predict complication in specific procedures like sleeve gastrectomy. This is a study based on US data, and they trained on 100,000 patients, and they found almost area under curve more than 0.6. The same applies for one anastomosis gastric bypass, when they found they studied 32 variables, and they found that smoking is the main risk factors for morbidity and mortality, 10 days, 30 days, and 90 days. And they created what's called clinical decision support system that can predict total complication percentage after bariatric surgery. Another one based also on US data regarding the complication after duodenal switch, and they also found higher accuracy with algorithm. Not only the primary procedures, but also in revisional surgery from sleeve to Roux-en-Y gastric bypass, they found that AI algorithm can predict more complications, and it outperforms area under curve. And it can outperform linear regression. It also can predict specific complications like cardiac events, like leak and VTE after bariatric surgery. This is the only study from MENA chapter regarding the AI from Mansour University in Egypt. They they developed an AI model to predict GERD after sleeve gastrectomy, and they found accuracy more than 0.97 and sensitivity almost 80%. There is a lot of papers regarding the complications. The other important factor is how to use the AI for resources utilization. So there is 2 papers regarding the overall cost prediction and the prediction of operative time. They found that type of procedures and the approach, whether laparoscopic or robotic, can predict the OR time. I'm running in the slides. This Chinese study refines the definition of obesity based on the criteria of AI. They categorize the obesity patients into metabolic healthy obesity, hypermetabolic hyperuricemic subtypes, hypermetabolic hyperinsulinemic subtype, and hypometabolic obesity, and this can lead to improved decision making. In surgical training, 50 videos were analyzed by AI platforms to check for safety milestones, and they found that AI can identify intraoperative complications, and they can identify any deviations and identify weak points for training. The generative AI is also very useful. This study compared between different models, ChatGPT and BARD, in answering 200 MCQ questions from ASMBS textbook, and they found that ChatGPT has 83% of accuracy.
Can you please conclude, please?
To conclude, so generative AI is evolving faster than its history. AI is not just ChatGPT or DeepSeek. AI remains in its infancy. In medicine, AI can improve utilization, decision making, and it depends on big data. So we have to call for a national and regional registry. Thank you.
Thank you very much, Dr. We always say save the best for last. It gives me great pleasure to introduce our last speaker of the session. I don't think he needs any introduction. Dr. Walid Bukhari, a very senior colleague, one of the pioneers of bariatric surgery in the kingdom. He's going to be speaking about bariatric surgery innovations, guidelines, how we did it. طبعا, one last thing, don't forget our GOS conference in Bahrain. Everybody's invited early December, inshallah. Dr. Walid, the floor is yours.
السلام عليكم ورحمة الله وبركاته. I have to apologize to start with. I was warned I should be talking very fast, so probably you will not understand what I'm saying. I barely speak English. The second thing, it's a very dry talk. The only witty part of it is the last part where I'm describing the state of the art of sleeve gastrectomy that was accepted by the World Sleeve Gastrectomy Consensus in last November in Montpellier, France. So, of course, the guidelines is very important, and the regulatory part is very important of any innovation. And as we're talking about innovation, we have to mention about people who have made a big impact. Laparoscopy is one, and endoscopy in general, is one of the very fast progressing. Any innovation takes a very long time. Look at SpaceX. It's many companies that took years on end to develop and to become. And sometimes chances plays a major role. So to talk about simple endoscopic approach to the abdominal hollow was always a dream. Ibn al-Haytham played a major role, one of the Arab innovators who used light source as candles as light source and multiple concave and convex lenses to be able to approach the abdominal hollow. Killings from Germany have done over 1,800 exploration of the abdominal hollow. After that came Christian Jacobson, where he created the trocar to introduce that they used to clean. I had the opportunity and the pleasure to be acquainted with a professor of gastroenterology, if you know, have heard of him, Kreutzfeldt from Göttingen, who has also looked into the abdominal hollow. The breakthrough there was 1953 by the multiple tubal lenses in one tube by Hopkins. Of course, Kurzem is a figure that you have to reckon with, who played a major role, was the first gynecologist in Germany who was beaten by eggs in the Berliner Congress 1978, when he presented the first laparoscopic appendectomy. And the surgeons, the German surgeons, took that as an offense because they believed in big incision, big surgeons. Hassan from America, from USA, originally from Egypt, did the first non-invasive blunt trocar to introduce. Nizhat, applying the camera, the 8mm, and mentioning the 8mm, myself, I was in Monterey, sent from the University of Göttingen, 1988, in a SAGE meeting to spy on the American, suffer from the incision more than anything. In 2 days, we had Visab, we had Karl Storz, we had Winter and Eba, Olympus coming to our university, and I was put in front line and said, Walid, you take care of that aspect. And we did. Of course, the guy who showed the film was a French professor from Nice. His name was Perissad, RIP, of course, rest in peace. This is Jacques Perissad, he died. Kurt Zim is the first gynecologist who have done the first appendectomy. So my dream was to bring that technology to Saudi Arabia. So I went and I was brave enough to meet with Mr. Winter in Hamburg, who is the owner of Olympus, the German Olympus. They make the scopes, the endoscopes, and you see that's the first VSAP, pneumoperitoneum. Before that, we used to insufflate the stomach manually, the abdomen, with our foot using air. So I went to him and I said, my dream is to introduce this in our country. He said, I will donate 2 equipment. So 1989, I went to Saudi Arabia and we presented that in the University of King Abdulaziz in Jeddah. We did a big number. That is my mentor, Professor Dr. Hans-Jürgen Piper from Göttingen, and he's now 98 years old. He's still alive. He was doing surgery till he was 84 years old, a very healthy young man. And in memory, of course, of our beloved friend and colleague and mentor, Nicolas Scopinaru, who have developed and pushed the bariatric surgery beyond the accepted or exceptional in a very short period of time. So when you talk about time span from 1988 to 2025 is a very short period to see the development that took place. So mentioning that, I have to mention Professor Adnan Mirdad, who is a professor of surgery in University of King Abdulaziz. When we came and did the first 12 cases, we presented a talk, and you know, Adnan Mirdad is like salt and pepper. He's aggressive when things happen that he doesn't like. And it seemed like he didn't like that. He told me, Walid, you are like a food fad. You always bring strange things and they disappear after 2 weeks. I told him, Adnan, as we talk today, this innovation is gonna fly. In 10 years, we will be doing at least 40% of general surgery. Little that I knew. In less than 6 years, we did the first international meeting in Saudi Arabia, in Jeddah, in King Abdulaziz Hospital, and we did more than 12 major surgical procedures that were never done before in Saudi Arabia. And we had people like Manuel Viamonte and Jacobs from Miami, and we did surgeries like low anterior resection, laparoscopically, segmental resection of colon. We had Kuhns from Germany. We had people from Brazil, I cannot remember the names now, 1994. And operations like advanced operation at that time, staging, splenectomy for lymphomas, hiatus hernia repair, incisional hernia repair, even exploration of CBD and cholecystectomies for failed ERCP for those patients were live operated in that time. So we come to that. Of course, running along with the development and the innovation in the thoughts and in the application of knowledge must go hand in hand with the application of technology. And one of the breakthrough items that we all have to admit is the energy factors that do that. Of course, I'm going to fly here because Professor Al-Gahtani Aid told me if you talk too much, we're going to call the security for you and kick you out. So I have to really fly on this. Main things that we have to take care of, developing the technology and keeping it up, is regulatory forms that I have to mention my opinion, and I could be wrong, is regulation, control, which we don't have, unfortunately. That's why today, with the dwindling number of cases of primary obesity surgery procedures, because of so many factors, we are getting a big number of chronic complications, short acute complications, revisional surgery, and we are very busy with that. So patient safety at the foremost priority for this technology to develop. And that involves preclinical testing, of course, and clinical trials, first phase, second phase, third phase. And what is very important is an effective, and that we have today. Maybe that's the most brilliant part of our development and sweep of technology, is post-market surveillance. Of course, and it has to be the approach to patient care, comprehensive pre-operative assessment, post-operative follow-up protocols, and patient education programs, and we are doing that. I must say, multidisciplinary care teams, I don't have to dwell on that, efficacy and outcome measures, standards, standardization of outcome metrics, and with AI development, that alone is a breakthrough in that aspect. Technological advancement, I don't have to tell you about that. I'm sure every one of you is being exposed to that through companies, through technical development. Advanced surgical instruments, we discussed that. Improved illumination devices, we're seeing that's happening. Insufflation devices, literature review, stakeholder engagement, and that is definitely economic factor that plays a major role in that. And we have to define our objectives. What do we want to do? Do we want just to continue doing surgical procedures, or do we want to see really a true fight against a very bad ailment and a disease? So that has to be decided, and that has to have vision and innovation up here in the mind. It's not just doing a surgery and putting a couple of thousand riyals in the pocket. Continuous education and training, very important. Somebody, Dr. Zahrani, yesterday said that is affected by the dwindling number of cases. That should not be the case. Meetings like this, discussing our real problems, openly saying what complications are happening, trying to spread the knowledge of that, advising against it, how to prevent it, and the professional, personal development. So each, and I call them units, each assistant that works with you is your responsibility, is a mirror image of you when you pass away, is your legacy. So you have to invest in that. Of course, certification and accreditation today is an important factor, and it's been definitely utilized, and it's been definitely well expanded, and we look forward for that. We have figures today in the Arab world, in the Islamic world, in the international arena, institutes that their sole job is to certify and accredit. Very important, very, very important. The point fact is ethical considerations. And I've been talking about that, and I've been hated for that. The first element of that is the informed consent. You know, I get sued like every other surgeon. And the first case against me, I made 5 pages consent form, 5 pages. Starting from a patient, normal general surgery complication, till the patient might get a flu while he's in the hospital. Signature has to be signed for any patient who are less than 21 years old by 2 of his close family members. So whenever I get sued, you know, nobody cares. Equity and access, very important. Innovations in bariatric surgery should be accessible to all patients who may benefit from them. So that's a backbone of ethical part of our mission and our life mission, regardless of their socioeconomic status. So patients must have the ability to come and get the best care, not because they cannot afford it, and that plays a role. The government, ministries of health, الضمان الصحي, the health insurance that protects the right of patients has to be involved. Efforts should be made to reduce disparities in access and advanced surgical care, ensuring that innovations do not exacerbate existing healthcare inequalities. So, not because we have excellent developed and developing innovations that only certain level of patient should be allowed to have the access to it or the expertise. I laid down a figure and a fact that areas should have committees from veteran surgeons who have the expertise to be able to answer at any time the younger colleagues that are practicing when they have difficulties or when they have problems. Okay. Sleeve state of the art, I'm not going to go there. I'm going to show the film, please. So one of the most important, and this is one of the old films, I've been doing that for the last 19 years. This state of the art, or I call it state of the art, and people in EFSO in Montpellier agreed that it is good. I always explore the hiatus as a matter of fact because of the fat pillows and fat pads that are there in patients with high BMI. Once they lose the weight, I believe that that plays a major role in the occurrence of reflux, a mechanical reflux, when those fat pads disappear. So the indication for preoperative fluoroscopy is mandatory for each and every patient. According to the ability of the patient, might it be cash patient or might it be insurance, endoscopy has to be applied whenever there is a positive indication of reflux. But I myself, I explore every patient who indicates the presence or no presence of reflux when I explore the hiatus. Okay? And that, in my opinion, have led to the decreased number of patients who have reflux in our cases. Is doing that. Another very important element that I will show now is the colorectopancreatical capsular ligament. Nobody mentioned. And I heard somebody yesterday, Dr. Zahrani, God bless him, talking about omentopexy. Omentum is a mobile organ. I had cases where all of the stomach, except for the pylorus, were in the chest, with the omentum, in a large hernia 7 years after surgery. So omentum is a mobile organ, and its main job is to protect that area from health problems, ailments, and at the same time supply blood. But it's no way fixating the stomach. There are so many ligaments involved, and in my opinion, one of the most important is the colopancreaticocapsular ligament. And that is, as you will see now, we use a 36 silastic tube with a balloon to create a small pouch at the antrum. And fixing it with interrupted stitches, making sure, yes, I was promised, I flew, you know, just let me finish, wallahi, that's very interesting and very important message. The whole subject is this the most important. Best another 2 minutes, لو سمحتوا لي. Where is Dr. Aida? Alhamdulillah, I can go on. God bless you, wallahi. Anyway, I just want to show you what I mean. Now this is, I do a tight sleeve. I do a very tight sleeve on a 36. And I want you to see, all of you do sleeves. When you put the tube, you will see the stomach moving up, right? Or most of you would. But look when we pull the tube in this case, look at the fixation to the ligament. That's a hard, very strong ligament. You could practically pull up the patient from off the table. Of course, now having said that, I have to tell you that this ligament is not always easy to identify, because sometimes it's very lax, sometimes it's full of fat, sometimes it is very thin. Important to identify it, because that is the fixating point of your lower two-thirds of the stomach that will prevent the stomach from going up. And having again said that, I have to say be careful, because behind this ligament lies very important structures like third part of duodenum and jejunum. And I had a case of mine where I totally obstructed the third part of duodenum, and I did not know why. I just took a deep stitch. I was very euphoric at that time. I'm creating a new technique, and the patient, that was the last time I saw her. She never came back to me. She goes to Adnan Sabbahi, my colleague. And the other thing is the vascular element, the superior mesenteric arteries and vein lies there. Some people are very brave. We had a case in Jeddah where a 25 years old had a ligation of that vessel and was presented, and nobody accepted him. Military, King Faisal, private hospitals, King Fahad refused to accept him. And he developed full gangrene of small bowel, 25 years old. And we had to do resection. We sent him to Karim Abul Majd in Cleveland, in Pittsburgh now, and he did a multivisceral small bowel and stomach transplant. And the guy is now 32 years old, and he just got married 2 years ago. Otherwise, he would have been condemned as open and closed case. Now, look what I'm talking about, pulling the tube out. Pulling the tube, the stomach is fixed like it's, you know, you see? It is fixed there. It doesn't move. It does not get pulled up in the thorax. And that plays a role in diminishing. So that's part of the innovation, part of the experience, part of application of the knowledge. Conclusion and key takeaway, innovation in bariatric surgical procedure holds great promise for improving the lives of individuals suffering from a very serious disease. By prioritizing patient safety, demonstrating their efficacy, adopting multidisciplinary approach, respecting ethical considerations, promoting continuous education and training, the field can continue to advance. There is no stop for it, while ensuring high standards of patient's care. Following these guidelines will help ensure that the bariatric surgical innovations are safe, effective, and beneficial for everybody. Thank you.
Thank you, Dr. Walid, for this lesson in history. I think for the interest of time, we will move on to the next session. It's going to be top abstract session, and I would like to invite the chair of the session, Dr. Ali Al-Mani, to chair the session. Thank you very much.
So we're starting the top abstract session. Our first speaker, Dr. Sulaiman Al-Sheikh, will tell us about regional bariatric surgery in a remote area, effect and safety. And it's 5 minutes talk.
بسم الله الرحمن الرحيم. Mr. Chairman, Mr. Co-Chairman, dear colleague, good morning. First, I would like to thank the organizing committee and SASMBS leaders, Prof. Gahtani, Dr. Timiyat. What I'm going to present is showing very well established collaboration between the expert of the SASMBS and the centers of the MOH dealing with bariatric surgery and trying to control the obesity in the kingdom. So revisional bariatric surgery, as we come across from yesterday, it's a term refers to follow-up surgical procedure for patients who previously had a weight loss surgery. Seven to 15% of weight loss surgery patients undergo revisional bariatric surgery. Revisional bariatric surgery, as we all know, may be for reversal of previous surgery, converting previous surgery from type to another, modifying the previous surgery, repairing a prior operation. Reversal procedure are needed when primary surgery is not enough to have the goal, or if we have malnutrition or GERD or other type of complication. Anatomical reasons include bowel erosion, gastric fistulas, breakdown of gastric stable lines, etc. Are there any benefits? Yes, all the literature supporting that. We are targeting to improve the patient health or quality of life, encouraging greater weight loss, and this is an issue, weight regain or fail to lose weight, and reduce or eliminate unwanted side effects or complications. It is not without risk, actually, such procedure, and it needs a dedicated, well-established tactics and team. So it has a risk of more bleeding, it has a longer time of recovery, and higher rate of leak concerning to the primary. Determine whether revisional bariatric surgery is needed or not. This is a pathway you should apply to the patient. You should standardize the procedure which had done first, and what's the results from the primary, and what is the expectation of the revisional surgery. So preparing the patient as usual, evaluation, medical history, physical examination, lab assessment, style of life modification, cardiac, pulmonary, all the anesthesia clearance requirements.
2 minutes.
So GI assessment we are doing, and upper endoscopy evaluation by dietitian. We are not doing CT volumetry because re-sleeve is not one of our options in our center. Or the literature supporting that. So far we are in our center. We are one of 25 centers, and we have primary cases in these 2 years. Preliminary results. We have our case load is 950 laparoscopic sleeve gastrectomy. Our revisional load is 42 cases. This is my team, and all of them has his positive input to our so far results. 31 cases mini gastric bypass, and 8 is RYGB, and 1 is reversal from RYGB for nutritional consequences. So all the patients undergo previous surgery within 2 to 18 hours. This is the recruiting of the patients. 42 of patients, 8 patients exhibited GERD, 24 weight regain, and 11 had failure to lose weight. The average PMI of those patients standing from 34 to 66 when they are selected to the revisional surgery. PMI improvement so far is 28 to 44 PMI, and by time we will see, in the end of the follow-up, we will see how much we have gained. But they are doing fine up to now. In conclusion, this is a primary result for collaboration between a team of the SASMBS and our revisional surgery cases, and I think it's a good collaboration, and we are looking forward to continue with that and to follow our patient for more results. So, Mr. Chairman and Co-Chairman, I think bariatric surgery is a stepping stone, not a finishing line, and it's a chronic disease. We need to be ready for any further intervention if the primary is not achieving the goal.
Thank you very much.
Thank you so much.
Thanks. Moving to the next speaker, Dr. Abdullah Al-Masoud. He will tell us about recurrent weight gain and second recurrent of hiatal hernia post. No, Abdullah Masoud, right? Endoscopic treatment and salvage surgery.
About long-term follow-up of a cohort with post-sleeve gastrectomy leaks, results of endoscopic treatment and salvage surgery. We worked on this study during my training. So sleeve gastrectomy is the most commonly performed bariatric surgery worldwide. Although rare, staple line leaks after sleeve gastrectomy are one of the most serious complications. Management remains challenging, and it usually depends on the expertise of the surgeon and the severity of the leak. However, over the past 15 years, the emergence of endoscopy made a major paradigm shift, improving the outcome of this complication. So the objectives of the study are to analyze the efficacy, morbidity of endoscopic management of leak, also to determine the predictive factors of successful endoscopic management. We also analyzed the long-term outcome of both endoscopically managed and surgically managed patients. So it was a single-center retrospective observational study that was conducted at a high-volume center. All patients diagnosed with leak post-sleeve gastrectomy at our institution between 2014 to 2023 were included. Patients who underwent another bariatric surgery prior to sleeve gastrectomy were excluded apart from previous gastric band. We collected the data, we collected the date and number of endoscopic procedure, technique used, associated procedures if any, size of the orifice of the leak. Also, we noted the anatomy of the stomach, especially if there was any anomaly, stenosis, and its severity. We also noted the complications of endoscopy and implants used. Surgery that was conducted either immediately or successfully or later on when endoscopy was unsuccessful was also recorded. Median follow-up was 24 months. Our data consists of a cohort of 37 patients, of which 78% were females. The median age was 43. 23 of the patients had sleep apnea, while 28% of them had hypertension. We note that 19% of the patients had a history of gastric band previously. About half of the patients were originally operated in our center, while being a referral center, the rest of the patients were from elsewhere. 9% of the patients were diagnosed and treated acutely within 7 days. And 71% of the patients were diagnosed early, within 6 weeks. The rest were either late or chronic patients. 21 patients underwent directly endoscopic management. 12 patients required laparoscopic exploration and drainage of the abscess initially. And 4 patients required percutaneous drainage before any other intervention.
1.5 minutes, please.
So overall, the success rate of pure endoscopy was 81%. However, if we only include acute and early leaks, the success rate rises to 97%. A median number of procedures per patient was 2. Associated procedure or adjunct procedure was required in about a few patients, like 24% required dilatation of stenosis. In chronological order, we can see that megastent and pigtail were used as primary intention techniques, while the rest were rather of secondary intention. Endoscopy was unsuccessful, and salvage surgery was required in 7 out of 37 patients. 5 of them underwent proximal gastrectomy and Roux-en-Y esophageal. 1 underwent fistulojejunal anastomosis, and the last one underwent Roux-en-Y gastric bypass. When comparing the patients who underwent successful endoscopic treatment to those who required salvage surgery, we note that there is no difference in the preoperative data, apart from history of gastric band, which doesn't show to increase the risk of failure of endoscopy. Time of diagnosis is shorter in the endoscopy group, and having an anomaly in the sleeve anatomy was seen more in the surgery group. The average length of stay is obviously longer in the surgery group.
Please conclude.
Okay. So removal of gastric band is a risk factor for leak, but not to failure of endoscopy. Deformity of the stomach is one of the main indicator, or it might predict failure of endoscopy. Salvage surgery should be considered in case of multiple successive failure of endoscopy.
Thank you very much. I'd like to invite the next speaker, Dr. Abdelmohsen Al-Raisa, who's going to talk to us about the outcome of concurrent hiatal hernia repair during sleeve gastrectomy.
Can I have the slide, please? Assalamu alaikum. I will talk briefly about just review about the impact of the concurrent hiatal hernia repair during the bariatric surgery. Mainly talk about the sleeve. Nothing to disclose. Briefly, I will talk about the prevalence and what's the current practice and what should we do for the hiatal during the bariatric surgery, and some technical pitfall. I will skip this. Okay. So the prevalence. This is a retrospective study. Showing a 181 patient with the average BMI 43.6. They show the hiatal hernia prevalence is 36. They diagnosed the hiatal through the endoscopy, showing small, moderate, and large. Radiographically, with the GERD also, because it's a mimic with the hiatal hernia always come together, and showing almost close prevalence, which is 40%. Most of them it's mild. Sorry.
So this is another study, the same study, showing the prevalence of the GERD was greater with the hiatal hernia. It's reached up to 52%, with the prevalence also the patient who's symptomatic is 37%. Most of them, which is 72%, had GERD and hiatal hernia, while the 28% they have nothing. So what is the current practice among the bariatric surgeons recently? They came with the survey during the International Summit of Sleeve Gastrectomy. It's among 130 expert surgeons for sleeve gastrectomy. 69% look for the hiatal hernia and search for it and as a standard of care, while 31% they are search for it if there is preoperative study or patient came symptomatic. 89% were fixed when they found it, while the 11% will do nothing. Another study by the expert panel showing the best practice guidelines, studying 12,000 cases. 83% they are supporting extensively searching for the hiatal hernia intraoperatively while doing the dissection of the phrenoesophageal membrane and look of the left side of the stomach for the hiatal hernia present. If they found it, the dissection carry posteriorly to reach the appropriate closure of the corona. Another systematic review, meta-analysis, showing just to differentiate what's the how they repair it. Either anterior, which carry a lot of, which is more simple and easy, less complication, but carry some problem which increase the severity of GERD, while the 79% they do posterior. This is the problem with this, it's increasing operative time and some complication post-operative. Okay. Shall we close the defect? This is briefly studying the patient, where 83 patient with the moderate hiatal hernia. They did 2/3 of them the Roux-en-Y and 1/3 sleeve gastrectomy. The diagnosis made preoperative or intraoperative. All of them went to simultaneous repair of the corona. They're showing similar preoperative complication and outcome with slightly increasing in time. At 12 months, 84 patients they reduce in medication, while there is similarity in the matter of weight loss, comorbidity, and outcome. This is another systematic review just to differentiate and evaluate the sleeve between sleeve and Roux-en-Y in the GERD patient. All the data and most of the data showing the Roux-en-Y, it's better effect on GERD and more efficient treatment compared with the sleeve gastrectomy. Video, please. So, what is the principle? What is the principle of repair? First, we need. This I'm talking about the sleeve gastrectomy. First, we look for the hiatal hernia, checking anterior dimpling, looking for the fat pads at the upper part of the hiatal hernia, mobilization of the esophagus, and reduce all the intrathoracic content. Reassure the length of the abdominal esophagus. Insert the bougie, and what I do, proceed with the sleeve gastrectomy and close the corona at the end. The reason behind this, just to minimize the risk of injuring the esophagus while controlling the size of the closure of the crust. So this is, sorry. Just repeating what I mentioned just now. So I will conclude here. This is I find it a good approach to repair the hernia. I use it personally. Centimeter. I will go with the posterior repair. Using the mesh selectively. If I decide about the Roux-en-Y, any hernia more than 2 centimeters, or I will go with posterior repair. About the small dimpling, if the patient symptomatic, might be I will do posterior repair, and sometimes I do nothing. Sorry. So I will conclude. the true incidence of hiatal hernia, it's underestimated for the bariatric surgeon, and the concurrent hiatal hernia repair at the time of the sleeve gastrectomy, it's safe and feasible and can improve the reflux symptom. Patient undergo to anterior repair derive no benefit and should be avoided, and we use the mesh when it's indicated. Thank you.
Thank you very much. Can we invite Dr. Mansour Rumadi? He's going to talk about closed loop gangrenous post-banded Roux-en-Y gastric bypass. Wish to stick to the time, 5 minutes.
Hi, good morning. I would like first to thank the Scientific and Organization Committee for giving me the chance to be part of this great annual Congress. Today I'm going to talk about closed loop gangrene post-banded Roux-en-Y gastric bypass by presenting a 35 years old male patient who presented to our emergency department complaining of generalized abdominal pain mainly in the bigastric area with a history of recurrent coffee ground foul smelling vomitus. He had a past surgical history of mini gastric bypass converted to lab banded Roux-en-Y gastric bypass due to failure to lose weight 8 months before his presentation. On physical examination, the patient generally looks dehydrated and mild pain with signs of bowel ischemia on his abdominal examination. His lab investigation showed high inflammatory markers, high WBCs, and CR active protein. CT abdomen done to the patient and showed a picture of bowel ischemia, decreased wall enhancement, small bowel dilatation reaching up to 4.9 centimeter. So the patient was taken to OR. Intraoperatively, he was found to have a retrograde herniation of the alimentary limb through the minimizer with around 45 centimeter ischemic small bowel. So the band was released. Reconstruction of the alimentary limb was done by resecting the ischemic part and doing primary anastomosis. Closure of both mesenteric and Peterson defect was done. Obesity prevalence is increasing, and that's lead to increase the number of the cases or the performed procedure to control this disease and its comorbidities. However, each procedure has its own perioperative complications. Failure to lose weight is one of the most common causes for revisional surgery, and it accounts for around 20 to 30%, and it can be defined as insufficient weight loss or weight regain. Most important factors for failure to lose weight are large or gradually increasing size of the remnant stomach or the pouch, behavioral factors, or non-adherence to the diet instructions given to the patient. To overcome those causes to lose, of failure to lose weight, multiple techniques have been developed and gained interest, such as narrowing the pouch, lengthening of the bilipancreatic limb, and placement of adjustable or non-adjustable band. Today, so I'm going to focus about the banded Roux-en-Y gastric bypass. As a history Mason in 1966, he was the first who clinically performed the gastric bypass, and it underwent multiple modifications to overcome the causes of failure to lose weight. The band is placed at the mid to distal third of the gastric pouch, around 2 centimeters above the gastrovaginal anastomosis. Its circumference is around between 6.5 centimeter to 8 centimeter. It adds a more restriction to the gastric pouch, which will prevent pouch dilatation and rapid emptying of the pouch, and that will decrease the incidence of Dummick syndrome. Although this band has some advantages, it has been also reported that it has the same complications of the laparoscopic adjustable gastric band, which are gastrovaginal stenosis leading to food intolerance, slippage or migration, and band erosion. Factors that can lead to the bowel herniation through the band are successful weight loss, which will lead to reduced amount of mesenteric fat, ectopic pacemaker cells, which will lead to dysmotility or reverse peristalsis over a fixed point, and failure to adhere to dietary instructions, which will lead to herniation of the intestinal wall over a fixed point. We did some literature review about the banded Roux-en-Y gastric bypass, and we concluded that studies that do describe the data exceeding 5 years usually have a low follow-up rate, and that will reflect a less representable images of the treated population. Several studies comparing the banded versus the classical Roux-en-Y gastric bypass. noted a statistically significant difference in both excess weight loss and in reduction of weight regain. However, it's just few points of kilograms or PMI. Also, the banded Roux-en-Y gastric bypass showed a low number of patients with long-term complication, a reduced number of associated medical problems. However, it has a high prevalence of food intolerance in comparison to the classic Roux-en-Y gastric bypass. If we compare the laparoscopic adjustable gastric band and the banded Roux-en-Y gastric bypass, the most important question we have to ask ourselves, will it has the same rate of complication? As we know that complication rate of the laparoscopic adjustable gastric band reached up to 47% in the literature, with less than 40% of the patients in the long-term follow-up had a functioning band.
Please conclude.
Sure. And reoperation rate of 68% due to complication or weight regain. Couple of case reports was found in the literature review, the same of our case or different type of migration or complication. So to conclude, careful consideration and patient education about the risk, benefits, and complication of the bands prior to their use. Early identification of the band complication can save the patient the comorbidities of the band. Long-term follow-up and further studies is needed to know the outcome of the banded Roux-en-Y gastric bypass. Thank you so much.
Thank you very much. I'd like to invite the next speaker, Dr. Hani Al-Ansari, who's going to talk to us about cauterizations of visible vessels to prevent bleeding from laparoscopic sleeve gastrectomy.
Assalamu alaikum. It's a great opportunity to be here. And, it is a great honor. Yes, please. According to IFSO 2023 Napoli, the prevalence of obesity body mass index more than 30 is anticipated to be rise from 14% to 24% over the next 15 years. Nearly 2 billion adults, children, and adolescents may be affected by obesity 2035. Metabolic bariatric surgery, most effective treatment, being the sleeve gastrectomy and Roux-en-Y, the most procedure to be performed. Sleeve gastrectomy rise up to 60% of all procedures. Let's remember something about blood supply. It is of the stomach. It is a profuse vascular network. Complication of sleeve gastrectomy, most to occur early is the bleeding and leak. Bleeding is the most common complication, especially occurred within the first 24 hours. It is usually from the long staple line, where the stomach has been divided. Significant bleeding can lead to multiple blood transfusions or reoperation. What to do to control bleeding? Avert sewing, monopolar cautery, clips, putrescing material, or fibrin glue. Several papers and literature showed, one of the paper by Osama Taha et al. Showed that stable lying oversewing, it is an inexpensive, easy, but it is a time consuming. Another paper showed that monopolar cautery versus oversewing, it is safe, efficient, and inexpensive, while stable lying putrescing reinforcement, it limits post-operative gastric leakage and bleeding. Fibrin sealant, better hemostasis by conclusion and decrease the incidence of anastomotic leak. We studied about 2,000 patients over a period of 3 years. One surgeon, one company, and one vessel sealing system. 2,000 were involved in the study. We included both genders and from 18 to 58 years old. Patients divided into two groups. The first group we use only clips. The second group we are using clips and this cauterization of the vessels near the staple line. The results there were a significant reduction in the operative time. The group one with the clips 45 minutes the procedure, while the second a marked reduction in the blood transfusion post-operative and re-operation, reduction up to 80% of the second group from the first group. And stomatic leak in both the groups was 0%, mortality also was 0%. Please run the video if possible to conclude. Putting little clips than before, we were using maybe up to 20 or 25 clips. Now we are using just 2 or 3. Look, we are just coagulate or putting cauterization on the end of the vessel. We check it also by ICG. There was no ischemia. These the offending vessels that causing bleeding, usually post-operative. For the sake of time, we can stop the video. Continue. Okay. Take-home message: bleeding is a non-case of complication of laparoscopic gastrectomy. The incidence rise maybe 1 to 6%. Bleeding is usually associated with complication, readmission and reoperation rate, mortality 3 in the first 30 days, and various methods to control bleeding should be adopted. Thank you very much.
Thank you very much. I may call Dr. Amal Habib. She's going to speak about management of incidental peridiaphragmatic cyst during bariatric surgery, case report and literature review.
So first of all, this is my objective, the medical advice in regard to excessive weight. She is medically free, noted in the form of laboratory works and ultrasonography. During her sonography, she was found to have a epigastric, a patient inside, and no solid component. The sonographers give us the differential diagnosis of pancreatic pseudocyst. CT scan was done to the patient, as you can see here in the center, if clear, showing the cyst again arising from the right cross, abutting the pancreas rather than arising from it. So MRI, again, here you can see the presence of the cyst originating from the right crus, abutting the pancreas, not arising from it, and giving the differential diagnosis of bronchogenic cyst versus foregut duplication cyst. So we attempted a surgical intervention in the form of combined laparoscopic sleeve gastrectomy with en-bloc cystic resection. This is our intraoperative imaging. Unfortunately, the video was lost due to technical issue. I was hoping to show you here today the communication between the cyst and the right cross immediately. Here, the first diagnostic laparoscopy picture, we saw a fullness in the lesser curvature. So dissection of the greater curvature was done, exploring the cyst, as you can see here in the image. So the cyst was connecting only to the right crus with minimal communication to the surrounding tissue. So the cyst was resected en bloc, and then sleeve gastrectomy was carried out safely. Histopathology. During her histopathology, the cyst was found has a respiratory type epithelium, ciliated pseudo stratified squamous epithelium, and smooth muscle lining in the walls, so the diagnosis is consistent with the bronchogenic cyst. The bronchogenic cyst is a rare anatomic congenital anatomy originating from the foregut, typically asymptomatic unless it carries out a compression symptoms around the surrounding organs. So the outcome of the patient was she had a very smooth post-operative recovery period and followed up as routine patient in the first 10 days, and then 3 months, after that 6 months, and the 1 year, and she has very smooth weight drop with no complications. So in our literature review, we have found that the incidentaloma found in during bariatric procedure is about 2% worldwide. And one study has been done in one of our elite centers here in the kingdom, studying retrospective analysis of number of patients over 10 years studying the incidental trauma. They found the rate is similar to the worldwide. It's only 1.8. Sure, 1.8%, and the top differential diagnoses were about 8 final histopathology. The top was just tumors and neuroendocrine and leiomyoma, none of which were bronchogenic cysts. So the discussion that we would like to discuss here, that the laparoscopic approach is very helpful, especially in remote lesions like bronchogenic one near the hiatal area, to minimize, and doing the combination of surgery, of the bariatric surgery along with the cystic surgery at the same time, give patient better outcome and decrease his recovery period. So the take-home message is thorough preoperative investigation to the patient, minimize your surprise intraoperatively, combined surgical approach when well investigated, doing the LSG and cystic surgeon in our case can be safely performed, minimizing the need for further surgeries and giving the patient better experience and satisfaction rate. This is my key references. Thank you so much. Appreciate it.
Thank you very much for this great presentation. With this, I would conclude the... sorry, one more presentation, my apology. So the last presenter will be Dr. Qusay Al-Wazzan, who's going to talk to us about comparison of laparoscopic sleeve gastrectomy, stable line enforcement techniques.
Assalamu alaikum. Good morning, everyone. I'm Qusay Wazzan, Senior Registrar in I'm Qusay Wazzan, Senior Registrar in King Fahd General Hospital. At first, I would to thank the organization committee for this opportunity. My talk today will be about the comparison of reinforcement technique in laparoscopic sleeve gastrectomy. We compare in our study buttressing material versus the suture. Dr. Hani made my presentation more easier to present it as he compared the clipping. So this is my outline for this presentation. I'll go through it, inshallah. The laparoscopic sleeve gastrectomy is one of the most commonly performed bariatric procedure worldwide. One of the critical steps in the laparoscopic sleeve gastrectomy, the reinforcement technique of the stapler line, to minimize the post-operative complication like bleeding and leakage. So there is different techniques in the stapler line reinforcement. Some of the surgeon using buttressing material, others using the glue clipping of the stapler line and the suturing, and some surgeon using nothing. So this is my objective from this presentation, to overview the outcome of Prince Sultan Center of Obesity and Advanced Laparoscopic Surgery in King Fahd General Hospital, Jeddah. We compare two material to reinforce the stapler line, buttressing on the left hand and the right screen, it's the suturing. We focus on this operative time, complication, and patient demographics. So our study design was a retrospective study including 347 patients, divided to 120 patients in the buttressing group and 227 in the suturing group. This data was collected between the period of 2021 to 2024. The data was including the demographic comorbidities of the patient, intraoperative data, and postoperative complication. So regarding the demographic, our result in this study, we didn't found any significant difference in the age group and the gender and hypertension. Sorry. We'll go back.
2 minutes.
Okay. In the BMI, we noticed the buttressing group was higher BMI of mean BMI of 44 versus the suturing group was 41. Regarding, we noticed also high prevalence of diabetes in the buttressing group. Regarding the interoperative data, we noticed mean operative time was less in the buttressing group than the suturing group, with almost 20 to 30 minutes difference. Post-operative bleeding and leak, and we compare also surgical site infection and reoperation for the patients. The post-operative bleeding, we reported a total of 8 cases. 4 in the buttressing group and 4 of suturing group, with no significant difference. All of it was the stapler line. The leak, on the other hand, it was higher in the suturing group comparison to the buttressing group. We recorded 0 patients from the 120 reported a leak. In the stapler line, in the suturing group, we reported of 7 patients in total. So to conclude my presentation, we found the advantage of buttressing material, shorter the operative time, absence of stapler line leakage with 0 cases presented. There is a notable prevalence. To finish my presentation, we recommend to conduct a multicentric prospective study to validate the finding of this retrospective study. We also recommend to explore the long-term outcome for different stapler line reinforcement technique in larger diverse of the patient. Clinical practice implication, we will recommend to consider the advantage of buttressing in surgical practice to enhance the procedure efficiency and to minimize complication. We encourage all the surgeons of bariatric and metabolic surgeon to evaluate the patient-specific factor like diabetes and BMI when selecting the reinforcement technique. That's it. Thank you for listening.
Thank you. Thank you very much. With this presentation, we bring this session to an end. Next will be the inauguration ceremony, and there will be an announcement by the presidency of the society.
Thank you, Dr. Amir. Now what we will do, we will have a break and you will be invited to the exhibitions. We will have the opening ceremony. We'll start with opening the area, then we'll come here and we'll try to make it short for you as well. So you are all welcome to the opening ceremony. We'll be sharp at 11, inshallah, in about 20 minutes back here on this hall.
بني آدم خذوا زينتكم عند كل مسجد خذوا زينتكم عند كل مسجد وكلوا واشربوا ولا تسرفوا إنه لا يحب المسرفين قل من حرم زينة الله التي أخرج لعباده والطيبات من الرزق قل هي للذين آمنوا في الحياة الدنيا خالصة يوم القيامة كذلك نفصل الآيات لقوم يعلمون قل إنما حرم ربي الفواحش ما ظهر منها وما بطن والإثم والبغي بغير الحق وأن تشركوا بالله ما لم ينزل به سلطانا وأن تقولوا على الله ما لا تعلمون
سعادة وكيل أمارة المنطقة الشرقية الأستاذ تركي بن عبد الله التميمي، سعادة الأستاذ الدكتور فارس بن عايض الهمزاني مدير فرع وزارة الصحة بالمنطقة الشرقية، سعادة الدكتور عبد العزيز بن عبد الرحمن الغامدي الرئيس التنفيذي للتجمع الصحي الأول. السادة السيدات الحضور، أهلا وسهلا بكم اليوم انطلاقا من المسؤولية الاجتماعية والمكانة الصحية والتميز المهني للجمعية السعودية لطب وجراحة السمنة على خارطة العمل الصحي وبرعاية كريمة من صاحب السمو الملكي الأمير سعود بن نايف بن عبد العزيز أمير المنطقة الشرقية. نرحب بكم وبحضوركم ونترككم الآن مع كلمة اللجنة المنظمة الدكتور أحمد القرزي.
السلام عليكم ورحمة الله وبركاته. سعادة الأستاذ تركي بن عبد الله التميمي وكيل إمارة المنطقة الشرقية، الزملاء الأعزة، السيدات السادة، حضورنا الكرام، السلام عليكم ورحمة الله وبركاته. يشرفنا اليوم أن نشكر سمو أمير المنطقة والدعم اللامتناهي الذي أولى لنا في لإقامة هذا المؤتمر الثامن السنوي الدولي الثامن للجمعية السعودية لجراحات السمنة. إن تشريف ورعاية لافتتاح هذا المؤتمر السنوي والذي يثمن أحد القضايا الصحية في عصرنا الحديث وهي السمنة وتأثيراتها على الصحة العامة، إن رعاية سموها الكريم وإمارة المنطقة الشرقية هي تعكس حرص من اهتمام ولاة الأمر حفظهم الله ورعاهم، واهتمام سموه الكبير بصحة ورفاهية المجتمع، والحرص الدائم على دعم الجهود العلمية والطبية لمواجهة التحديات الصحية المتزايدة. إن هذا المؤتمر يجمع نخبة من الخبراء المختصين لمناقشة الحلول المبتكرة والتوصيات للحد من الانتشار في السمنة وتعزيز أنماط الحياة الصحية الفعالة، مما يسهم في بناء مجتمع أكثر وعيا وصحة لمواكبة تحقيق الرؤية ل2030 للمملكة العربية السعودية. إن هذا المؤتمر يجمع نخبة من الخبراء والمختصين من داخل المملكة وخارج المملكة، من الدول أمريكا الشمالية وأوروبا وآسيا، مع مشاركة الاتحاد الدولي لجراحات السمنة واضطرابات العمل التمثيل الغذائي لفرع الشرق الأوسط وشمال إفريقيا. مع زملائنا في الجمعية الخليجية لجراحات السمنة بحضور أكثر من 80 متحدث محلي ودولي. بدأ التحضير لهذا المؤتمر منذ 8 أشهر على أن يظهر بالقوة العلمية والتنظيمية التي المتميزة. فاق الحضور أكثر من 450 ممارس صحي معظمهم من الزملاء الأطباء، وتميز بورش العمل، حيث لأول مرة في المؤتمرات الجراحية عمل ورشة عمل على الرجل على جراحات السمنة بالروبوت الجراحي، وتم منح فرصة تدريب 45 طبيب كفرصة للتعرف المباشر والتدريب على أساسيات جراحات الرجل الآلي، وورشة عمل للتدخلات المنظارية للجهاز الهضمي لمعالجة السمنة ومضاعفاتها. ومن أهم الورش العملية على تنظيم الممارسات العلاجية الطبية لجراحة السمنة وأمراضها. أخيرا نتقدم بالشكر الجزيل لرعاية الأستاذ تركي بن عبد الله التميمي على دعمه وتشريفه لنا في هذا اليوم، والسلام عليكم ورحمة الله وبركاته.
شكرا للدكتور أحمد القرزعي. إن التغيير يبدأ بخطوات صغيرة ولكن ثابتة. أنتم النور الذي يرشد، وبالإضافة أنكم أنتم الصوت الذي يوقد الوعي والطاقة التي تحفز على تبني أسلوب حياة فريدة وجميلة وجديدة، أكثر توازن وأكثر صحة. الكلمة الآن لرئاسة المؤتمر الدكتور سلطان التمياط، فليتفضل.
السلام عليكم ورحمة الله وبركاته. سعادة الأستاذ تركي بن عبد الله التميمي وكيل إمارة المنطقة الشرقية، الأستاذ الدكتور فارس الهمزاني مدير فرع وزارة الصحة بالمنطقة الشرقية، الدكتور عبد العزيز الغامدي رئيس التجمع الصحي، الأستاذ ناصر السبيعي المدير التنفيذي لمجموعة المواساة، الأخوة مسؤولي المراكز الطبية الحكومية والخاصة، الزملاء الأطباء، السلام عليكم ورحمة الله وبركاته. تحت رعاية كريمة من سمو الأمير سعود بن نايف أمير المنطقة الشرقية تجري فعاليات المؤتمر السنوي الثامن الدولي للجمعية السعودية لطب وجراحة السمنة، ونحن سعداء هذا اليوم بحضوركم جميعا. والزميل الدكتور أحمد القرزعي تفضل مشكورا بالحديث عن هذا المؤتمر. سأخذكم في رحلة قصيرة لنتحدث عن تاريخ جراحات البدانة في المملكة. طبعا هذا التاريخ بدأ من عملاقي جراحات البدانة، وأحد أهم ركائزها في المملكة البروفيسور عدنان مفتي والبروفيسور وليد بخاري، حيث أنهما بدأ هذه العمليات في وقت مبكر. العملية الأولى للبروفيسور مفتي كانت في الثمانينات من القرن الماضي، وكانت عن طريق الجراحة التقليدية. بروفيسور وليد بدأ جراحات البدانة عن طريق المنظار. المنطقة الشرقية ولله الحمد كانت التجربة الحقيقية بدأت في عام 2004 تقريبا في العصر الذهبي لمستشفى سعد التخصصي، حين كان هناك 3 من الأطباء يافعي السن بدأوا هذه العمليات في المنطقة الشرقية في القطاع الخاص. وفي نفس الوقت تزامن في المستشفى العسكري الدكتور أحمد القرزعي والزميل الدكتور أيضا خالد مرزا في الحرس الوطني. بدأت هذه العمليات المتقدمة في ذلك الوقت قبل أكثر من 20 سنة تجرى بسبب التطور الصحي الهائل في القطاع الصحي في المنطقة الشرقية. بعد ذلك شعرنا بوجود أهمية مظلة لنا أطباء الجراحة تحت الجمعية، بحيث نستطيع أن نطور من مستويات الأطباء فيها ونطور أيضا من أنفسنا. وكانت معضلة في البداية، عددنا قليل لا نتجاوز 10 أشخاص، ولكن الجهد الكبير الذي قام به زملائي الدكتور أحمد القرزعي والدكتور خالد مرزا وأنا معهم في الشرقية، أسسنا ما يدعى نادي الشرقية للبدانة. في هذا النادي قمنا بمحاضرات علمية متكررة على طول يعني كل شهرين 3، وبالتالي جذبنا الزملاء لهذا العمل، وأيضا أعطينا توعية كبيرة للزملاء الأطباء في التخصصات الأخرى. كانت لدينا مشكلة للانضمام للاتحاد العالمي للبدانة، لأن بسبب عدم وجود جمعية في ذلك الوقت ولا يجوز العضوية بشكل فردي، ولكننا استعنا بالفعاليات لنادي الشرقية، فقبل في الأرجنتين بعدها بسنة واحدة قبلت المملكة العربية السعودية كعضو في الاتحاد العالمي للبدانة دون وجود جمعية بفضل ذلك النادي العلمي. بعد ذلك أصبح الأمر سهل، بعد 2 و3 أصبح عددنا الأطباء الزملاء وكلهم بيننا الآن، وصلنا حوالي 20، فتم ولادة الجمعية السعودية لطب وجراحة السمنة، والتي انطلقت فيما بعد بإقامة الكثير من المؤتمرات على مستوى العالم. وبعض من الممكن أن نرى في هذه الصورة عام 2013 العديد من الزملاء المشاركين هنا. ويشرفنا أيضا في إفسو أن رئيس إفسو اللي هو المنظمة العالمية الاتحاد العالمي لطب وجراحات البدانة، أن رئيسها القادم الدكتور خالد جودة من مصر الشقيقة، وهو موجود معنا الآن. أيضا كانت فرصة لإقامة الجمعية الخليجية بفضل الزملاء في الجمعية السعودية المؤسسين ووجودهم معنا. في نفس العام تأسست الجمعية الخليجية لطب وجراحات السمنة، والتي يرأسها الزميل البروفيسور عايض القحطاني. طبعا نحن أطباء نعمل ونتنقل وما زلنا في القطاع الخاص، وحينما أتيحت لي الفرصة للذهاب إلى مستشفى المواساة في نفس المنطقة أيضا لم نتخلى عن المسؤولية الاجتماعية، ولم يكن العمل فرديا بل عمل جماعيا. كل الزملاء اللي في المنطقة الشرقية، الدكتور أسامة الصانع، الدكتور أحمد القرزعي، خالد مرزا، زملائنا أيضا من خارج المنطقة شاركوا في أكثر من فترة 10 سنوات في تدريب جميع الأطباء في المملكة على تقنيات جراحة البدانة، وكنا نجري أيضا عمليات مباشرة. بعد ذلك قبل 2 وفي الجمعية طبعا السعودية تولاها البروفيسور عدنان مفتي، ثم الآن في عهد البروفيسور عايض القحطاني. التجربة عمت المملكة العربية السعودية مع زملاء من نفس الجمعية، فأصبحنا نجري ورش العمل في جميع مناطق المملكة. هذه كانت في مكة المكرمة، وهذه في حايل العام الماضي، وأيضا أجرينا في عسير في الجنوب، وفي مناطق في الرياض. أنا بما أني أنتمي للشمال كانت في شوي عنصرية، فسويت بعرعر ورفحة مع الزملاء قبل 2 أسبوع ولله الحمد، وهم موجودين كانوا يحضرون معنا ورش العمل ثم ذهبنا إليهم. الزملاء اللي موجودين في عرعر مع التجمع الصحي في الحدود الشمالية أيضا يقومون بنفس العمليات في المدن الصغيرة مثل رفحة. ما كان أحد يتخيل تجرى عملية تكميم أو تحوير في مكان في أقصى وطننا الغالي. في النهاية اسمحوا لي أن أتقدم بجزيل الشكر لأشخاص هم خلف هذا النجاح الذي ترونه الآن، ونحن نفتخر بما شاهدتم، خاصة ورش العمل والربوط الجراحي اللي هو المستقبل إن شاء الله. البروفيسور عايض القحطاني رئيس الجمعية قام بعمل مدهش لإنجاح هذا المؤتمر، وكان خلفنا وداعم لنا في كل صغيرة وكبيرة. الدكتور أسامة الصانع هو الدينامو المحرك لهذا والقلب النابض لهذا المؤتمر، وكل شيء طيب في هذا المؤتمر للزميل الدكتور أسامة. ولو في نقص، إذا في نقص هو علينا حنا يا اللي تاركينه أكثر الوقت يقوم بالأعمال. الدكتور أحمد القرزعي رئيس اللجنة المنظمة، الزميل الدكتور عبد الله الغامدي رئيس اللجنة العلمية، الزملاء أيضا اسمحوا لي بذكر اسمائهم: الدكتور مالك المطيري، والدكتور عبد الله العتيبي، ومحمد الغامدي، وموسى الزهراني، والدكتور العرفج، والدكتور حسين العنزي. نسيت احد؟ وعبد العزيز اذكر اسمه مرتين. واخيرا الاء الشريف قامت بعمل عظيم. اشكركم جزيل الشكر.
شكرا للدكتور سلطان طميات. جهودكم ليست مجرد كلمات، بل نبض حياة يسري في وعي المجتمع، يرشد إلى طريق الصحة الصحيح ويضيء دروب صحية. الأمل لمن يسعون في التغيير. الكلمة الآن للبروفيسور عايض القحطاني، فليتفضل مشكور.
السلام عليكم، سعد الله صباحكم كل خير. سعادة وكيل إمارة المنطقة الشرقية الأستاذ تركي بن عبد الله التميمي، سعادة الأستاذ الدكتور فارس بن عايض الهمزاني مدير فرع وزارة الصحة بالمنطقة الشرقية، سعادة الدكتور عبد العزيز بن عبد الرحمن الغامدي الرئيس التنفيذي للتجمع الصحي الأول، وسعادة الأستاذ ناصر الصبيعي الرئيس التنفيذي لمجموعة الموساة، سعادة الزملاء الأكارم ضيوفنا من كل أنحاء العالم، وسعادة الزملاء أعضاء الجمعية السعودية لطب وجراحة سمنة. نرحب فيكم اليوم، وأشكر صاحب السمو الملكي الأمير سعود بن نايف على رعايته لهذا المؤتمر. طبعا الزملاء قدموا أشياء كثيرة، ولكن خليني أقول لكم إحنا نعامل ونعالج أكبر مشكلة تواجه القطاع الصحي في العالم. الوباء الأول المهدد للصحة هي السمنة، تقتل 2,800,000 شخص سنويا. احنا لو كنا حرب عالمية، لو قلنا أي شيء، مستحيل تصل إلى هذا الرقم. 2,800,000 شخص يموتون سنويا، تكلف الاقتصاد السعودي 100 مليار سنوي. بعض الناس يقول أنت 100 مليار أنت منين جايبها هذه؟ احنا نقول لكم السكر والضغط والمفاصل كل هذه والعقم 30% كلها بسبب السمنة. تخلص من السمنة تتخلص من هذه الأمراض، ولهذا يجب أن نقف مع وقفة رجل واحد من أجل محاربة هذا الوباء. السمنة الآن لم تعد شكل تجميلي، السمنة الآن هي مرض لها تصنيف عالمي ولها مسمى ولها عيادات. يمكن قبل حوالي 20 سنة بدأنا في جامعة الملك سعود علاج السمنة بما يسمى متعدد التخصصات. وقتها كانت معاناة، وكنا نتحدث مع وزارة الصحة في ذلك الحين إنشاء عيادات في كل قطاع في المملكة. في الرعاية الأولية نسميها عيادة سمنة. طبعا وقتها كان أنت تجي مستحيل أحد يستقبلك في مركز صحي تقول عندي سمنة أبغى أتعالج، يقول ليش عندك سكر وضغط ولا لا تجيني ولا أشوفك، ليش عندك؟ ما في. الحين لا، صار إنه عندك سمنة يعني أنت عندك مرض، نفتح لك عيادة ونعالجك. وإن شاء الله إنه هذا يتبنى على مستوى القطاع الصحي والزملاء هنا في القطاع الصحي وفي جهات أخرى، إنه يكون. ووزارة الصحة عندها من خططها الكبيرة هي إيجاد عيادات لعلاج السمنة على عدة مستويات: الرعاية الأولية، ثم المستشفيات الطرفية بعدة مستويات، ثم المستشفيات اللي هي المرجعية. نحن في الجمعية نسعى لنشر الوعي عند المجتمع وأيضا تغيير السياسات، والحمد لله احنا الآن في طور نشر الإرشادات الحديثة إن شاء الله بالتعاون مع وزارة الصحة والقطاع المسؤول عن الإرشادات لوضع أسس علمية مبنية على براهين كيف نعالج المرضى، من تصلح له مثلا الإبر، ومن تصلح له العمليات الكرمشة، ومن تصلح له التكميم، ومن يجري هذه العمليات وعلى أي أسس. ونسعد أن نعمل مع بعض يد بيد على هذا الإطار إن شاء الله، وإن شاء الله نحقق هذا الهدف معا. أنا أشكركم جدا الحضور، أشكركم جدا الشركات الراعية، وأشكر كل من ساهم في نجاح هذا المؤتمر المميز الرائع. ومش أقولها مجاملة، الزملاء اللي معانا يعرفون المحاضرين الآن، والزملاء من أمريكا ومن أوروبا ومن أماكن أخرى يقولون أن هذا المؤتمر هو من المؤتمرات المميزة اللي نشارك فيها دائما ونسعى لنشارك فيها دائما. ونحن نفتخر في المملكة العربية السعودية أن نجد هذه المشاركة وهذا الثناء على محتوى العلمي وعلى الورش المقامة في هذا المؤتمر. اسمحوا لي قبل إحنا إن شاء الله نبدأ في تكريم بعض الزملاء وندعو للتكريم، ولكن الناس اللي بنكرمهم اليوم معانا هم لأسباب معينة، ليس لأنهم قدموا محاضرة، الدكتور سلطان التمياط بين أن هناك رواد حققوا تغير في ممارسة جراحات السمنة في المملكة العربية السعودية، وليس فقط تغير في الممارسة كمهارة، إنما تغير في أن تقود بأخلاق، تقود بتميز، تقود بمساعدة لزملائك، تقود أن تعلم، تقود أن تكون قدوة للآخرين. ممكن أكون مميز بعملي وعملياتي لكنني لست قدوة للآخرين، لكننا نسعى لهؤلاء أن يكون هم فعلا قدوة، ونسعى للآخرين أن يتعلمون أن القدوة اللي زيهم إن شاء الله يستحقون التكريم. عندما نكرمهم اليوم وسترون أسماءهم، هم قدوة لكم للمجموعة، وإن شاء الله نتعلم منهم ويتعلمون منهم، ونتمنى لكم التوفيق وشكرا لكم. أنا أسمح لكم، اسمح سعادة الأستاذ التركي بن عبد الله الله يطول عمرك، إذا سمح للتكريم، ندعوكم لتكريم الزملاء، تفضلوا معنا.
طبعا لكل عطاء قيمة ولكل قيمة بصمة وأثر، وأكيد إن شاء الله نكرم البروف عدنان مفتي. الدكتور وليد بخاري. الدكتور أسامة الصانع. الدكتور أحمد القرزعي. الدكتور عبد الله الغامدي. البروف عايض القحطاني. والآن تكريم الشركات الراعية. الرعاة الماسيون شركة ليلي الأمريكية. الرعاة الذهبيون شركة بوسطن سالتفن الأمريكية. شركة نوفو نوردكس الهولندية. تتشرف اللجنة المنظمة رئيس المؤتمر الدكتور سلطان التمياط. تتشرف اللجنة المنظمة تتشرف اللجنة المنظمة لتقديم درع تكريمي لسعادة وكيل إمارة المنطقة الشرقية تركي بن عبد الله التميمي. الحفل صاحب السمو الملكي الأمير سعود بن نايف بن عبد العزيز آل سعود أمير المنطقة الشرقية. صورة تذكارية جماعية. أعضاء اللجنة المنظمة يتفضلوا والمتحدثين. شكرا لحضوركم، ويبقى الوعي هو السلاح الأقوى في مواجهة السمنة وتداعياتها. الله يعطيكم العافية.
خالد ميرزا، دكتور عوض القحطاني and دكتور مالك المطيري as a chair and co-chair please.
دكتور عوض القحطاني. So, excuse me. Now we will start the session. Dr. Awad al-Qahtani, he will present. What's your topic, Doctor?
We are starting our session. So it's a strategy and decision making for Revision Roux-en-Y bypass. Can we start presentation, please?
Can you start the presentation of Dr. Awad al-Qahtani, please?
So, incidence of obesity is increasing, and the incidence number of cases of bariatric surgery is increasing, and this will lead to increase of revision bariatric surgery. So, the message from this presentation at the end is not everyone can do bariatric revision surgery, and not each hospital can do this type of procedure. Can I have my presentation, please? Stop the timer. Okay, so till we have the presentation, as I mentioned, the incidence of number of cases is increasing in bariatric surgery, and revision cases is increasing. And if you look to the indication of revision surgery or Roux-en-Y bypass is including weight regain, failure. Next slide. Okay, so the indication of revision Roux-en-Y bypass is indicating weight regain, failure of weight loss, and also management of complication, and sometimes severe bad reflux. The key factors for revision Roux-en-Y bypass or a strategy decision for revision Roux-en-Y bypass is selection of procedure, selection of patient, and also assessment of patient compliance. And as you know, till now, there is no clear guideline regarding revision Roux-en-Y bypass or revision surgery in general. What I will discuss is indication of revision surgery after Roux-en-Y bypass, patient assessment and evaluation, decision-making strategy and how I do the strategies, and also surgical revision options and our experience and strategy implementation. So, as I mentioned, weight regain is one of the most common indication for revision Roux-en-Y bypass. It's around 30%. Anatomical complication like a stricture, ulcer, and fistulas, another indication. Malnutrition, dumping syndrome, another indication. And complication like severe reflux is one of the most common complications. So we are starting by assessment and patient evaluation. So the first step we do is symptoms and comorbidity assessment, what we call it clinical assessment by history and examination. And then we do some blood tests, including multivitamins, to assess the nutrition and malnutrition deficiency. We do some images like upper GI studies and endoscopies and sometimes CT scan. And then the most important part is psychological assessment by mental health and eating behavior and also patient compliance. To assess and establish decision-making strategy for any surgeon or any hospital, it's really important to identify the cause. Is it mechanical or metabolic failure? Also, patient selection based on the body mass index, comorbidities, and lifestyle changes. And one of the most important factors is shared decision-making with your patient by explaining the benefit and risk of the intervention. We know that, and from the presentation yesterday, there's surgical options and non-surgical options, including anti-obesity medication and endoscopy intervention. So you need to know, before you start discussing the benefit and risk with your patient, you need to know the option, the surgical option, which include pouch resizing, distalization, Roux-en-Y bypass, and conversion to duodenal switch and SADI. Non-surgical options like endoscopic suturing and stoma pouch reduction, and also, as I mentioned before, weight loss medications. So if patient is coming to our clinic, what we do usually, we do the assessment. Why he is in the clinic it's because weight regain and failure of weight loss. So what we do in this patient, usually we send him to clinical dietitian for assessment and behavior therapy assessment, and we are waiting for their recommendation. If patient came to our clinic and he is complaining from, let's say, symptoms of reflux or dysphagia, then we do habit assessment. We start him in GERD diet protocol. We stop smoking and alcohol, and we try anti-acid BBI medication. And also behavior therapist is really important in this patient. So patient, already you did assessment, you have the recommendation from the dietitian and behavior therapist, and he is post Roux-en-Y bypass. We look why he failed the primary Roux-en-Y bypass. Is it weight regain or failure of weight loss? Then what we do upper GI study plus minus endoscopy to assess if there is a large pouch or not. Is there a candy cane or no? Is the anastomosis wide or not? And we assess for complication like fistula. If patient came to us post Roux-en-Y bypass and he's complaining from reflux, and he is using BBI and he is dependent on BBI, usually we assess by endoscopy to assess if there is large pouch, if there is a hiatal hernia, or if there is a marginal ulcer. So now we reach the diagnosis. We have this patient, he is post Roux-en-Y bypass, and based on our investigation, if we found a hiatal hernia and candy cane, what we do usually, we do resizing. If there's just a pouch dilatation, we have options. We can do resizing, we can do plication, and we can apply minimizer band. Regarding the limb length, and this is one of the most important things. If you look to different guideline, is not clear regarding the distalization of Roux-en-Y bypass. And sometime in the clinic, we see patient with malnutrition. They got Roux-en-Y bypass during the revision surgery. So our strategy regarding the limb length, it's based on the total elementary limb. You need to have minimum of 4 meters to avoid malnutrition and multideficiency. We measure the elementary limb, we measure the biliary limb, and we keep total elementary limb and 5 meters. We do distalization, we elongate biliary limb by 1 meter. If the total elementary limb is more than 6 meters, we do distalization, we elongate biliary limb by 150 to 204 meters, then actually we don't touch the bowel. During the endoscopy, when we do the assessment of the anastomosis, what we can do is we can do gastro-jejunal sleeve, but in this technique and this procedure, be careful not to injure the blood supply and end by a disaster. The other thing, if just the anastomosis wide with minimal dilatation of the pouch, then you can redo the proximal gastro-jejunal anastomosis. You can resize the pouch and redo the anastomosis itself. If you look to the American Society for Metabolic and Bariatric Surgery, that's what they did. So they recommend type 1 distalization is the recommended, while if the total elementary lip less than 4 meter, this will increase the malnutrition. In 1 year, 56 patients, average age 36, and most of them female, and average body mass index is 43 plus minus.
Doctor, 1 minute.
Indication of revision, most of our patients got weight regain and failure of weight loss and also reflux. Type of distalization, as I mentioned before, is type 1 distalization. If you look to the assessment, 3 months, excess weight is around 12%, 6 months is 13.8, and in 1 year is around 18, and in 6 months it's 33.6, and in 1 year, it's our weight reduction in 1 year is around 18.
Please, because there is no.
Here is a video. I'm not sure if you can give me just, it will take only 1 minute. So this video is including all the type of procedure what we did. We do the dissection of the pouch now, and we will resize the pouch. And then this patient, he had phobia band displaced to the anastomosis. So after we resize the pouch, usually I reinforce the stable line. And then we take and dissect the phobia band. 1 minute, please, just to finish it. This is the phobia band, so we release it. We apply the minimizer band after, because with this patient, body mass index is high, and also he's young, so we put some restricted procedure, which is applying minimizer band. As we see, one of the cases complicated by herniation and bowel ischemia, I think is secondary to the positioning and fixation of the minimizer band. And then at the end, you will look to the JJ anastomosis, how we do the counting the elementary and the common channel and the biliary limb.
Okay. Thank you, doctor.
Move to the conclusion.
We don't have time.
So the conclusion of this, I'm sorry. Thank you.
Yeah. Thank you, doctor. Thank you. Next speaker.
Thank you, Dr. Awad. Great presentation. Sorry for the time. Due to this situation, we have little bit manipulation of the program. The next speaker, Professor Khalid Jawdat, he is the president of the IFSU MENA chapter and the president-elect of IFSU. He is going to present a very interesting subject. I hope we will have time for discussion. Yes, please.
Assalamu alaikum. Taban, this is an amazing conference, and I would like to thank the organizing committee. I will try to go very fast. You know, all my presentations are very offensive, so I will just keep it, because I'm going to Umrah after that to watch what I'm going to do now. So, okay. So this, Osama gave me a weird topic. Roux-en-Y gastric bypass remains the best procedure to save patients from harm done by simple, innocent procedures, bipartition, OAGB, or sleeve gastrectomy. It took me like 10 minutes to understand what does this talk about. So these are my disclosures. This is my bias chart. My bias chart shows you how biased I am. 100% of my procedures are banded. I do very few sleeves. I hate sleeves. And 70% of my practice is revisions. So first, do no harm. This is our oath. And we don't have risk-free treatments, so make sure the benefits outweigh the risks. You know, I'm quite old, so let's make this a history and philosophy lesson. So now today's topic is about good guys and bad guys, okay? So good guys, Roux-en-Y gastric bypass. Bad guys, sleeve, OAGB, and bipartition. Everyone believes they are the good guys, and those who differ are the bad ones. No one on the bad guys' side feel they are doing anything wrong. It is not hard to do the right thing. It's just hard to know what the right thing is. If you want to tell people the truth, you have to make them laugh. Otherwise, they will kill you. We all love before and after pictures. So this is a very nice before and after picture. Johnny, in 2 weeks, he's just lost 2 weeks. Okay, so if you say the same thing about bariatric surgery, Johnny, you can say Johnny had a sleeve, and in 5 years, Johnny lost 5 years. Statisticulation is misinforming people by the use of statistical material. And the blackest lie is a partial truth that leads you to the wrong conclusion. Every procedure that we do has a honeymoon. All bariatric procedures give some weight loss in the first 18 months. All bariatric procedures show weight gain after that, and results at 5 to 10 years will be completely different from your initial results. Logic defying science is wrong. So whenever somebody tells you that I will do a pouch, it's not going to dilate, this is wrong. And the hallmark of any scientific study that it could be replicated. And this was the lap band blues. You go to a conference, they tell you lap band is good, you go home, do it, and it's not good. And last year they spent $30 billion to fund biomedical research, and half of the results of these are not replicated. And the demise of the lap band did not happen because bariatric surgeons proved it's a wrong operation. It happened because patients stopped asking for them when their peers told them it doesn't work. So, and this is starting to happen with sleeve gastrectomy. So what are the practice styles we have nowadays for bariatric surgery? We have the scientific, evidence-based, logic, university setting, no financial implications, and no confirmation bias. And we have the commercial bariatric surgery. Give me the money regardless. So if you have the money, I'll take it, and then we can discuss the details. You have a severe reflux hiatus explosion. So we started to see surgeons doing 40 sleeves per day and a re-sterilization of equipment. Now we have $400 sleeves in Egypt. And this doesn't have any pre or post-operative care because there's no time for that. And this has led to the relaxed sleeve concept. So if you want to do many cases, less complications, just make it a little wider, you have less issues. And of course you have less weight loss. And even with zero follow-up, they do publish 6-year results, as what happened with Rutledge. And everything is recyclable and reusable, including patients themselves. These are soft drink factory techniques, and unit numbers rather than true human care is what is relevant. And the perfect deception with the simple, innocent procedures is when you have an easy procedure with a short-term success, long-term, who cares? And if the patient fails, just blame it on the patient. You're one of my very few failures. So what are the easy bariatric procedures? Today we're talking about sleeve gastrectomy, bipartition, and OAGB. And this is nice. The difference between surgeons and internists is that surgeons practice ethics while internists mainly talk about them. This is an amazing document by Ward Griffin. So in bariatric surgery, we don't have follow-up. Very few series have more than 90% follow-up at 1 year, and very few have more than 10% follow-up at 10 years. And patient follow-up do not represent the whole sample. So if you interpolate results based on this poor follow-up, it's not going to work. How does bariatric procedure work? We don't know. We think there is an element of restriction, element of malabsorption, hormonal element. Probably it's a combination of all of these, and you said this by the change of anatomy imposed on the patient. And I used to sit with the duodenal switch group, and every year they change how they do the procedure. And in the 90s, I used to do duodenal switches, and guess what? They fail. I have seen failures with duodenal switches. So sleeve gastrectomy is the #1 operation worldwide. Yes, of course. But the voice of the majority is no proof of justice. Popular doesn't mean good. So many fast food restaurants serve food around the world. That doesn't mean their food is any good. So the facts about sleeve gastrectomy, it's a stage 1 of 2-stage duodenal switch. This happened because of the very high mortality that faced Michel Garnier doing laparoscopic duodenal switch. And it has the initial 22 to 18 month to 2 years honeymoon. And that's why when Michel Garnier wanted them to come back to him at 6 months to 1 year, nobody showed because they were in their honeymoon. And it's an irreversible reflux-inducing radical gastric resection, and also it could be considered as a self-reversing procedure. If you give it enough time, it will dilate. And tight sleeves just take longer to dilate, but eventually they all dilate. And the logic-defying sleeve timeline is when patients need help, sleeve gives initial honeymoon, giving some restriction, and patients lose weight, patients and surgeons are happy. And then sleeve dilates, patients eat more, gain weight, and patients become unhappy and ask for the help from the surgeon. Surgeons yell at the patients and tell them, well, you are one of my very few failures, you didn't change, you should change your lifestyle. Because these patients, if they were capable of lifestyle change, why would they come to us in the first place? And logic defying here is patients need help, surgeons give them temporary restriction by sleeve, restriction goes away, procedure fail, patients are blamed for the loss of restriction and weight gain. So it's a blame game between the patient and the surgeon. And usually a lie often told becomes truth. So sleeve gastrectomy on the long term, we have more than 50% weight loss failure, and we have reflux, intrathoracic migration, and Hayes hernia. And why do we revise them? Because of weight gain, GERD, and intrathoracic migration. Okay, so Rutledge devised the OAGB because he was not capable of performing the 2-step Roux-en-Y laparoscopic in 1998. So he did a big pouch, 1 anastomosis. What happened to Rutledge? Rutledge, he published 6-year data without having, with zero follow-up because he was following up his patients with internet, and when they got sick, they went elsewhere in the United States. What happened later? He lost license to practice in many states in the US. Now he's not allowed to practice for 15 years in the US, and he is the only surgeon that his membership at the SASMBS was removed. His mini gastric bypass, that to make the patients feel it's a mini procedure. So we're not allowed to say that 1 anastomosis gastric bypass in France. Okay? I'll try to stick on time, Khaled. No worries. Very popular in the Middle East and Asia, of course, because it's easy and nice and commercial. So what are the issues with OAGB? Is the anastomotic ulcers, big pouch, more acid, more ulcers. That is just logic. Alkaline reflux, it happens in 100% of patients. 8 liters of alkaline secretion pass through the stomach. Whether this is clinically significant or not, this is something completely different. Yes, maybe you don't have alkaline gastritis, but you have alkaline reflux in all the patients. Hypoabsorption, you know, with the way things are going, when you have patients without follow-up and you don't have good follow-up for them, and you have malnutrition for patients with, especially with tourism now. So the bipartition principle, SASI was invented as a technique to treat sleeve leaks. This was the initial intent. And then they said, oh wow, it's a good operation, let's do it. And it all started with Santoro. Are you guys familiar with Santoro? Santoro is a Brazilian guy that slept one night, dreamt that he could do a sleeve gastrectomy and remove half of the small bowel, and next morning he was doing this in kids. Okay, this is the Santoro 1 procedure. Now he's raving about the Roux-en-Y bipartition that he does. What are the issues with bipartition? Pathway variability and outcome variability. You can have some patients with everything would pass to the duodenum. Some patients, everything would pass through the bypass, and then few are variable, and results are very variable. And also, we run into severe malabsorption issues, and we have publications in the Middle East for medical tourism treatment with also alkaline reflux. The original malabsorption was by Nicolas Copenaro. Khaled Mirza did a lot of Copenaro procedures in the past, and he had a very tight follow-up for his patients. Look at this. I've witnessed this in 45 years follow-up in IBC in UK was presented. And actually, this was a junior resident when he was working with Nicola at that time. And they recommended you have to abandon the severe malabsorption. Now we have SASI OAGB would causing severe malabsorption without appropriate follow-up, and we're going to have an epidemic of liver failures and big problems if we don't follow up the patients well. Okay, Khaled, I'll finish. Okay, so a sleeve gastrectomy with added. So what is SASI? It's a sleeve gastrectomy with added unsupervised, unregulated, severe malabsorption performed in a commercial setting without appropriate post-operative follow-up, the recipe for disaster. So this is the publication on malabsorption with it. So you become like what you worship. Okay, so probably just to cut the chase, fixing all these problems with Roux-en-Y gastric bypass is it's not like the good guy. It would fix your reflux problems, yes, and all of these procedures, but it will not fix the weight loss. When you do Roux-en-Y gastric bypass after sleeve, what we see is 100% resolution of the reflux, 100% weight gain. So it's a weight gain procedure, and if you need to do a Roux-en-Y gastric bypass after failed any of these three procedures, you have to modify this with smaller pouches, bands, and distalization. There are patients whom we cannot help, but there are none whom we cannot harm. Standard Roux-en-Y gastric bypass is not a good. It's not a good weight loss procedure after this procedure. A relaxed pouch size is more comfortable surgery. SASI and OAGB need a metabolic follow-up for life. Standard bypass is good in restoring proper nutritional problems following malabsorption with OAGB and bipartition, and standard is not good for treating weight loss. You need to modify the operation. Our conflict of interest is the patient's well-being, not how much money we make, and acknowledge your existing biases. Thank you.
Thank you. Thank you, Dr. Khalid. Sorry for bothering you. Really, it was very nice presentation.
Thank you, Khalid.
And
I made my point.
There is nothing white and black and white, and you are very popular. Most of the audience, they don't want you to stop. I try to stop you. They said, no, let him
No
go.
problem, no
very
problem.
Nice presentation.
Thank you.
Thank you, but we don't have time for discussion. We'll go for the next speaker.
So, next speaker, Dr. Fadl Zahrani. He is consultant in upper GI, bariatric surgery, director of fellowship program, bariatric in King Abdullah Medical City in Mecca.
Thank you very much for having me.
Okay. So we are excited to hear from you. The topic: should primary one-stomach gastric bypass be restricted or modified in the area of the low BMI surgery?
I was hoping to stay before Dr. Khalid Jawdat. Now that he sold all their bariatric surgery to Lilly and the other companies, I would start my presentation by: should primary OAGB be restricted or modified in the era of low BMI? Traditionally, the bariatric surgery was offered for those with BMI above 40 or those with 35, BMI above 35 with comorbidities. Now, in the recent guidelines, the benefit and efficacy of bariatric surgery has been seen in the patients with a lower BMI, and that's why there is an update in the guidelines. One-stomach gastric bypass, also known as mini gastric bypass, metabolic effects. Now, why modify it? But we all, as physicians, risk, Dr. Khalid Jawdat mentioned earlier, excessive weight loss, nutritional deficiencies, and overly excessive malabsorption. These are some of the studies that you can see on the left side of the screen showing the benefit of bariatric surgery over the non-operative techniques for treating these obesity-related complications. Modifications that are done to one-stomach gastric bypass include what's summarized in this systematic review: either fixed BBL, short biliopancreatic limb, tailor the biliopancreatic limb to the BMI, or tailor the biliopancreatic limb to the total small bowel length, or a fixed common channel. In all these, I'm just going to go quickly through them so that we can give enough time for the other speakers. In all of those, whether you have a fixed biliopancreatic limb, or you tailor it to the BMI, there is no much difference. But the only thing that differs between 150 centimeter or the tailoring procedure or the 200 is that the nutritional effect and malnutrition post-operative. But in terms of excess weight loss, it all remains within the 65 to 85 plus minus 5 range. Even in this tailored approach, we are still remaining within the 65 of excess weight loss to 85% plus minus 5, but it seems there is, as we all know, that there is a wide variation in the total small bowel length, especially in regard to the again, you see that the excess weight loss remains between the 65 and 85 percentage. In the last FSO meeting, there was no consensus on this. A fixed common length can be another alternative, basically, but again, we see that the excess weight loss remains within the limits of the other procedures. So, and if you want to adopt this kind of procedure, you have to measure the total small bowel length, and you report the benefit to Shutam Palmer, was published in 2020. They studied 376 patients, a mean BMI of 29, the mean follow-up of 32 months, median limb length with a higher rate of marginal ulcer, and we'll come to the reason for that in details. They started with 52 articles. They ended up selecting 9 articles. You can see the gastric pouch here is constructed a little bit wider than what they would do in normal BMI patients. But and the limb lengths, as you can see here, limb lengths range between 150 and 100 and 200. As a result, all the patients had their HbA1c below 7. Resolution of type 2 diabetes was achieved in 75% of the patients. Is still above the 20. Marginal ulcer was higher because of Kim's Kim's publication, in which 22 of the patients they were smokers and they used non-absorbable suture. Their anastomosis, for which his next publication he changed that. We can't speak about lower BMI patients if we don't talk about Bagoa study, in which they included patients with C-peptide of 0.0, less than 0.0. 11 patients that were followed for 19 months, mean of 19 months. They tailored the procedure 100 centimeter for BMI of 24 to 29, 120 centimeter for BMI of 30 to 32, and 150 for BMIs of 33 to 34. As you can see here again, which is important to us, that the BMI after the procedure is never less than 20. All the patients, they stopped using the short-acting insulin, and long-acting insulin dropped by more than half for all the patients. These are type 1 diabetic patients. All comorbidities resolved for those patients. This is another article in multi-centers. This was published in 22. Studying one anastomosis, multi-centers, same surgeon, 14 patients, 12 months of follow-up. More than 50% of patients underwent remission. The HbA1c reached significant change at this first 6 months, but then remained still at 12 months. So to conclude, there is a compelling evidence that shows the safety and efficacy of anastomosis gastric bypass in lower BMI patients with comorbidities. Yet I think this area still needs further research. The ideal PBL is yet to be defined, but reasonable to stay at or below the 150 centimeter mark, or 1/3 of total small bowel length if you're going for the tailored approach. We have to pay attention to the pouch size, and with that, I would conclude. Thank you very much.
Thank you, Dr. Fadl. Now we have a question to ask you. Any question for Dr. Fadl about this topic? Yeah, Doctor. Mike, please.
Thank you, Dr. Fadl. Excellent review for the low BMI patients bypass.
So if we are adjusting the BB limb, why not just do a Rho and Y standard 100 centimeter BB limb, 100 centimeter Rho and Y?
I totally agree with you, but in many studies, the one anastomosis gastric bypass showed much more benefit in terms of weight loss. I don't agree with Dr. Khalijo that, again, the one anastomosis gastric bypass is just another variation of the bypass in general. It has more effect on the in the data and differences in practice. But again, the one anastomosis gastric bypass, at least in our center, at least with our short experience, I think it has a really strong role in the control of the comorbidities and less of nutritional effect, to be honest with you.
Dr. Fadl.
Yes, sir.
What's your opinion if a patient coming to your clinic and her BMI 32 without any comorbidities? What you will say for her?
Again, we would always consider the patient. Of course, we still abide by the governing rules, but for most of us, we would try to treat patients in multi-stage and also treat their expectations. If a patient coming with actually genuine problem and we can help them with bariatric surgery, there is absolutely no harm. And there are evidence nowadays that support whatever we do at either the governmental or private practice.
So it will be first line for you?
I always start by lifestyle modification.
Bypass for her?
No comorbidities. I don't think she's a candidate for bypass, but lifestyle modification, probably anti-obesity medication. If she is still and failing to lose weight, we'll definitely offer her surgery.
Thank you.
Thank you very much. Thank you very much.
Allow me to call our bariatric surgery Dr. Talal Al-Khwaiter. He will give us a hint to how to manage suboptimal initial weight loss post OGB. Welcome, Dr. Talal.
Thank you. Thank you very much for having me. Just to quickly say that there is clear difference between suboptimal weight loss and the weight regain. So there is totally different concepts here. What we mean here is somebody who did a surgery, who went through a surgery, but he did not get the benefit he's looking for. Either the weight, either the improvement of the obesity complications, or other reasons. So to be clear, this is the concept I'm going to talk about in the next 7 minutes. Okay. So this is my cases. I'm actually bypass and look to the suboptimal initial weight loss in bariatric surgery in general. We'll find many different definitions for that. More than 23 actually definitions in the literature reported, and most of them are different totally from the other people. So the more acceptable, let's say, definitions, somebody will say less than 50% excess weight loss. Within how long, we don't know. For how long, we don't know. And again, and less than 20% of total weight loss. We still not clear definition. The same question was raised in Napoli by J.W. Grieve, and he was asking the same question: how we can define the suboptimal responders? Who's the initial suboptimal responders? Who's the secondary non-responder? And we still have lacking of definition. So this dilemma led to clear confusion in the data and the description, and it's actually underreported in all bariatric procedures, either sleeves or bypasses or whatever the kind of surgery. We still have some lack of definition, and this lack of definition and clear or let's say accepted or convinced definition led to description of the data. So recently EFSO released this consensus about the definition, and they raised three phrases regarding the suboptimal responders. They said it's the suboptimal initial responder is either inadequate weight loss or unusual modest improvement in the obesity related complications. In general, suboptimal initial clinical response to metabolic surgery demonstrated either by total body weight loss less than 20 or inadequate improvement of obesity complication. But in my opinion, this is still lacking something. Over how long period, this definition? 2 years, 1 year, we don't know. It's not clear in the consensus. We believe it's 2 years, but it's not clear in the consensus of the EFSO. Maybe in another paper, okay. So finally, the suboptimal weight loss has different indication or implications to how to treat, how to convert, what's the problem, and etc. So, how important is this? How important is this? Mario reported in 2017 almost 0.4%. And himself in 2022 and his colleagues in the largest court of one anastomosis gastric bypass, he reported 0.48%. Shahab peers. Still lack of definition, lack of standardization. Why this issues? Many reasons. We don't know. Okay, how to deal with this problem if we have it? So we'll go standard to assist the patient, dietary, psychology, gut hormones, all this, to review the anatomy, imaging, gastrography, etc., all this, endoscopy. Then we have to discuss and to collect all these data together in one piece, and then to think what we can do. We can modify the lifestyle, we can start anti-obesity medications, and we can, actually 2 patients. The first patient was 37 male. Okay, he had no previous history, and he had a BMI of 53.1. He presented on August 2019, just before the COVID-19. He was operated in that time, on August 19, on anastomosis gastric bypass was done for him. And then in October 20, his weight, nadir for him, was 136. The BMI was 46. Total percentage of weight loss was only 13.8. That was 1 year after the primary one anastomosis gastric bypass. Then, in July 22, he was presented with BMI 54. So actually, he gained 2.5%. He was negative. This patient is labeled as suboptimal responder, initial response. After that, by 3 years, in January 25, last follow-up, his weight now is 73 kg and BMI was 24.7. And the issue with this patient is the anemia, actually 8.7. This is what we done for the patient. In 2019, his total limb is not known, but we gave him 200 centimeter of biliary limb. And then after revision surgery, we know that this patient has 13 meter total bowel length, and then 9 meters was given as total biliary limb and with 400 centimeter common channel. The second patient was female, the same story. She started with BMI of 55.5. In 22, that was in 22, she gained she lost the nadir, she reached the nadir, and then BMI was only 46.4, which was only 16.3 total weight loss. After discussion, she went through a revisional on anastomosis gastric bypass. After that, been 1 year, 2 years actually, and then she is currently on 95 kg, BMI 39. After 1 year of revisional on one anastomosis gastric bypass. Her hemoglobin level is okay, albumin level is okay, A1C is back to normal, and she's off medication, she's on remission, actually. The same story, this patient, initial procedure was 2 meters, then the total bowel length, we discovered in the revisional surgery that she has 16 meter of total small bowel length. So 200 for her, 200 centimeter was nothing for her for the initial or the primary procedure. In conclusion, suboptimal weight loss is still underreported because of lack of standardization, lack of definition, lack of consensus. Maybe significant number of people in one anastomosis gastric bypass or another metabolic surgery due to a lack of documentation, lack of reporting in the literature. We are not clear. We don't know. Is it really big number of people or small number of people, or don't know. Counting the total bowel length maybe is a good option, but still with tax, with big tax, bowel injuries and weight and time, operation time. Maybe we need to do some extra pre-op works, like working on gut hormones, genetics, some more investigations to avoid this category of patients, or to avoid this non-responders, or to choose the optimal procedures for optimal patients. Till now, we cannot predict the ideal procedure for the ideal patient. We cannot predict the outcome of any bariatric surgery, and still this topic is open for research. Thank you very much.
Thank you, Dr. Talal, for sticking to the time. Next speaker.
Thank you, Dr. Do you have any question? Yes, please.
Question?
Thanks a lot. Congratulations. Interesting presentation, but my comment is very quick. First one is your presentation should be adapted to any surgical bariatric procedure, not just only to the OHB.
Yes.
Your comments were logical, but my comment is that when you have a problem so early, you have an insufficient weight loss at the beginning, probably there's some technical issues. I mean, and you gave us the answer with your two cases. You, explored later by enlarging, lengthening the common limb,
yes.
And, the BP limb. And possibly this should have been considered before. Later in my presentation, I'll explain you why I believe this is an interesting issue about measuring the length in the OHB and in general in all procedures.
Yes.
In any case, I agree with you, but this should be for any procedure, not just for the OHB.
Yes. Thank you very much for this question. Actually, you are right. We should speak in general about all metabolic bariatric surgery, but this task was given specially for the one anastomosis gastric bypass. And I have these two patients, so it was really interesting to just show. I believe total bowel length is very important, but it's not easy, as you know. It's time consuming and possibility of bowel injuries without clamps and mobilization. So still nothing free. I think we should think about also the taxes. And I think those patients also, the very, very small number of patients, that does not really, let's say, significant to go for everyone counting bowel. So if you have like 2% or 10%, let's say, it's not justified to go for 100% for total bowel length while you're lengthening the procedure and complications.
Dr. Talal, thank you.
Thank you very much.
So much. Thank you. Next speaker, Dr. Hamad Sbey. He will present about recurrent regain weight, post-Renoir gastric bypass. What's our options?
Assalamu alaikum. Thank you, Prof. Ayed, for the invitation. Thank you, Dr. Sani and Dr. Timiyat, for the invitation and give me the chance to speak in this beautiful gathering. My talk will be about weight regain post-Roux-en-Y gastric bypass. What are the options? We all know that Roux-en-Y gastric bypass is one of the most common procedures for obesity. It has been shown in the literature and in clinical practice that it's improving the long-term outcome of comorbid illnesses that are associated with obesity, and also the quality of life for patients. Systematic review have shown that really good excessive weight loss, and it's usually after the first 2 years with an estimated percentage of 67. However, some of the patients, they may have insufficient weight loss or regain of weight that they lose it. There is two definitions between them, and the regain of weight is when they gain more than 50% of their excessive weight loss, while actually the insufficient if they lose less than 50% of their excessive weight loss. My talk will be about the regaining and the surgical. So if you look at the Roux-en-Y gastric bypass, weight regain could be either. It could be either from large pouch, or your anastomosis up there is big, which is the gastrojejunal anastomosis. There could be also possibility and the malabsorptive nature of the pouch. So after finishing the upper part of the anatomical bypass, the lower part, what are the reasons that could be relating to weight regain? It could be either the length of the biliary limb, your measurement is not the best, or the length of the Roux-en-Y, and some people, they said it's the total, the common channel. So I'll go through them step by step. I will not talk about the anti-obesity medication. It's going to be, my talk will be only for the surgical. So pouch dilatation. Pouch dilatation, your pouch or the stoma is considered to be large if it's more than 5 centimeters in its width and more than 6 centimeters in its length. That will give you a big pouch that could be related to the weight regain. Ideal pouch size, you want it to be less than 5 centimeters, and which will give you an estimate of around 30 to 50 ml as a size. So what are the options for the pouch if it's large in its size? You resizing it. You can resizing it endoscopically or surgically. Endoscopically, there is the gastric plication, which is like you suture the mucosal fold to make it smaller in its size. There is also the Rose procedure. It's the same explanation that I just mentioned. It's just suturing the mucosal fold to make it a small stoma size, small gastric pouch. It showed a good outcome within the first 3 months. Then after 12 months, start to have the issues with the weight regain. If the endoscopic failed, then the laparoscopic surgical approach is the best option. There are different techniques for it. Some of them, they go with longitudinal gastric pouch resection on a bougie, smaller than 36. They would go either with 34. This can be one of the maneuvers to be done, but I think resecting the whole anastomosis with the candy cane is the best for those patients, which is the last option, resection of the gastric pouch with the new JJ anastomosis, which is the gastrojejunal, and removal of the candy cane. In the literature, it showed short-term result, but with longer follow-up, there is the problem with weight regain again. What about if a patient have a gastrogastric fistula, which will compromise? A fistula have been formed, so it will decrease your malabsorptive, malrestrictive approach of that procedure. What's the reason for the fistula? Usually fistula, they are either from, the etiology for them could be either incomplete dissection when you create when you dissect and create the pouch. So it used to be in the past that they were not able to reach the area there and dissect the upper part. So there is a fistula. Other causes, it could be related to a contained leak that lead to communication between the remnant stomach and the pouch. So it forms a fistula. What are the options for treating that? They can be classified based on their location, so it will help you a guidance to treatment. They can be type 1 fistula or type 2. Type 1 if it's actually more than 2 centimeters. So you could be lucky and isolate it, then dissect it with the stapler. If it's less than 2 centimeters away from your JJ anastomosis, then you will end up, unfortunately, with removing the whole thing. But I think in this real life scenario, you will end up with resecting the whole thing and anastomosis again. Other causes is your anastomosis, the gastrojejunal is wide. So usually the hand-sewn anastomosis is usually give you a millimeter of 1 to 2 millimeter. The circular one is 25 millimeter, and the linear 45 significant. What are the options? Either you do endoscopic or surgical again. The endoscopic is, they can use sclerotherapy. They use it with the esophageal varices, scarring, which will decrease the anastomosis size. Or you can go with the TOR. Surgical refashioning is, I think, it's the best option for those patients. You just resize everything, remove, if there is a candy cane, you remove it, you resect the anastomosis and make a smaller one. again. Other option is banding the gastric pouch. It's been shown to have some effect, but the problem with it down the road is the migration of that band or erosion of it. So again, we fix the problem on the upper, which is the gastric pouch, the anastomosis, the communication between the remnant and excluded stomach. So what about the lower part? There are two types of distalization of the Roux-en-Y gastric bypass, type 1 and type 2. So the first modification is when you actually elongate the biliary limb. And how do you do that? You go to your JJ anastomosis, you make a cut on top of that anastomosis, and you move your anastomosis down. So in that way, you create a long biliary limb to decrease the absorption on that limb. So basically, just cutting above your JJ anastomosis in the Roux limb, and you move it on the Roux limb, which is the elementary limb, and you move it down, so you create a long biliary limb. The length that you put it down and anastomosis down there, it should be based on your measurement of the whole small bowel. But you want it to have a common channel of around 300 to 400 to prevent malabsorption. The second type of, or the second modification of the distalization is elongating the alimentary limb. This is shown to decrease the weight, but the one superior to it is the type 1. This is the same slide I'm talking about. I'll just save the time. Studies have shown, this slide is talking, I'll just make it easy for you, that you wanted to have a common channel of around 300 to 400 to prevent malabsorption micronutrient deficiency. And you wanted to have a raw limb, which is the total alimentary limb, around 400 or more. And the biliary limb, if you bypass it more, you will get more weight loss, but more protein deficiency and micronutrient deficiency. This is the same I'm talking about, and the laparoscopic. No, so after distalization, we
1
will
minute
come.
remain, please, Doctor.
Sorry? Yeah, sure. After the distalization, we will come to the laparoscopic conversion to biliopancreatic diversion. The old biliopancreatic diversion, which is the scopinaro, is actually where they make a common channel of around 500, around half meter, and then the alimentary limb around 250. So you bypass a lot of biliary limb. That's the old traditional, which is on your left side. There is the modified of biliopancreatic diversion, which is called the duodenal switch, where actually they create the gastrectomy, sleeve gastrectomy.
Can you conclude, Doctor?
Yeah, sure. I will reach to that. They create the gastrectomy and then connect it to the duodenum down there, around 4 centimeters. Then they elongate the common channel to prevent malabsorption. This is the same I'm talking about. I will go to the conclusion. This is the old scopinaro, which is biliopancreatic, and the newly modified one. And my conclusion is the mechanism that drive weight regain after Roux-en-Y is complex, and it involves a lot of factors in it: lifestyle, mental health, hormonal, and not only the surgical factors. So you have, as a surgeon, you have to judge all of those. Patients with weight regain should go under multidisciplinary approach before they're offered the treatment. The choice of surgical intervention should be based on the balance between all the risks that have been associated with the procedure that you will use to the patient and the patient's factors.
Thank you, Doctor.
Thank you so much.
I think we have no time for question. Next speaker, Professor Haytham Fawal, a known bariatric surgeon in the field of Arab area and Middle East and also international. He's working in Beirut University Hospital and different places. Dr. Fawad, sorry for short presentation for you, but anyway, you are a known surgeon in the Arab area.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. I will try to answer through my presentation a $1 million question, which is one anastomosis gastric bypass refluxogenic, and it will lead to problems at the GE junction and at the gastrojejunostomy? But I will tell you from the beginning, we will not have a clear answer, but I believe that we will have some guidelines to follow to know more and more about this procedure. I get a grant from J&J to do this study. We know that one anastomosis gastric bypass is now the third most commonly performed surgery according to IFSO. It had a good reproducibility, good weight loss, acceptable mortality and morbidity. But there is some controversy remain concerning the mid and long-term outcome, especially in terms of nutritional deficiencies and bioreflux. And after the adoption by SASMBS and IFSO, the recommendation was to surgeons who are doing one anastomosis is to study more the issue of reflux after one anastomosis gastric bypass. The literature gap on this procedure is that either they rely on only symptoms without endoscopy or biopsy. And we tried with our study to retrospectively analyze patients for which we operate at the year 2020 at 2 centers, one center in Asyut with my friend Usama Taha, and another center in Beirut. And we did biopsy at the GE junction, biopsies from the stomach, and biopsies from the gastrojejunostomy. And we try to correlate between the symptomatology and the biopsy findings and the endoscopic findings. This is the characteristics of the sample. Most of the patients are female. The age is 48 years. Half of the patients are symptomatic, and the other half are asymptomatic according to the SS score. When you look at the endoscopic findings, you will find that we have 26% hiatus hernia, 26% incompetent cardia, but for the mucosal abnormality, we have 20% of abnormalities, and I will talk later about these abnormalities. As for the gastric pouch, we have 16% erosive gastritis. At the anastomosis, we have 16% marginal ulcers. When you look at the biopsy findings, look, this is really was astonishing for us. We have 14% of Barrett's esophagus. But what was really astonishing to us is that half of these Barrett's were asymptomatic, and half of these Barrett's had normal endoscopic findings, which means that even if we have patients who are asymptomatic, and even if the gastroenterologist is doing an endoscopy and he finds a negative endoscopy, he should take biopsies because there may be a Barrett's behind a normal mucosa that he is seeing. And the same for the ulcers. We have 12% marginal ulcers in our series. Now, if we look at the diagnostic accuracy of endoscopy versus biopsy, you can see here. Is it working, this one? Not working. Okay. It's okay. So you can see that for normal endoscopy, we have 4 positive biopsies. So even if we have normal endoscopy, this does not mean that the patient don't have any problem. And the same for the anastomotic site, 8 normal endoscopy had a positive biopsy, which means that biopsy is mandatory regardless of the findings on endoscopy. And the same for the symptoms. Look here, we have patients with normal symptoms. They have who are asymptomatic. We have 43% negative endoscopy, and we have 17.4% positive biopsy. So again and again, negative symptoms, negative endoscopy does not mean that patient is fine. We should go for more exploration through biopsies. So to conclude, the current study will improve the understanding of post-1 anastomosis gastric bypass endoscopy and histopathological changes. Patients need to be routinely followed as per the recommendation of the ASMBS and IFSO task force to do after 3 years a yearly endoscopy. But I will add to this, regardless of symptoms, and that we should do always biopsy for the GE junction and to the gastrojejunostomy. I believe that larger samples are needed and longer follow-up will strengthen the thin evidence.
For any questions, I think we will go for the next speaker. We already.
A very quick question. Sam is a great friend of mine, so I won't be. But two things. The first one, if these data are very interesting, but are a little controversial if we take as a sample the paper written from my friends in Rome, Alfredo Genco, and published in British Journal of Surgery. They reviewed a number of one anastomosis at 5 years, and they find a rate of esophagitis, severe esophagitis or Barrett's, much lower than yours. But if I can take a message from your presentation is don't trust asymptomatic patients, don't trust negative EGDS, exactly. But in my opinion this should be translated to possibly any bariatric procedure, not only to the OAGBs. Exactly. So this is interesting, but it's not easy to convince a patient to undergo an EGDS if this is totally asymptomatic, you know what I mean, and is going good, is having good results with your procedure, regardless from the procedure you've done.
I totally agree, Mario, because if you look at the data from Roux-en-Y gastric bypass, also you will find for patients who had the scope, they have 4% Barrett's and 15% erosive gastritis, but those were biopsied because there was some findings. So if they biopsied all the patients, maybe they find the same outcome that we've got. But what is good in all of these patients, we did not convert or revert any of them. So only medical treatment works, and now we are following the patients to see later whether this Barrett's will progress to another pathology later on. Thank you.
Thank you, Doctor. The next speaker, Dr. Ali Abbas, is Senior Consultant Bariatric and Laparoscopic Surgery at Al Ain Hospital, Shams University in Egypt. He is a member of the Egyptian Society of the Bariatric Surgery, and we are excited to hear from him, Dr. Ala, why and how to revise one anastomosis gastric bypass.
Thank you for the nice introduction. First of all, I would like to thank the Saudi Society of Bariatric Metabolic Surgeons for the wonderful meeting and for the great hospitality, and I have to mention Professor Aid, Professor Sultan and Professor Osama and Professor Ahmed Al-Narzai. The whole team, they made a very big effort to reach a very nice conference and very informative. I was asked to present about why and how to revise an OAGB. I have no disclosures regarding this talk. First, we have to say why OAGB, not Roux-en-Y, as it's been in the last 1.5 days, everyone is geared towards the Roux-en-Y gastric bypass. The OAGB has all the benefits and the mechanisms of action for a bypass procedure. As a metabolic bariatric surgeon, it's proven high efficacy in producing good weight loss and metabolic remission, even in high BMI patients. It is less complicated operatively, with shorter OR time, less anastomosis, less closure, time for closure of mesenteric defects. So it's technically easier. It has much less risk of internal herniation on the long term. And one of the best and the beauties of this procedure is the easy revision, which we are going to talk about in this presentation. And the IFSO updated position states the value of the OAGB as a mainstream bariatric procedure. This is in 2021, after the literature proven research of the rather long-term outcome of studies up to 10 years from this single institute, showing it producing good results as good as Roux-en-Y or even better as regards weight loss and metabolic remission. So why should we revise? Like any other procedure, we have early complications and late complications. The early complications we are not going to talk about. It's within the first 30 days of the leakage, hemorrhage, and stomatic stricture, but nice or higher. These are higher after revisional procedures, and this is still acceptable compared to other bypass procedures. On the long term, late complications, revisions are after OAGB in the literature is in the range of 5.4%. 1.3% need reoperations in some studies and up to 2.3%. And the reasons for these revisions are either marginal ulcers, which are usually in smokers, malnutrition with BB limb longer than 150, and it can be the reason for revision in 34% of the studies, especially at the era where the BB limb used to be 2 meters and 2.5 meters for high BMI patients before the Omega study from France. And now with the shorter BMI, shorter biliary limb of 150, we have less revisions for malnutrition. GERD, including biliary reflux, up to 18% in revisional cases, and very rarely bowel obstruction. Here is the stomatic ulcers. The incidence of stomatic ulcers in the OAGB is similar to the Roux-en-Y gastric bypass, and probably they are mainly restricted to patients with smokers or using ulcerogenic medications for other reasons. The reflux in the group of OAG patients is complicated, can be acid or bile reflux, but at the end of the day, the revision for reflux will be the same. Can we show the first video, please? Oh, there is a video before this. Can we start the video? One of the options of dealing with bile reflux, if it's not associated with hiatus hernia or weakness at the gastroesophageal junction after manometric study, you can just change it into bronze anastomosis and creating a jejunal anastomosis. But the literature is divided as regards this. Some papers would say that the bronze anastomosis is successful in inducing the in curing the biliary reflux, and others would say that it still persists, and the division form of diversion of diverted one anastomosis gastric bypass as advised by Raul Ribeiro from Portugal, Lisboa, when you cut the biliary limb near to the anastomosis and re-anastomosis to the common channel about 60 to 80 centimeters distally, is more sure to cure the biliary reflux. So, are we getting anywhere in the videos?
It doesn't work.
Okay. The other reason for revision other than the reflux is the marginal ulcer. So in revisions for reflux disease and marginal ulcers, the situation is the same, and the best option is to resect the big pouch, creating a smaller pouch and creating a Roux-en-Y gastric bypass. And this clears the problem of the large pouch causing being a factor in the marginal ulcer, and at the same time also being a factor in the reflux disease. So a smaller pouch associated with hiatal repair and the Roux-en-Y reconstruction are usually very successful in curing the two reasons of revision of reflux disease and for marginal ulcer as well. In cases of malnutrition, the ones we've dealt with in the last 2 decades were before the Omega study, where the long limb of the biliary limb was 250 centimeters. Really, these were also done in low BMI patients in many cases, and the patient came in a very, very bad nutritional situation. So the idea of managing this was mainly by improving the nutrition of the patient, either by a TPN for a few weeks, or sometimes you have to put a feeding jejunostomy in the proximal part of the biliopancreatic limb and give the patient 2 or 3 months eating through this feeding jejunostomy. And when you take these patients to theater, what we used to do as a solution is to revise them to a normal anatomy by dividing the anastomosis and doing a gastrogastrostomy. And because of the original BMI of these patients was usually very, very low and not high, and we didn't elect to do another bariatric procedure at the time of the vision, especially with the patient's immune suppression from the severe malnutrition, the risk of operative complication by doing reanastomosis of the intestine to a pouch with a shorter biliopancreatic limb, or creating a sleeve at the time of revision will increase the incidence of complication in these malnourished patients. So in these situations, revising the patient to normal anatomy is the safest way, and it saves the day. And even if a small percentage of these patients down the line, few years later, became obese or suffer from obesity again, as we would expect, they can be managed again from scratch, either by medications if they are picked up early on, or other interventional procedures.
So we can skip the video. They'll continue the.
Yes, I had 3 videos, one for the conversion to the Roux en Y, one for the revision to the normal anatomy, and one for getting the diversion of the bile and leaving the pouch and anastomosis in place. So unfortunately, they are not being able to handle it. I tested them 2 days ago, and I came here first day, and it was working. But because of the sake of time, I think I finished. If you have any questions.
Thank you. Thank you. There is any question?
Dr. Haider.
Dr. Haider.
I think now we are going more and more. If you look to the trend which has been published in EFSU registry, that the when anastomosis gastric bypass number is decreasing, unfortunately. But what my comment of the reflux is not the problem of the procedure. It's the problem of the obesity, and the patient has already a incompetent cardia. So that is why he has reflux before as an acid, and now if we do mini or one anastomosis, he will have reflux of bile. So I don't think the one anastomosis will cause the reflux. The mechanism of reflux is there, but in your things, and now what we heard from Haytham, which was, I am very impressed about it also, and your presentation. What do you think about now in this retrospectively? Will you support to do it again as in a patient who has already documented gastroesophageal reflux, even grade A or grade B? Will you recommend one anastomosis gastric bypass?
I think the problem of the reflux is passed in a patient who's already suffering from reflux. I think the best way is to study these patients properly before surgery, doing 24-hour pH metry, impedance, manometry, actual good endoscopic measurement of the hiatus, and try to stratify the patients who are going to be really indicated for Roux en Y gastric bypass. And the only group which is feasible to do sleeve or one anastomotic bypass are the patients who have reasonably good pressure at the lower end of the esophagus, normal esophageal motility, mild degree of esophagitis, minimal size.
To call Mario Musilla as the full professor of surgery in Napoli University to speak regarding establishing criteria for limb length in OGB, 14 years experience.
Thank you once again to the staff of the Saudi Society for this invitation. I'm very happy to be here. Well, I'll go quickly. And in my opinion, currently, if the technique is well done, you respect basic surgical recommendation to have a long and narrow gastric pouch. Possibly reflux is a minor problem. What I believe remains an issue is the length of the BP limb or the common limb. Well, why the OHGB works and how it works, these are the questions. And it's a question we could rebate for any other bariatric procedure. This is the first report from Rutledge in 2001, starting from 1997. At the time, he recommended 2 meters BP limb. In a following series, more or less, the indication was the same about the BP limb length. And this is what Wei Jie did in 2008. He recommended 150 for starting from 35 BMI with a 10 centimeter increase in the bypass length, in the limb length, for every point of BMI increase. These are the pioneers for this technique: Rutledge, Wei Jie, Miguel Carbaco, and Jean-Marc Chevalier, very good friends of ours. And this is what Miguel recommends, or better recommended in his first series of more than 1,200 patients. And basically, at the time, he started to count the entire small bowel and dividing BP limb and common limb at the same level, more or less 350 for each part. At the midway, at the midpoint of the small bowel, this is the formula is BP limb length is 50% of total small bowel, more 50 centimeters, with a common limb that should be at least 180. This is his recommendations, pushing very much on hypoabsorption. If you see at these graphs, and this is what the consensus conference has concluded regarding the counting or not counting the entire small bowel. I believe counting the entire small bowel is sometimes useless. We'll see why. May be dangerous for the tears you can generate on the surface of the small bowel. So it's a point to, how to solve this question. We want to give malabsorption or hyperabsorption better, but we should avoid to count the entire small bowel. Very quickly, some experiences in published series. The first articles will remind us how dangerous could be going further at 150 or 200 meters. 200 centimeters, of course, in counting the BP limb. And this is a paper from Kamal, and recommending not going beyond 150. This is another paper from India, reminding us to stay around 180, not going beyond 250. And another paper from Italy, and reminding us how it's important to remain between 150, 180 BP limb. And conversely, these are other papers from Greece, this one, in which they compared different limb length, and they found no significant difference in the incidence of nutritional deficits, with a variation of the BP limb length. Another paper from Austria, more or less the conclusion is the same. They saw no differences in vitamin malabsorption by modifying the length of the BP limb. And other paper again, and concluding more or less the same in terms of malabsorption. The level of serum albumin was interesting, was good, was appreciable even when tailoring the small bowel length. And another paper in which, as you see, they found, Dr. Eskandros found no differences, even pushing very much beyond 250 with the BP limb length. And let's go to the core of the talk. I mean, this is a paper from Turkey. I love this paper. I quoted it a lot of time because it defines what I believe. It's counting in laparoscopy. The small bowel sometimes can be useless or misleading, because this is what they concluded. The same surgeons counting 2 times the small bowel found 2 different measures, and this happens if the surgeons is more tricky. The surgeons are 2 or 3, so this should be taken in account, especially when counting in laparoscopy. And this is a confirmation of what I was commenting. And this is interesting about malabsorption, and reminding us how, conversely, if the length was longer, we could face nutritional issues. But remaining to the point, I believe that we surgeons are, well, sometimes very gross. I mean, we should take in account that hypoabsorption is not only a matter of limb length. My 1 meter limb length cannot be equal like your 1 meter or is 1 meter, because we have to consider liver secretion, pancreas secretion, the immunological status of the patient, the length of the villi, the bacterial growth, the small bowel motility. Sometimes when I count the small bowel, I found it very dilated loops, and sometimes they are very thin, and this makes me count in a different way. I got not the same numbers. So possibly what I do, and what could be the solution, what I normally do when I do a standard one anastomosis gastric bypass, I start from the BMI of the patient. If the patient has obesity, I have no fear of reaching 290, 3 meters, 3 meters 10 from the trites angle. But before doing the anastomosis, I always check I have at least 3 meters below of common channel, of course. These my 3 meters put me in safe, and the patient is safe for any issue regarding malabsorption. And this is what I do with male-female patients in primary surgery. In revisional surgery, I used to count the entire malbubble, but possibly this is the solution. This is a paper from France, and now we have started a study in Italy, several centers, my centers, Dr. Raffaelli centers and other centers in Rome and Padua. We are measuring with an algorithm in the radiologists do this with while when the patients come to us, we measure it intraoperatively 2 times from the trites to the ileocecal valve. And well, we have got no results so far, but we will be happy to give you the results for this study that I believe could be the solution. Lesions you can do when you count the intestinal bowel. So in conclusion, why the OIGB works? It works probably thanks to a doubled mechanism of action. Restriction at the beginning is criterion, is very gross criterion. It cannot be considered the only criteria we should consider, but remains an acceptable criterion so far. We should consider ethnical and religious issues. There's people who are mainly vegetarians and other who are not vegetarians. It should be taken in account. The BP limb, well, this is my experience, the guide for measuring the BP limb that should be tailored, in my opinion, the entire small bowel, and taking you out for any nutritional, and your patient out for any nutritional issue. CT scan and MRI studies, surely interesting and promising. We
will move on to the next speaker, Professor Muhammad. He's a professor of surgery, Ain Shams University, MRCS, England. So, Professor, you can start, please.
Thank you, Dr. Khalid, and thank you to the Saudi Society. You know how much I love you. Please, the presentation. Muhammad Abu Zaid. Okay, so I still do lots of sleeves, but most of my revisions are one anastomosis gastric bypass. Gastric bypass is gaining popularity throughout the world. In the last 12 years, it's gaining popularity, and I'm not with that it's less now, it's more now. All over the world, it's getting more popularity. So I think I assist and operated more than 3,500 applications and literature, because there is a strong relation between the bariatric surgery and one anastomosis gastric bypass and the individuals with liver cirrhosis. So here in this publication, we can see the bariatric surgery in individuals with liver cirrhosis. The prevalence of obesity among cirrhotic individuals for transplantation are doubled since the United States, and it's more and more every year. In addition to the risk of the liver disease in patients with non-alcoholic liver disease, the existence of other comorbidities remains a big influence. And so if you have a liver cirrhosis and you are having the bariatric surgery, you will have regression of the non-alcoholic liver cirrhosis. The improvement occurs not only because of the weight loss, but also related to complex mechanisms linked to structural and biochemical changes caused by the surgery, such as it's proved to have regression of the non-alcoholic liver cirrhosis. In relation to the severe liver cirrhosis and for candidates for transplants, the choice of most appropriate surgical technique and the time of completion of the surgery are relevant aspects. The conclusion in this first part of the presentation is that if you are having a patient with liver cirrhosis, sleeve gastrectomy will give you a chance for good anatomical position and also the less. There are no studies that examine the pharmacokinetics of the immunosuppressants of liver transplant patients undergoing bariatric surgery. However, reports say that we need larger dose of immunosuppressants. So if you are having a patient who is going to have a transplant or after. What about hepatic complications of bariatric surgery? So we have a patient who is coming without any previous history of liver transplant or liver cirrhosis, and then we have a bariatric surgery. The reverse side of the coin. Liver injury cannot be considered hepatic decompensation in Roux-en-Y gastric bypass with extended Roux limb. Similar consideration can be done about the DS variant, and also we have 470 cases and reported, and there was rising ALT and AST. Here you can see the normal liver, and you can see overgrowth, chronic malnutrition, even persistent non-alcoholic steatohepatosis due to reduced success of bariatrics can favor the onset of cases with progressive liver damage. So we have portal endotoxemia, we have all of these factors are counting on the liver affection after the one anastomosis gastric bypass and the long limb, BP limb in the Roux-en-Y gastric bypass. Severe fetal protein malnutrition was documented in Iran, and in this case, the case died after the one anastomosis gastric bypass. But as you can see here, the authors believe that the timing of action as well as the treatment plan is particularly great significance. Most of the one anastomosis gastric bypass surgeons started with very long. We started to hear about the cases of fatal malnutrition and the fatal cirrhosis, and the patient was presenting late. Right now, most of the surgeons all over the world are doing less aggressive procedures, more long pouches, and they are following the patients more. The real challenge remains the optimum timing for corrective intervention. Too early correction. Which one is better for, this is another publication, which one is better for non-alcoholic fatty liver disease, the Roux-en-Y gastric bypass or one anastomosis gastric bypass? And as you can see here, there is no significant difference between the two procedures. Both have predictable beneficial effect on the weight loss. However, one anastomosis can improve non-alcoholic liver better on the short-term follow-up. This is another paper with another different opinion, and they said that compared to Roux-en-Y gastric bypass, one anastomosis gastric bypass had greater weight loss, but there is increase in the one anastomosis gastric bypass is very good and very effective. We did a survey in the MENA region in 2019, and most of the surgeons, as Mario said and Haitham said, didn't count the whole bowel length. They only said that they won't cross the 180 centimeters BP limb. At that time, we found out that we have 3 patients with excess weight loss, so we started to have less BP limb after 2016. And right now, I don't exceed 180 in the primary cases, and I don't exceed 1 centimeters. The most important thing about the whole one anastomosis gastric bypass is the long pouch. Long pouch, exactly like sleeve pouch, starting at the antral level with anastomosis 3 centimeters and 180 BP limb. This is the good thing we can do for patients. The 18 patient who presented with insufficient weight loss after one anastomosis gastric bypass, and they were seeking more weight loss and seeking more malabsorption. We found out that 15 of them had already malabsorption. They already had hypoprint of patients, because in these patients we found out that the the pouch was short, and the patient had bile in his esophagus, and he was of the short pouch, one gastric bypass. Bile in the esophagus is the main concern for malnutrition and liver cirrhosis, because the patient is not able to eat good amount of protein per day, and he's taking lots of sugar. And this is the main concern for us. After the one gastric bypass, the patient has bile in his esophagus. So please, if you are having a weight regain patients, we are doing everything about the operation. He has less weight loss, then he can have another. The upper GI is very important to assess these kind of patients. So in conclusion, mild liver cirrhosis can have one gastric bypass as long as you know the principles and you don't transplantation in the future. Exceeding 180 in primary cases carries more nutritional deficiency with significant affection or short pouch. Patient safety is our ultimate goal. Thank you very much.
Thank you, Dr. Muhammad. We conclude this session, and we come back again 2:30. We enjoy the lunch. Maybe some
2:30. The lunch for the faculties will be beside the swimming pool, the same area yesterday, and also on the Indian. You see, we give you more than the.
Okay, we have a match. There are 3 surgeons who are challenging themselves. One will be on Da Vinci, one will be Hugo, and one will be on laparoscopy. So the idea is who will do the fastest suturing, running 5 runs, doing 5 runs, and making knots and then cutting. So whoever wants to see how things will work with robots compared to the laparoscopy, they can join us.
With the lunch, you can go to the exhibition and you can compete with the laparoscopy, Da Vinci, Hugo. for GERD patient. أبو فرح تفضل على ها خليه do your presentation. Can we have the presentation on, please?
Bismillah ar-Rahman ar-Rahim. Good afternoon, Mr. Chairman, Co-Chairman, dear colleagues. I'd like to thank you all for attending, and I'd like to thank the organizing committee for giving me the honor to be with you. Today I'm going to present a patient, and the reason I'm presenting him, I thought we shall discuss together the hiatal hernia. How can we dissect it, and how can we prevent it in a gastric bypass patients? The other thing is the technical steps in gastric bypass. How can we make it simple, reduce the incidence of stomal hernia, stomal ulcers, and further complication in the anastomosis. Can I start, please? So this is a 41-year-old female patient who was referred from family physician with a GERD symptom and a CT finding of a large type 3 hiatal hernia. On assessment, patient was found obese with a BMI of 35, diabetic, hypertensive, typical GERD symptoms, mobile, exercise tolerant, and compressible abdomen. Upper GI endoscopy showed class C esophagitis, nodular gastritis, Helicobacter pylori positive, and was treated. The CT, as you could see here, see how big was the hiatal hernia. So a decision was made to go for hiatal hernia dissection and bypass. I'm sorry here, I missed the dissection of or reduction of the hiatal hernia, but this is the dissection of the hiatus and elongating the intra-abdominal esophagus. After that, I always do darning of the hiatus rather than multiple interrupted suture, two-layer technique, in order to ensure a tension-free or near tension-free repair with enough network of sutures that can induce fibrosis around the hiatus. And at the end, you are going to see, in addition to this, we try to ensure there is enough intra-abdominal esophagus, so we'll do an esophagopexy at the end of the procedure. I always take number 1 silk suture, 30 centimeter long, and I take it 2 layers, and that's it. The first layer is simple continuous, and the second layer is interlocking in order to ensure fair and balanced tension on all bites. When we do the gastric bypass, I do the anastomosis transverse. I don't do it vertical anymore. And I see the advantage of this. It makes it easier, less tension on the anastomosis. In case you need to revise the anastomosis, you would cut it and still have the pouch. So, as you could see, the first stapler is inclined cephalid, sloping cephalid, in order to allow the anastomosis to align well with the pouch. So once we open it here, we'll make the anastomosis, and when you do the anastomosis, you keep the 2 stapler line of the pouch and the stapler line of the gastrojejunostomy in front, and I offer sew them together in order to avoid in case of risk of ischemia between the 2 endostapler applications. All the surgery is done supracolic. So we bring the alimentary we bring the bowel supracolic, and we do both anastomosis supracolic. These sutures will go closing the gastroenterotomy, and then we will run it over the anterior wall where the two suture line or two staple line are running parallel to each other to reduce the chance of ischemia and leak in that area, and that's it. And I think this carries the least risk of ischemia, because if you go through the pouch, lateral part of the pouch theoretically goes ischemic. I know that there are multiple factors to contribute to this, but I think creating transverse anastomosis would probably eliminate this risk. And if you make it sloped superiorly, that will make the alignment with the alimentary limb well aligns. Now we test it with passing the orogastric tube. Now this is the island between the stomach and the biliopancreatic limb. I always create a biliopancreatic limb of 150, alimentary limb of 100 centimeters. So the anastomosis is made, and the island between the two anastomosis, gastrojejunostomy and jejunostomy, is not divided. I divide it after methylene blue test, where I could test the two anastomosis together. This is closure of the mesenteric defect, which I'm sure, I think we are doing it more or less the same. We are using silk suture and putting it together. We lift it up until it becomes a V-shaped, and then we start from the base. Closure of the Peterson space is the same. We close it from the base up to the transverse colon. You could see here, now we did the methylene blue test, and we tested both anastomosis. Then this island of jejunum in between will be divided. That's the Peterson space is closed. Now, this is the esophageopexy we are going to do at 3 o'clock, at 9 o'clock, using number 1 silk suture in order to ensure, less hiatal migration, and we ensure the intra-abdominal esophagus will be in place. And these are the anti-kink sutures at the gastrojejunostomy, which we sometimes do. I did it for demonstration, but the alignment is okay, and I don't expect it to twist, because we made slope in the anastomosis to avoid gastrojejunostomy twist. A drain is introduced, and the 12 millimeter port is closed using an endo close technique. Thank you very much.
Is there any questions for Dr. Abdullah? طيب. Thank you so much, Dr. Abdullah. تفضل دكتور أحمد. طيب. We'll keep it until the end. طيب.
باقي لك محاضرة يا عبد الله.
So may I present our next speaker will be Dr. Ali Al Yahya. No questions. طيب. Is a دكتور حيدر. دكتور حيدر. Our senior consultant, Dr. Haidar Al-Shurafa, he will talk about Roux-en-Y gastric bypass post-sleep, the important surgical decision to make.
السلام عليكم مرة ثانية. ومساء الخير. ميكروفون عافية صوتك
والله يعني الواحد so happy to have these people with us. So I'm over these 2 nights we learn a lot. We start, huh? بدأ ولا ما بدأ؟ يلا, we can start. So nothing to disclose. This is my mixture, case mix. Majority still is sleeve, but the most common is the raw and why gastric bypass. And in the actual life, the most common procedure is the sleeve. So the most common procedure to be revised is the sleeve. صح? That is, we all agree. And the most common revision for sleeve is the raw and why bypass. Now, the indication, of course, weight regain or GERD. This is my revisional raw and why gastric bypass. It's form almost 34% of the raw and why revisions. The key decisions are in between these 4, which is pre-operative considerations and surgical technique, post-operative care, and special consideration. The pre-operative including all, history, investigations, and all and all. Now, in the surgical technique, we will go over these. Usually supine, surgeon to the right, all, even the revisions for whatever. But that will give you the chance to move from side to side. Now, the adhesion, we don't do adhesolysis as a whole, only targeted adhesolysis and in the upper part of the sleeve, and we release the bands if there is anterior abdominal wall band with careful hemostasis to avoid bleeding. You know that these adhesions are hypervascular, so that more adhesolysis, more risk of bleeding and injury to the other organs. Of course, if you have a twisting in the distal stomach, the decision to remove it is up to the surgeon during the operation. But look, this is what have already by Dr. Abdullah, what he said. We should, in all patients, post-sleep, check the hiatus, regardless what is the endoscopy. Because it has been clear there are cases where they have reflux and they don't have hiatus hernia, and the opposite is also true. They have hiatus hernia, but they don't have symptomatic reflux. So we do need to repair the hiatus hernia. That is very important, and this is true. It has been reported before where the risk of GERD even after raw NY is still there up to 31% in the literature. Just imagine one guy who do for him raw NY and still you need to do for him a revision because of reflux. So of course you diagnose, you reduce, you repair and reconstruct of oesophageopharyngeal ligament. And that is what usually we do, is doing these things. Now, the next important decision is regarding the pouch size. The pouch size is very important, and there is a very good study and meta-analysis systemic review from the Swedish series where the pouch have a crucial part, and there is very clear now, we know that bypass is a restrictive, majority of the procedure is restrictive procedure. So the smaller the pouch, the better the outcome, and the between hand sewing and the saline is very important, and usually should be not more than 2.5, and that is our practice. In the gastric pouch size, the larger the size is, the more the risk of marginal ulcer, GERD, and retrosternal pain. And standardizing the technique to measure the pouch size is very important despite the variability in the actual. It is truly, we don't measure an actual size, but at least we do have fixed way of measurement technique. Of course, the smaller the gastrointestinal anastomosis, the more the risk of stricture. Now, just to show you, this is the pouch, and what is the benefit of having a good length of esophagus intra-abdominally, apart from anti-reflux system, it is also give you the small pouch of the stomach more nearer to the anastomosis and less tension on the anastomosis. And as you see here, that the pouch is, despite it is small, but it is higher, lower in the part of the abdomen where you can bring the small bowel easier in the super obese patient. Of course, we used to do 2.5 or 20 millimeter anastomosis. And this is the most important part of any revisional bypass. All the revisional bypass should have a full measurement of the bowel, full length of the bowel, each limb measurement, and actually the direction of the bowel measurement is also important. That is very important if you are doing revisional bypass. And as you see, this is the good review by Dr. Nemeri, where he mentioned that even prolongation of raw limb will not add to the weight reduction, but the shorter the raw limb may lead to lose less weight. هاي شوية فلسفة يعني philosophic terminology. So the shorter the raw limbs does not help you in weight loss. That is very important. We usually brief before we do 150 raw limb. And then came the idea of that, the micronutrient deficiency. But later on, we know you make it shorter, you lead to less weight loss. And that is what is the other study has been proven. And of course, the technique of doing the raw NY bypass is very important. We use the loop technique where we do DJA the first, and that will help you a lot in avoiding raw NO. You have a lot to, no need to do a lot of measurement and go right, go left several times. You do it in one way all the time. That make it very easy. Of course, the other limbs also has to be measured, including the common channel, which should not be less than 300, but still there is a lot of discussion of being 300 or not 300, but the most important is to measure the whole limb in order to decide how much you will make the limbs. The conclusion, ترى أنا وصلت. أنتوا you predict إني ما مسوي زين. لا, predict good things. So the conclusion, a closure of both defects must be methylene blue, and that's all. Now this is the video. Looks like it is شغلين يا لا ما تشغل. طيب أعتقد يعني هو سريع كذا بس I think adhesive lysis, it is the same what I have said. خلاص, conclusion. Yeah, take home message. All step of revisional after a sleeve known but need to be standardized and reproducible and accurate. And we know this standardization is not easy, but at least in our practice, I mean in personal practice, fix the way. Don't do every time different way. So that if there is bias, the bias will be fixed. The second, all hiatal hernia has to be repaired, whether revisional or primary. A lot of RCTs are needed in each step of this procedure, and the detailed revision of each LSG to raw and Y gastric bypass according to the indication. Of course, optimizing the steps to maximize the result. شكرا جزيلا.
Thank you, Dr. Haider. I would like to welcome our next speaker, Dr. Ali Ali Yahya. He is a distinguished pediatric surgeon with expertise in bariatric and robotic surgery. We will be talking about one anastomosis gastric bypass in patients with melanocortin 4 receptor mutation.
Assalamu alaikum. I want to thank the organizing committee to allow me to present in this nice conference. Today I will talk about the benefit of one anastomosis gastric bypass in special criteria of patients who has the MC4 receptor deficiency and who failed the primary bariatric procedures. And here it's very important to identify the genes for patients, especially when you have a very young or familial obesity, because this is very crucial in the management of such patient. There are a lot of genes involved, but the most important one, it is the MC4. And it is part of the G protein coupled receptors. It regulates intake and energy spent and then lead to hemostasis of body weight. It's very important. If you can see here the leptin up on the left side of the screen and also the MC4 down on the left side of the screen. It is the one which has regulated the feeling of satiety and the hunger. And if you have any deficiency in one of these two, this will lead to excessive eating, and regardless of how full you are doing or how full is the stomach, still they think they need more food. And this is very important even in the decision of what kind of bariatric surgery you are going to offer to these patients. It is not new. It is started before 2007, but in 2007 they start to correlate between the obesity and these genes. And the second gene was discovered, the MC4 receptor deficiency, and it was in 2008. And since that time, there is an evidence of a correlation between the severe early obesity and these genes. There is meta-analysis for more than around 81,000 cases from 220 studies, and they found that there is a very correlation between the presence of MC4 receptor deficiency and severe obesities. Another one study also showed the same deficiency, and the children, they are going not to benefit from the lifestyle. They need more than lifestyle. Medical treatment is encouraging, especially GLP-1 3 milligram, and lead to maintain at least the weight, decrease it a little bit, but it is not sustainable. Setmelanotide is the treatment for monogenic obesity, but it is very expensive and it only reduces 10% of the excess of the weight. There is a lot of research about the malabsorptive procedure, RO&Y, and it showed that there is its benefit in these patients, in adult patients, and show there is the excess weight loss for them is similar to controlled people, regardless of their mutation. And another study came later on, showed that the safety and efficacy of one anastomosis gastric bypass in pediatric population. So combining these studies, we came with this question: is one anastomotic gastric bypass is safe and effective for MC4 homozygous patients? And we have 4 patients, and those patients, they are not the only patient of MC4 patients, but from this diagram, you can see that the MC4, they are regaining weight at the end. After 2 years, they start to regain weight after sleeve gastrectomy. And we faced 4 of our patients who had sleeve gastrectomy. they success to reduce the weight around 18 to 24 months, but then they regain the weight after that. 3 of them, they were off, the 4 patients, they were off the CPAP. 3, they returned to the CPAP after. 1 did not improve in diabetes. So all these patients, after this extensive discussion with my colleague to see what is the best management for them, either to leave them or to do something else for them. So this is the patient's pattern over the 3 years after the sleeve gastrectomy, and you can see they start to come back to their original weight after sleeve gastrectomy. So we offer the one anastomotic gastric bypass, extensive workup for them, endoscopy, ultrasound of the abdomen, contrast study, and also the psychiatry and nutritional consultation was done. And we start to think about doing the biliopancreatic limb between 150 to 200, and based on their severe obesity, 200 was, or 175 was the ideal, but none of the patients went for 200. They were all around 150 centimeters. Resizing the stomach if it is huge, and then GJ anastomosis with around 3.5, closing the Peterson space. If you can see here, all the patients, they are between 13 to 15 years, and the BMI and the weight is really very high for this age, and you cannot claim this is related to the obesity is related to modern life or less activity as increased intake, because if you have one who's around 14 years and his weight is 205, there is something different for this patient. It's not only lifestyle. Is there something in his metabolism make him to reach that weight? So we compare, we came after we did the one anastomotic gastric bypass, we compare the 3 months, 6 months, 9 months, and 12 months results. When the same patient subset for the sleeve gastrectomy and the one anastomotic gastric bypass. And if you can see initially, the total weight loss was not significant different until they start to 9 months and after. So the first 6 months, I think the total weight loss was similar, and I contribute this to the start weight. I think they have more start weight when they underwent the sleeve gastrectomy. You can see here the same patient in the 3 months and 6 months. You can predict that with time they are losing more total weight with one anastomotic gastric bypass. Start sleeve is good because the start weight for them, but then the one anastomotic gastric bypass just take the lead, and it's better for decreasing the weight. Same for here you can see the variation. It is constant with one anastomotic gastric bypass, while it's variant between patients in the sleeve gastrectomy. Same for excess of weight loss. One anastomotic gastric bypass was better, and if you can see, it's very significant after the 6 months of surgery. Same thing, you can see there is a variation in sleeve gastrectomy in the weight between patients, while it is very constant and the standard deviation is very narrow in one anastomotic gastric bypass. PMI is the same. PMI is the same. There is more decrease in one anastomotic gastric bypass. And the thing that we face is the nutritional status post one anastomotic gastric bypass. They have more vitamin B12 deficiency in the 9 months. Hemoglobin is low, and ferritin and iron is more low. Compliance with injections and tablets is not good for these patients. And there is a lot of things that came in market may help, but the most important thing is the start of the home care program in our center, so they can go and they give the multivitamin. Also, what I heard lately, that there is another company that coming from the MOH, it's called SAR. They are taking the blood results and building the multivitamin and send it for the patients. So in conclusion, sleeve gastrectomy, it is very strong, but it's short to mid-term results. It's very effective to take the weight to acceptable weight for, and take the patient off his metabolic problems. But this will not stay for a long time, and we should think about another procedure for these patients. One anastomotic gastric bypass, it carries a risk of nutritional deficiency. They need more regular follow-up, and they need to implement a very structured program special for them. It's very nice if you have home care program, they go and give the multivitamins for them at home. Inshallah, in future will be better for these patients. We understand that our patient is very short follow-up. We don't know what will happen after 2 or 3 years. Maybe they will have the same pattern of sleeve gastrectomy, but our understanding from the initial result, these patients, they need malabsorptive procedure more than restrictive procedure alone. Thank you very much.
Thank you very much. I think we'll leave the questions together later on if we have time. Now I'll call upon Dr. Fawaz Al-Rashid to give us a talk about internal hernia, post-Roux-en-Y bypass with its diagnosis, complication and management. And Dr. Fawaz Al-Rashid is an associate professor, scientific positions in the university.
Do this presentation and wonderful gathering really. My bariatric surgery and Roux-en-Y bypass although laparoscopic sleeve gastrectomy is currently the most common performed weight loss procedure, Roux-en-Y gastric bypass is the golden procedure. One of the complications related to Roux-en-Y 1%, other including adhesions and interceptions and all other also intraluminal clots. Multiple techniques through jejunostomy and jejunojejunostomy, retrocolic, retrogastric or retrocolic antigastric or anticolic antigastric is also prevention or occurrence of the internal hernia after Roux-en-Y gastric bypass. Another important factor for developing internal hernia is rapid care about it is the intro, also the transverse mesocolon defect. There was no clear mechanism. Loss may not allow adequate time for potential hernia space to completely close. Potential site also of internal hernia between the two jejunal lobes, barrows, and on the other hand, interception also, which may define telescoping of proximal bowel segment of gastrointestinal tract within the lumen of an adjacent segment, is far less common than internal hernia and Roux-en-Y. But gastric bypass, the internal hernia can be potentially life-threatening if misdiagnosis, if not diagnosed early, and it is one of the most challenging clinical scenario in terms of diagnosis. Internal hernia can occur in any time from 1 year to 3 years, and patient with rapid excess weight loss, while stenosis and adhesions will be presented earlier. A retrospective review of 914 Roux-en-Y gastric bypass patient done by OBEID, 5% of patients develop internal hernia. Presentation with vago-abdominal pain is 60%, while 8.8% of patients presented with acute abdomen, with vomiting, nausea and vomiting, and one case 2.2% presented with acute abdomen and peritonitis. In retrospective chart review done by Spector, the finding of 4,000 Roux-en-Y gastric bypass patients, among which 99 small bowel obstruction, most of these patients had internal hernia, and imaging study are important for diagnosis of internal hernia, even more to keep in mind that 20% of cases imaging study are negative. Upper GI series and CT scan frequently diagnosing the internal hernia after Roux-en-Y gastric bypass, which one of them is superior to the other is a matter of controversy. Nowadays, CT scan is imaging as the preferred imaging tool in diagnosing internal hernia after Roux-en-Y gastric bypass, with multiple reasons. It is technically difficult than upper GI series, especially in positioning patient, and also CT scan has a better quality of imaging. They have patient with post-Roux-en-Y gastric bypass and the swirly appearance of fat with surrounding power. Dysentery in the PIST is the PIST single predictive sign with the sensitivity of 61 and specificity to 67 to 94. Even the further look, noting that the degree of swirly was important. For example, who had swirly less than 90 had negative finding of internal hernia exploration, and who have more than 270 degree were all positive in exploration. Arose pointing to the mushroom sign, a typical appearance of the internal hernia and CT scan due to crowding or stretching of the vessel of the mesentery route as they travel through the hernia. And clustering of the lobes, small bowel marked with arrow in the CT scan. This internal hernia was confined at the time of operative exploration. And CT scan demonstrating here a small bowel behind the superior mesenteric artery. The arrow pointed to the segment of the bowel which is thin and stretched behind the superior mesenteric artery. Mushroom and hurricane sign had low sensitivity but higher specificity, while the swollen mesentery lymph nodes had moderate sensitivity 44 to 89% and high specificity 9 to 100%. Another study conducted by Marcin, the most consistent CT scan finding was a clustering of a small bowel 79%, followed by the small bowel obstruction 73 and swirly mesentery. Algorithm for treatment of patient with presenting with abdominal pain following the Roux-en-Y gastric bypass, that if patient hemodynamically stable and patient positive CT scan, you need to take the patient to OR. If the CT scan is negative and there is neutrophilia, you need to take the patient to OR. If the patient hemodynamically not stable, you need to take the patient directly to OR. It's important to stress again that undiagnosed internal hernia can lead to devastating results. Hence, we should have high indexes of suspicion even in absence of diagnostic evidence, and patient should get an early intervention for diagnostic treatment of the one who is having this experience, or refer patient to other center who have the bariatric surgery service. Management of internal hernia remaining surgical. The emergency of surgical intervention relies on the clinical condition of the patient. For example, a patient with toxic signs and full-blown fracture obstruction should be taken immediately to surgery. You need to have a high index of suspicion, and it's important to stabilize the patient generally, and general condition of patient, you need to stabilize it and proper intravenous fluid, and you need to correct the electrolyte of the patient and acid-base balance for the patient. And the placement of the NGTube, you need to take care that NGTube will be difficult, then placement of percutaneous decompression, or even we can do it surgically. My take-home message that if you don't have, if you suspect of patient with post-Roux-en-Y gastric bypass, you need to consult urgently expert person, or to refer the patient to a higher center who they can deal with the case. Thank you very much.
Our next speaker, without any further recognition, our founder and one of the tests in 20 years.
This is my disclosure. The gastric bypass started, as you all know, with one anastomosis gastric bypass in 1967. It was a horizontal pouch with one anastomosis in loop configurations, biliary reflux esophagitis patients. So open surgery, so the size and measurement is different from what we have today. We invited the loop technique of gastric bypass. It's almost 24 years ago. I'm still doing the same technique. So when we came back in 2004, me and Osama, and the moment we started to do lots of gastric bypass, we considered the procedure that time to be the gold standard procedure, 50 or 60 years, and been studied most So you can see lots of, when you review the literature that time during the open era, yes, the pouch was big in size and the limb measurement were different, and yet you are getting almost similar result. So we were very comfortable to do the bypass that time. We know that this procedure has a metabolic effect, but there was no explanation that time why those patients, they have improvement and in their surgery until his passage of the nutrients. So they removed the fasting glycine because they put the animals, they did the procedure. So when again the diabetes. So in four factors in the duodenum, when we exclude, this is again, it's the distal passage of the anatomy. We have three components. We have the pouch, we have the anastomosis, and we have lesser the pouch is, the smaller the pouch is, the lesser acid production and lesser incidence of ulcer, but not necessarily to have better weight loss. So the pouch, we have here the pouch size and orientation. In many occasions in EFSO, I remember, they gathered a group of experts. There was no expert opinion. I mean, in expert opinion, there was no consensus about the size. And the common sense, it's okay, let's make it at least, we should have a small pouch, not to have problems, but not necessarily to have better outcome in terms of. And the observation, there is no correlation between the stoma size and the weight loss or the maintenance of the weight loss. But the common sense here, you should do it right. No stenosis and no tension. When you go to the limb measurement, I remember when we started the bypass, we were classifying the patients that time, 20 years ago, to BMI less than 50, and the biliopancreatic limb that time it was fixed to 50. If it is more than 50, the BMI we give 100. It's not necessary to have a better weight loss if you elongate the raw limb. And instead, you might have nutritional consequences to elongation of the raw limb. So the common sense now, we learn again that we should do it just to avoid reflux. So 75 to 100 centimeter is enough for the raw limb. For the limb length, again, no consensus. All these meetings, no, there was no agreement on that. And the observation that most of people, they observe that the more you bypass, the more you will have result. But in fact, I mean, the more you will have weight loss, extra weight loss. But what we have learned from our own experience, there is no difference. Maybe in the beginning there will be acceleration of the weight loss, but after 1 year they will be the same at the price of nutritional consequences. So the common sense here again, as we said, that the measurement should be 75 to 100 for raw limb, and for biliopancreatic now we increase it to 100 because we have rising evidence of improvement anti-metabolic effect of the biliopancreatic limb. So in conclusion, and I think this is very important, we have limitation to what we do in bariatric surgery. We have to be safe. There are so many things that we don't understand, especially in the gastric bypass surgery. There are our job, we should do a perfect procedure, safe procedure, optimize the technique itself, and we try to minimize the side effects and the complication of the procedure, depend much on lifestyle modification, exercise, high quality diet with permanent change in nutritional diet. So you can, this is my experience for the past 20 years, and you can see the RYGB at one stage, there was a rising of the procedure and then descent. And this is not because I don't like the procedure, but because there are other procedures. There was sleeve gastrectomy coming in the way, and also one anastomosis gastric bypass that has taken, let's say, 20 to 30% of our volume. Thank you very much.
Thank you, Dr. Sultan. I would like to, thank you. Okay. No questions, Dr. Alta. Okay. I would like to call our next speaker, Dr. Ali Aminian. He's a director of Bariatric and Metabolic Institute at Cleveland Clinic, Ohio. He has more than 250 publications in high-impact journals. We will be talking about when and in whom to choose Roux-en-Y gastric bypass over sleeve in 2025. So please, Dr. Ali.
Very good. Thank you. Good afternoon, everybody. Can I have my slides, please? Okay, so in the next 10 minutes, hopefully I can try to show you that there is no perfect procedures. All procedures have their shortcomings. So there are good things and bad things with every single procedure. But my talk is specifically on when and in whom to choose bypass over a sleeve in 2025. Here is disclosure. So this slide, you see the efficacy and risk gradient of all standard procedures, if you call it standard. On the left of the screen, we have DS and SASMBS. Those are the most effective procedures that we have with greatest risk of nutritional problems. On the right side of the screen, we have gastric banding and a sleeve, less risky and less effective. So overall, as I try to show, there is no perfect procedure. All procedures have their own risk and complications. So we need to choose which procedure would be the better choice among the procedures that we have when we see a patient in the clinic. So in the middle of this gradient, we have gastric bypass and sleeve gastrectomy, which have reasonable risk and efficacy profile for most of our patients. So here is, I show you this yesterday. So here's data, Cleveland Clinic, the past few years, 8,000 patients who had the sleeve or bypass. So patients with gastric bypass lose more weight compared with the sleeve, and about 30% versus 25%. I mean, after all procedures, patient gains some weight back. But again, this is for the whole cohort. So when we plot data of every single patient, you see that the dots are all over the place. So we have done gastric bypass for our patients, and they haven't lost any weight. And in the bottom, you see that we have done gastric bypass for patients, they lost 50% of their weight. The same thing with the sleeve. But overall, it seems like bypass overall when you compare the density of the dots where they're located. So again, this is the other cohort. These people had diabetes. Again, bypass versus a sleeve, people lost more weight with the bypass. It seems like more durable than the sleeve. And usually, bypass is better for diabetes control than the sleeve. So for diabetes, the thing that matters the most is the severity of diabetes at the baseline. If we intervene early in the course of diabetes, then we can get excellent results. But if we intervene late, then when all or almost all beta cells in pancreas have already been burned out, then we're not going to get that great result. So the long-term response depends on severity of diabetes at the baseline. And based on that, we developed this IMS score that can help in procedure selection. So basically, in the IMS score, we put the predictors of diabetes remission in the calculator, including number of diabetes medication, if the patient is on insulin or not, duration of diabetes, and the A1C level. If the patient fall in the middle, which is in the moderate group, with the IMS score between 25 to 95, in that group, gastric bypass outperforms the sleeve gastrectomy. If the patient falls in the mild group with the IMS score of less than 25, then both procedures do relatively the same. So those patients have mild diabetes. A simple push from each of them can help patients to have good diabetes control. In the severe form, again, bypass is slightly better than the sleeve, but not that much. So, so keep that in mind. And here's the calculator. You can download it from the App Store or go through that website. So that's the efficacy. But if you look at the safety, so obviously sleeve gastrectomy is safer, both in early post-op and the late post-op. So in early post-op, all complications are less commonly seen after a sleeve compared to a gastric bypass. The only complication that is more commonly seen is portal mesenteric vein thrombosis, which is more commonly seen after a sleeve than the gastric bypass. But every other complications are more common after bypass. In late post-op follow-up, bypass again had more complication, the ulceration, reactive hypoglycemia, internal herniation, you just hear about it, malnutrition, all are more commonly seen after gastric bypass. Acid reflux and esophagitis are more commonly seen after the sleeve. So it's not just about efficacy, about the complication too. So when we put everything together, so these are the factors that I consider when I see a patient next week in my clinic. So there is no factor that make a decision or help me to make a decision. I shoot every single of those, and then I have a conversation with the patient to identify or determine the procedure that would be the best for that patient. For the average risk patient, this is going to be about 75%, 80% of patients that I see. Both procedures are really good. I tend to do more gastric bypasses because it's more durable. Patient lose more weight with that. But both are good for average risk patients. So if the patient is extremely high risk, obviously a sleeve would be a better choice. If the patient is high BMI of 50, 55, 60, again, I want to help them lose more weight, then the gastric bypass is my preferred choice. But if extremely high BMI, if there is no working space, if I don't have any choice, then the sleeve. I talk to the patient, I tell them both gonna be good options, we go to the OR, then I get the consent for both, and then if there is a working space, I do anastomotic procedures. If there is no space, then I do the sleeve. But I obtain the consent ahead of time. I tell the patient that you are like my brother, you are like my sister, I do the safest and the best operation for you, so I don't do anything risky. So for those rare situations, a sleeve would be a better choice. If there is a complex large abdominal wall hernia, if the patient had multiple small bowel resection, Crohn's disease, patient with transplant recipient or candidate, if the transplant candidate, if patient had complex psych history requiring multiple psych medication for their mental health, active smoker, chronic NSAID users, that they are at risk to have marginal ulceration, then a sleeve would be a better choice. If the patient is a patient that in future they need to have access to duodenum and biliary tree for the stenting and the ERCP, then the sleeve would be a better choice. If some patients had hereditary increased risk of gastric cancer, so on those, again, the sleeve would be a better choice, or we can do the resectional gastric bypass and resect the excluded stomach. Again, if the patient has a history of kidney stone, we know that the gastric bypass risk of kidney stone development is greater than the sleeve, then the sleeve would be a better choice. Again, these are the factors that I consider, but I don't make a decision based on just each of them. So I look at the totality of the information that I get, and then based on that, I make a decision. So osteoporosis, if the patient already has very bad bone health and with severe osteoporosis, especially post-menopausal women, 70, 75-year-old, Then if we do the DEXA scan, it shows that the patient already has bad bones, then the sleeve is going to be a better choice. Type 1 diabetes, always a sleeve, less bypasses, because the management of glycemia, diabetes is going to be very difficult on those patients. If the patient has a GERD before surgery or Barrett esophagus, I tend to do more gastric bypasses. If the patient has hypercoagulable state, we do more gastric bypasses because, again, we talked about it, that portosplenic vein thrombosis is more commonly seen after sleeve gastrectomy. So we tend to do more gastric bypass because we know that if they have hypercoagulable state, if we do the sleeve, that may increase the risk of portal vein thrombosis. And we talked about diabetes. So if the patient has mild diabetes, both procedures are good. A sleeve would be bypass to make a decision. In patients with moderate diabetes, which is majority of patients with diabetes going to fall in that category based on the IMS score, we do the bypass because bypass has more profound metabolic effect. Thank you.
Dr. Ali, to keep with the time, we will continue the next session. And we would like to call for Dr. Kawthar Al-Haddad. She will give the first talk about cardiometabolic effect of trizepatide, insight from the SURMOUNT 1 and 2, and the change in the cardiometabolic parameters upon the SURMOUNT 4.
Assalamu alaikum everyone, this is Kawthar Al-Haddad from Lily. It's a pleasure to be here surrounded by this number of experts, so no pressure at all. And I'm pleased to present a post-hoc analysis from the SURMOUNT 1 and 2 regarding the early weight loss and cardiometabolic parameters. So these are my disclosure. I'm an employee at Eli Lilly, of course, and this material is only for educational purpose and it's not promotional slides. So we all know about tirzepatide that it's a GIP GLP-1 receptor approved for both obesity and type 2 diabetes. And tirzepatide led to significant weight reduction and improvement in the cardiometabolic parameters in participants with type 2 diabetes in the SURMOUNT 2 and participants with obesity without type 2 diabetes in SURMOUNT 1. And early response to weight loss intervention had led to assess if early weight reduction, which was defined as losing 5% of the body weight or more at week 8, will have a greater improvement in weight. And so let's go overview really quickly about the study design in SURMOUNT 1 and 2. SURMOUNT 1 was for the patient with obesity or overweight but without type 1 or 2 diabetes, and the SURMOUNT 2 was included all the patients who have obesity plus type 2 diabetes. Another difference between them that in SURMOUNT 1 they included the 5 mg as well as an arm, but the SURMOUNT 2 they only compare the 10-15 to the placebo. And let's skip this and I will go directly for the analysis. So during the analysis, they group the patient based on how fast they lose their weight. So patients who lose 5% or more at week 8 will call them as early responder. And patient who didn't lose the 5% or more at week 8, this is an early responder. And then the endpoint is to assess the percentage change in the weight, the lipid profile, the hypertension, and proportion of participants who lost weight of 5%, 10%, 15, 20, and 25 and 30%. And they looked specifically in the SURMOUNT 2 and the target of the A1C as well. These are the baseline clinical characteristics. I will skip it and go for the results. So this is the graph. It's super clear and shows us for the non-early responder how much they lose weight. Early beginning, and we can notice the divide. Is he not getting the regardless of how early they lost 5%. However, we will see the difference when we look at a grade. 4% of them lost 30%. But when we look to non-early responder, only 4.5 who reached the 30 reduction. Okay, what about the dosage? When we compare it for early responder, we can see the difference. Look at the light blue line showing us the 5 mg of early responder comparing to patients who non-early responded and better comparing with the patients who didn't respond early. And for the SURMOUNT-2, the most important thing is the A1C. Here in SURMOUNT-1, the difference was not that significant, but in SURMOUNT-2, it's a little bit high. Let's look at that. So patient with diabetic will not benefit from tirzepatide, and the answer is no, because we can see most of the patients are still reaching the target of A1C less than 7. However, when we look to a better result or a greater result to reaching the 5.7, we can see the difference is slightly larger there. Similar results found in the blood pressure as well and the ALT level. And they did it also to assess the lipid profile, high level cholesterol and triglycerides. However, participants with more than 5% weight reduction at week 8 achieved a greater result in terms of all the cardio parameters. And this analysis is relevant to clinicals as they support their patient to achieve this personal therapeutic goals. These are the acknowledgement and disclosure of the author, and these are the safety contact information for anyone who have any inquiries or a question regarding the safety or adverse event related to Lilly products. Thank you so much. And now I will go really quickly and I will be super short to present the other sub-analysis of the SURMOUNT-4.
You will need 10
So
minutes
the
for
timer
presentation.
was giving me 3 minutes. I will stick to 3 minutes. If you allow, it's up to Dr. Osama as well. Okay, thank you so much. Sure. In this sub-analysis, we will see the changes in cardiometabolic parameters upon discontinuation of tirzepatide in SURMOUNT-4. And I will not go over SURMOUNT-4 because I know that Dr. Nasri is continuing the changes in cardiometabolic parameters by the degree of weight regain after discontinuing tirzepatide. This is the study design, and my voice is not helping me, so I need to stop. I will skip the study design as well. Moving to, let's go to the conclusion, I guess. Tirzepatide. And tirzepatide discontinued regained to 25% or more. So what's the benefit of this sub-analysis? These findings support the need for continued obesity treatment in adults living with obesity. Thank you so much. Again, this is the reference, and this is the safety contact. Thank you. Thank you.
So our next presentation will be by Dr. Naif Al-Matrafi, who will talk about impact of post-operative follow-up on long-term outcomes of sleeve gastrectomy in Saudi population during the COVID-19 era.
Assalamu alaikum warahmatullah. I'm going to present impact of post-operative follow-up on long-term outcomes of laparoscopic sleeve gastrectomy in Saudi population, retrospective cohort study during COVID era. Obesity is now recognized as one of the most significant public health challenges in the 21st century, with global prevalence increasing at alarming rate. And its consequences are severe, leading to increased mortality and morbidity. The COVID pandemic has further disrupted the healthcare system globally, affecting routine care and follow-up care of bariatric patients. King Abdullah Medical City in Mecca between the 1st of May 2019 and into follow-up patients, those with follow-up more than 1 year and no follow-up patients. Our result among all age group and comorbidities, no statistically significant were observed, and BMI reduction were compared between non-follow-up and 1 year, more than 1 year follow-up. Shows in non-follow-up group was BMI reduced 13.4, and more than 1 year follow-up, BMI was reduced 14.3, with no significant were observed. The complications from non-follow-up group was collected through the phone and consented and witnessed, shows overall complication in follow-up group more than 1 year showed 77.1%, comparing to non-follow significant was shown. Regarding the resolution of diabetes mellitus, shows in more than 1 year follow-up shows 80%, and no follow-up was 20%, and the resolution of hypertension was 66.7 in more than 1 year follow-up, and 33.3 in non-follow-up group, and no significant was observed. In conclusion, the findings suggest that regular monitoring allows of timely detection and management of which may otherwise go unnoticed. Detection of complications such as leaks, bleeds, including diabetes mellitus and hypertension, was more common in the follow-up group, though this difference was not statistically significant. Thank you.
Okay, we will end the session with the final talk from Dr. Abdulrahman Al-Amri, and he will give us the retrospective safety analysis of bariatric surgery in elderly patients in Saudi Arabia.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman and Co-Chairman. This our experience for bariatric surgery in elderly patient who aged 60 and above. So this is the outlines that we will go through it. So as you know, with the aging, the physiological function start to decrease, and the risk of illnesses start to increase in the other hand. Obesity, as you know, strongly associated with serious problems like cardiovascular disease, hypertension, diabetes, osteoarthritis, sleep apnea, and others. So effective interventions therefore essential to enhance the quality of life in aging people. So the research suggests that achieving a good weight loss for those patients with 65 and above can result in enhancing body composition and physical function and advancement in metabolic and cardiovascular well-being. Sure, we will start with non-surgical interventions, but also with studies that showed bariatric surgery, it has an excellent option for treatment of obesity in elderly patients. So our aim, this is to see the safety of bariatric surgery in elderly patients in our region, south and southwestern region of Saudi Arabia. This is another specific objectives that we will go through it to analyze the demographic and clinical features of geriatric patients who are undergoing bariatric surgery, and see the safety parameters associated with the bariatric surgery to identify and assess complications related with the bariatric surgery in this age group, and to examine the distribution of post-operative complications. So the significance of this study to bridging outcomes and advancing geriatric study research. So the methodology for this study, it was a retrospective analysis that's being conducted in Najran Specialized Hospital in our of 2018 to 2022. So about the result and discussion, we can see here about the demographic and clinical features of the patient. The mean age, it was 64. We have females. Most of the patients underwent sleeve gastrectomy. 3 patients underwent laparoscopic groin with 2 comorbidities and more. As found in other studies, most of the patients, around 85, apnea, hypertension, and diabetes, has been also, there is no mortality. There was no indication for reoperation. The length of stay in the hospital around 1.7 patient to another observed bariatric procedure in the general population. Risk of reoperations or percentage around 40. So definitely, we found that, again here, we can see the distribution of the post-complication patient with those who is, most of the patients who get the complication, the age is 64 and below. And from the other study, who found the age is independently associated with the post-operative complication after adjusting the co-founders. Again, the complications more happened in those patients with more than 2 associated rate of the post-operative complications. In our short experience or short number of the cases, the complication happened more with the sleeve gastrectomy, more other than the laparoscopic gastric bypass, despite the literature review indicate sleeve gastrectomy to be more feasible and more safer than laparoscopic gastric bypass. Anyhow, the differences in our study, it was insignificant, and our findings show that bariatric surgery in geriatric patients is very safe and very effective and associated with the risk of complications not differing significantly from another general gastrointestinal surgeries. Limitations of the study, it was a small sample size that limit us to draw a definitive conclusion. Finally, we conclude that the result of this cohort study suggests that bariatric surgery has a favorable safety profile with acceptable complication rate and low mortality. The safety profile is consistent across different bariatric surgery procedures, giving those findings. So bariatric surgery should be considered for elderly patient to enhance their health and quality of their life. Recommendation, we need a further research with a larger sample size and long-term follow-up is needed for a better understanding the impact of bariatric surgery in elderly patient, especially in terms of quality of the life and.
Thank you, Dr. Abdurrahman. By this lecture, we concluded our session, and I would like to call for the chairperson for the next session, which is Bariatric Surgery Awareness, Care, and Managing Complication, Dr. Abdul Muhsin Al-Isa and Dr. Muhammad Abu Khater.
Session is Dr. Hussam.
Unusual complications, hemolysis, sarcopenia, neuroleukopenia, and acute liver failure. Regarding rhabdomyolysis, actually, there are multiple case series about it, and regarding prevalence is actually range between 1.4 up to 75%. What are the, and when it reach more than 15,000, it may develop microglobin factor actually. But this is the most independent risk factor that have been the risk factor for rhabdomyolysis. The treatments actually is IV fluids, should between 3,000 to 5,000 fluids to start the treatment. Regarding sarcopenia, what you mean by sarcopenia is actually progressive loss of muscle mass and also muscle strength that cause functional impairment. Its prevalence range between 15 up to 15%, up to 30%, and more than obesity, which is associated with obesity. It's loss of muscle mass, increase of fat, associated could be with aging and insulin-resistant oxidative stress or inflammation. How to assess sarcopenia in patients with bariatric surgery? CT scan, where you assess the paravertebral muscles at the level of T12 or muscular BIA, which is actually body impedance analysis, depends on the impedance of the measurement between the electricity between fat and muscle. It's very simple measurement. Also, how to assess the strength, muscle strength, also different ways, but simpler way is to use the hand grip, and for women should be more than 20 kilogram, and for the men more than 30 kilogram. And the performance is just simple way to the gate speed. They have to pass through 4 millimeter with speed more than 0.8 millimeter per second. What about the sarcopenia in bariatric surgery? you can see from this study, it's associated with more gastric leak in a sleeve gastrectomy. So it's very important to take care of these patients. It may reach 9% with patient is sarcopenia, compared with 2% in absence of sarcopenia. This actually, you can skip that slide, but just to show there is how to prevent and treat. Actually, the most important is nutritional supplements, exercises, recent recommendation up to 30 minutes each session. Hypoglycemia, low plasma glucose, and relief of symptoms we give the glucose. We should differentiate this one from actually the dumping syndrome, which is happen after few minutes to 1 hour. Anxiety is the important differentiation. Regarding level of 50 milligram. What about the preference of the hypoglycemia post gastric or bariatric surgery? If you look to this study, actually they found it's 2.6% after the bariatric surgery. Most of them, majority of them actually post Roux-en-Y gastric bypass, 98%. And it ranged between 13 to invasive treatment. 75% resolved by the treatment. Another study, but showing less incidence of hypoglycemia by 0.2%. What are the causes actually? It's more complicated. And most recent study blaming the carnitine and acetyl to read these guidelines from the European Society how to approach this kind of patient, meal or after meal. If they have fasting hypoglycemia, you should exclude insulinemia. And if postprandial and bariatric surgery, you need to consider its hypoglycemia related. Include small frequent meals, reduce carbohydrates, avoid use the cornstarch supplements. You give 2 spoons of cornstarch before the meal. And you finish. The other one is exercise. You have to have exercise, some carbohydrates in developing while you are practicing. Treatment, the first line of treatment is the acarbose. Then, if failed, we go for short-acting steroids. The exercise, a third line of treatment. Then glucagon injection in patient with severe postprandial hypoglycemia. This is a new medication, the efixatride, is still under investigations. Regarding surgical options, could be gastrostomy for feeding, then either to reverse the gastric bypass to normal anatomy or the sleeve. But of course, we have regaining weight of 40% and GERD symptoms up to 25%. If associated with pancreatic mass, you have to go for partial pancreatectomy. There are some endoscopic options also regarding to minimize the size of stenosis or to create gastrogastric fistula. Finally, the acute liver failure. Actually, we need to just a quick talk about this one disease. Also, we have the acute liver failure, which is severe acute liver injury plus hepatic encephalopathy. To suspect it when you have elevated AST more than ALT. And the treatment usually it's in combination with hepatologist. Thank you very much.
Jai, minimal invasive and bariatric surgeon. He will give a talk about who should receive the extended VTE prophylactic post-bariatric surgery and for how long.
Good afternoon, everyone. Thank you so much, and thanks to the organizing committee to give me this opportunity to be among here. And if I can say and give a question to everyone, and we have the DVT and the issue of the post-bariatric surgery. So far until now, I can tell you what is the number that we had for bariatric surgery in governmental MOH recognized during the pre-op and the intraoperative. And we know that the obese patient, they are very high risk for developing a DVT. and also plus their comorbidity, plus their immobility, and under the general anesthesia. So all of these are risk factors. The Ministry of Health, it has been recognized as DVT is a big issue and a burden, and it's something that can be preventable. So they did the program and the patient who is potential with the clinical practice guideline. And according to that, we have already the Cabrini score or the modified Cabrini score, and it is a must now, and it has to be filled out for all the patients pre-op and for any patient with admission to the hospitals. From this one, we can say that they categorize that according to that, the patient with the BMI, if they are below 40 or more than 40. If for an enoxaparin, it will be the different in the timing between the 12 hours and the 24 hours. And for fundabuxahiberine, it will be the double the dose. The amount will be dubbed as a pre-op and for the patient who is during the hospitalization. According to our new guideline, we already, for hospitals with the almost class C for the our grade. For the patient with enhanced recovery after bariatric surgery, it also mentioned that the thromboprophylactic and who should be recommended. And to give that extended, it's only for specific group. So the bigger question, how much you give post-op and for how long? To answer this question, it's written already also in our guideline that this is regard the enoxaparin and to be given only with this amount, and it's only from 10 to 14 days. But what is the evidence or what that something can support that? From the ASMBS and what they are mentioning regard the enoxaparin, and 88% of the patient that they are having unfractionated, still the optimal dosing until now it's not yet mentioned. And from the other point of view, again, there is a lot of variation, and we know that according to that, patient also with the risk of the bleeding. So this is another thing. So Dr. Ali Aminian and our mentor, Dr. Philip Shower, they already present who should get extended thromboprophylactic after, and they validate from 2013, and they have this specific among those categories. And from 45 examined variables, they found 10 specific variables that it can lead. Just I will go with you through this. The initial timing, which is almost the second day post-op for sole patient, they increase the risk to develop DVT. And this is will plateau and continue until almost the day 20. And this is according from the study and from that. So the patient, they are at high risk from the second day post-op, especially if they are immobilized and they are not ambulating until the day of 20. And according to the p-values, and those are almost the tables with all the data. And those are the 10 category that if history of congestive heart failure, paraplegia, return to operating OR room, dyspnea at rest, nasogastric, non-gastric band surgery, age of 60, male as usual, we always dominant in all the good things. And again, the BMI more than 50, with length of stay more than 3 days, and the OR time if it is more than 3 hours. So according to that, this is the tables. I will just not bother you much with it. But there is also unmodified and modified factors, such as with the smoking or alcohol. But the age, the sex, the race, and the BMI, this is something maybe people, they will not be able to do anything more. The comorbidity, most of our patients, they have a lot of comorbidity with that. And the preoperative labs that should be recommended to be done regard the creatinine, albumin, hematocrit, and the platelet, and it's also playing a role. Especially that also the ASA of those patients is mostly 3 and 4. If we compare our patient to the cancer patient, we found that yes, they are almost over and they comparable to those, and they are more than prone to develop. So for such patient, and there is the regulator, the risk calculator that it's recommended by the Cleveland Clinic and by the group with the, according to the gender, the BMI, and all the specific 10 category that we mentioned. So what is the next step? Who's regard those now you identify, and you have now your high risk patient. So what is the dose and for how long you are going to give this patient? Consider keep in consideration the risk of bleeding and also the type of the molecule regard the low molecular weight heparin or in other types. And the duration. If I ask now who is giving it for 2 weeks, can you raise your hands? 1, 2, 3, 4. Type more than 2 weeks. So still there is a variability. Until today, there is, I think, no consensus regarding the duration and for how long. Is it safe? Yes, it is safe. It's recommended? Yes, it's recommended. The other question, are you giving it to all of your patients? Who is doing for all his patients? Raise your hands. All post-op patients. For selected patient, so the minority who is giving for a selected patient. So the recommendation is only for high-risk patient who should receive almost the high extended prophylactic. My conclusion, more than 80% post-bariatric surgery VTE event occur post-discharge and mainly with comorbidity. Routine post-discharge pharmacotherapy can be considered for high-risk patient. Thank you.
Thank you, Dr. Sam, for an interesting presentation regarding the VTE in bariatric surgery. Now we'll go to the next presenter, Dr. Hanan Al-Ghamdi. She is a consultant hepatobiliary and bariatric professor in University of Imam Abdurrahman Faisal. She will present a very interesting lecture about bariatric surgery and liver transplantation, review and recommendation. Please, Doctor.
Can we start? And before we start, first, thank you. Very inspiring to see attendance at this time of the day. One of the best meetings, and really I would like to thank the organizing committee, Ahmed Sultan, Dr. Ahmed Sultan, and Dr. Aid and Dr. Abdullah for putting together a wonderful agenda and expert here. My talk is about bariatric surgery in special subset of patients. Unfortunately, we don't hear a lot, and we don't have a lot of data that were explored in different meetings, which is the transplant patient, specifically the liver transplant patient. I know myself hepatobiliary and transplant patient and bariatric for more than 18 years, and Dr. Haidar Al-Shrufa, but anybody else here in the audience who are dealing now or before with the transplant patient had any experience? Anyone? Hand up. 1, 2, 3. Okay, there is some, quite some number. I mean, not much, maybe 5. Okay. You can use the USB. Until we get the presentation, we know that NASH is one of the commonest indication of liver transplant. In fact, in the United States, it's the second.
Ready,
huh?
Ready.
Yes, I can use this. Okay. Okay, this is my declarations and my experience. NASH is non-alcoholic steatohepatitis, and one of the commonest underlying etiology for liver transplant worldwide. We know that 38 to 15% of liver transplant recipients are obese. So this is tell us about the magnitude of the situation worldwide. And it is the second commonest indication of transplantation. Why obesity in transplant, I am focusing in. Meta-analysis showed that poor outcome in patients who are obese and candidate for specifically liver transplant, obviously because of the metabolic syndrome and its subsequent effect in their outcome and perioperative complication. Also, for the surgical complication, wound infection, incisional hernia, spontaneous evisceration, and disease recurrence. Some of the transplant center, unfortunately, had upper limit of BMI. It ranges from 35 to 40, but not more. The Mayo Clinic have nicely set a program of weight loss starting from dietary modification and so on. But this is not very effective, as we know, bariatric surgeon. And some of the patients, they had their priority delayed because of this. And this is, of course, had a drawback. GLB, we can debate this, but there is no convincing data that it can be used in very advanced end-stage liver disease, especially child C and B. And the disease recurrence is also an issue. So bariatric surgery in the setting of liver transplant program, why? Because as I mentioned previously, it's a challenging situation in any transplant center. There are several factors taken into consideration when establishing bariatric surfaces to offer it for the patient who are candidate for liver transplant or any transplant. The indication and selection of patient, the timing of bariatric surgery, the technique, the complication, and the effect in the immunosuppression. So the effect in immunosuppression was quite debatable for some time. Is it going to affect the absorption of the immunosuppression or not? Several studies showed contradicting outcome. Personally, in my situation, I see that the patient would require less immunosuppression, not the opposite. And the conclusion was from all these studies, therefore, despite the limited experience in the current literature, bariatric surgery does not significantly alter immunosuppression level and the doses. So now the question is which bariatric surgery? Sleeve gastrectomy gained a lot of attention, probably because the continuity of the anatomy is preserved. So we can access bile duct in case we need to do any intervention, or bleeding from varices. And there is not much effect on the malnutrition and absorption. Now the timing. Is it the best to do it before, during, or after liver transplant? Before, it's extremely challenging because there is double procedure. There is cost issue. If there is a complication of sleeve, this can be delaying the patient. However, it has been done, and several studies have reported it. The majority in all of these, mostly the MELD score, which is the model for end-stage liver disease, scoring is less than 15. Doing it simultaneously, the biggest data coming from the Mayo Clinic. They randomized patient between dietary or doing a sleeve simultaneously, 29 with MELD score more than 32. So the one had simultaneous sleeve gastrectomy with the liver transplant had higher MELD score. And they had excellent outcome, and this is like an iconic research cited for simultaneous bariatric surgery and liver transplant. After liver transplant, these patients are normal. There is no reason why these patients are not referred for bariatric surgery any bariatric surgeon, even without an extensive experience with the liver transplant. Unfortunately, still we see resistant. And the patient that I'm receiving is not, unfortunately, from my colleague liver transplant, but from the gastroenterology who are worried about the recurrence of NASH. This is the biggest meta-analysis looking into all the patient, published publication in, in different transplant, and this is a summary of it. Not big study, but it is growing, and it's showing the outcome in after, during, or before transplant.
2 minutes, Dr.
And there is actually no mortality in these cases. There is EASL guideline strongly recommending that if there is high MILD score, simultaneous sleeve gastrectomy and transplant by guidelines is acceptable. I'll skip this. I will go to one of the video. Turn the video on. Okay. So as I mentioned that this patient is, she had fulminant liver failure and transplant. I had short report from a gastroenterologist 5 years after transplant. And this is what we are facing, extensive adhesion. If you're not aware of the procedure, not aware of, this is Mercedes-Benz procedure. The patient has a BMI above 40. She was only in tacrolimus, nothing more. And incisional hernia, as I can see here. However, you have to know that surprises can be discovered during the surgery for a patient who underwent liver transplant in different center. And this patient was likewise. There is extensive in every quadrant, everywhere. And it's a thick adhesion and bowel sometime. And because she had the incisional hernia, probably it was more adhesion than any other patient. So typically we have to put the adhesion down using bipolar. This is only 3 trocars, and this is my standard. I use only 3 trocars. I don't use any assistant. Usually I do sleeve around not more than 5 centimeters from the pylorus, between 2 to 5 centimeters from the pylorus. So short gastric now are dealt with, bipolar, similar. I do reinforce the edge of the omentum with the clips because I do put them. This is surprising. I found something here below the stomach. What is this? We're not used to see this structure below the stomach. And because I have knowledge about transplant, this is the jump graft from the left iliac until the hepatic artery. And it was below the stomach. If I knew this before surgery, maybe it will deter me from doing the surgery, because if there is a leak or anything with the graft, this is disaster. But we did not know this. The patient doesn't know, the medical report doesn't have. So I did something here to protect this graft, which is oversewing, I mean, whatever tissue above it, pre-pancreatic, whatever I could find. I tried to bury this vascular graft, which is a Gore-Tex graft. So in case of leak or anything, this will be somehow protected. Usually I don't fiddle with the porta hepatis area, and there is no need to do it, but all the adhesion in the abdomen, if I can, I try to mobilize it so there will not be bucket of collection post-operative. And then just a classical sleeve gastrectomy using my favorite, which is powered echelon, sometimes tri-stapler, with hand sew.
Can you conclude?
Yes, covering, not over sewing, but invagination of the stapler line. Patient did very well post-operative. We had to decrease her immunosuppression by 30% based on the TAC level. She did very well. I did put her, because of the graft, in a longer time in Clexane, 6 weeks. She reached, conclude, yeah, next slide. Next slide, please. Last slide. Last time. Obesity is a poor prognostic factor for liver transplant. Liver transplant center must consider all options. That is unethical and should be revised. It's my dream to have a consensus meeting, and I think it's essential, and I think the bariatric community has to lead this. So, thank you.
Thank you, Dr. Hanan. Our next speaker is my friend, Dr. Talal Khwaiter. He's a consultant, advanced laparoscopic surgeon and bariatric surgeon in Bariatric Surgery Center in King Salman Force Arm Hospital in Tabuk. He will tell us about who can undergo for hypoabsorptive SADI in Saudi, 5 years single Saudi institution data.
Thank you. Good afternoon, everyone. It's something quick about SADI and our results as a single center. This is my case mix closure. And all of you know that after the statement of the EFSO, the SADI procedure is safe and reproducible with low early and late complications. Primary procedures may be better than the conversional ones, and it yields significant sustained weight results on the medium and long-term results up to 5 years, according to the published literature. It has a very good result in obesity complications, especially type 2 diabetes, and dyslipidemia and hypertension on the medium term. And there is some cautious about the serious, and we should. Many studies actually consider that above and all other criteria, but we believe that this is a very strong hypoabsorptive procedure and shouldn't be really offered to any usual candidate for any other type of bariatric or metabolic bariatric surgeries. So in our opinion, we should tailor the criteria of inclusion. So not any obese or BMI above 35 should go for SADI. So we present here our experience on long-term outcomes of laparoscopic single anastomosis duodenal switch, SADI, as one staged and conversionable. October 2024. BMI was approaching 60. Time interval between the conversion and for the 2 stages was 21 months. And the operation time, almost 82 minutes. It's higher in the 1 stage, of course. The procedure, as usual, sleeve in 1 stage or sleeved in these conversional cases. And then 3 meters, at least 3 meters from the ileocecal junction. We never did below than 3 meters. And the anastomosis at least 3 to 5 centimeter from the D1 at the end of the D1, actually at the beginning of D2. Usually Hanson using barbed sutures. How's the BMI figure will move? We have 2 patients completed almost 6 years, 5 years, and 3-4 years, and the others, as you can see. During COVID time, unfortunately, there was no surgeries. Regarding the 5 years, up to 6 years, and regarding the nutritional status, that's what I look for. So I kept it in numbers to make it clear for everyone that we have an issue with the iron deficiency anemia. If you can see here, highlighted almost in red, that some people or some patients have low hemoglobin level after improved actually in hemoglobin levels. We have also some patients, number from 26 to 28, with some drop in albumin level over time. That's interesting to have some of the strong or aggressive nutritional support after surgery. So SADI, in our experience, SADI-S is a very effective procedure in reducing the weight in class 4 and class 5 obese patients as a one-stage or staged or as a conventional procedure from sleeve gastrectomy or adjustable gastric banding, 14.3%, and hypoalbuminemia in 10.7%. However, a significant improvement of hemoglobin levels were seen or observed in 8 patients, means 28 or almost a third of the series. There was no short-term 30 days or long-term complications, no admissions, no readmissions, and no mortality in this series. Regarding the obesity complications, 3 of our patients were diabetic, type 2 diabetes, all of them on remission. Regarding the hypertension, we have 10.7% hypertension in 2 patients. We have recorded 2 patients, and then both of them has cleared up. Now, who's not a candidate according to our series and our literature review? I think class 1 and class 2 obesity without obesity complications has a query Down syndrome, because we have 1 patient in this series, Down syndrome, and she did well in the follow-up. So the BMI did not really change much, and the other obesity-related. Who is the candidates? We believe that class 4 and class 5, with or without obesity complications, who regain weight or not respond or non-responder after any metabolic barrier. Careful about those candidates or patients, especially in our community. They have to be well educated. They have to listen to the advices. They have to take their supplementation for life. They have to understand the changes in the bowel motions, in the odor, in the absent after 6 years. So we were very careful in selecting these patients, and we keep in touch with them at least 6 months, a call. At least every 6 months we give them a call and to document everything in our system that they are still following and taking their medications, and they come for their 6 months lab investigations.
If a patient post-leave and you want to do SADI, or a patient with hiatal hernia, you can repair the hiatal hernia and do SADI at the same time?
Yes, of course, for conversional cases, we have to do upper GI endoscopy and barium swallow to rule out any hiatal. What I usually do, I repair the hiatal hernia, I put a mesh, absorbable one from Gore, and then I do the SADI. They have then follow-up endoscopy in 6 months to make sure that there is no more reflux, and biopsy again.
Thank you.
Thank you. Thank you very much.
Surgeon, laparoscopic and bariatric surgeon. He is the founder and president of the Jordanian Society for Obesity. He will speak about initial experience with a single anastomosis ileal bypass compared to OGB. Please.
Assalamu alaikum. Thank you for the invitation again and for the organizing committee. So, evaluation of weight loss after single anastomosis and Roux-en-Y gastric bypass are nowadays mostly or the most performed procedures. Was performed and in laparoscopic form in 1994 by Whitgrove, and laparoscopic gastric band in 1990s. However, 93 laparoscopically formed. Sleeve gastrectomy in the form of which is performed now in 99 by Garnier, and biliopancreatic diversion in 79 performed, and biliopancreatic diversion with duodenal switch in 88. There are multiple procedures, single anastomosis duodeno ileal bypass, SADI, in 2006 by Torres described. And SASI is recently a procedure. Some of the colleagues are performing this, and there are some studies about this. It's based on the principles of one anastomosis gastric bypass. However, the pylorus and duodenum axis remains possible, no high pressure in the gastric tube, and gastroileal anastomosis 250 to 300 centimeter from the ileocecal valve. SASI bypass is recently developed a procedure, hoping with it to avoid the negative side effects of other procedures and to achieve more positive results on weight loss, maybe follow-up obtained regarding the weight loss and effect on comorbidity. And we compared our results with one anastomosis gastric bypass. We had two groups, the SASI group and one anastomosis gastric bypass group, analyzed variables, the BMI and excess weight loss and pre and post-operative comorbidities for 2 years. The technique of one anastomosis gastric bypass, we used always to measure the whole small bowel, which I recommend always to do it, as this length is different or differs individually. And at 2 meters from the DG flexure in one anastomosis gastric bypass, and the same we measured for SASI from the DG flexure, not from the cecum valve. However, always measured the remaining common channel. It means around 3 meters from the bowel length, and always left 2.5 to 3 meter distally length. Between 2019 and 22, we had 102 patients in SASI group and 120 patients in one anastomosis gastric bypass group, and the follow-up was around 94–93%, and there were no significant differences between both groups. I have to make a bit faster just to save the time. Regarding the body mass index in both groups, there was no difference after 2 years regarding weight loss. And looking at the iron deficiency, it was a significant difference in the incidence of iron deficiency between both groups, and was less in SASI, more common in one anastomosis gastric bypass. Looking at the effect on arterial hypertension was similar without significant difference in 41% one anastomosis gastric bypass, and vitamin D deficiency more common, hypoalbuminemia more common, otherwise no differences. And bowel motion habits, which is very important aspect actually, we don't maybe use to ask the patient, but it is very important. The frequency of bowel motion within 2 years was less in SASI group. Even the odor was different, and we postprandial abdominal pain, patient with bypass, they complain about this. In SASI group, 15%, and one anastomosis gastric bypass in 55%. Satisfaction, asking the patient, in 93% of the patient, they had result very good to good in SASI, where in 83% in one anastomosis gastric bypass, and not satisfied 6% in one anastomosis gastric bypass, mostly because of the pain and the odor and frequency of the bowel motion. The results, we observed a mild, not significant difference in excess weight loss in favor of one anastomosis gastric bypass. Diarrhea and postprandial abdominal pain less frequent in SASI. Stool odor less bad in SASI group. Iron deficiency incidence less in SASI group. And no significant difference in improvement of diabetes mellitus, hypertension, or reflux disease in both groups. The conclusion, SASI bypass achieved superior results in terms of quality of life, morbidity, and results with significant and comparable excess weight loss to one anastomosis gastric bypass. SASI is a variant of one anastomosis gastric bypass based on physiological principles. It is a restrictive and malabsorptive procedure, and long-term results are still required. Okay, there are some studies published in favor of this procedure as well. I don't want to go on details here because the time is running. Okay, just to see the video, short video. Oh, what's happening? Okay. Yes, we do the sleeve first, like a normal sleeve gastrectomy. I'm sure there is always some variations between surgeons to do the sleeve. I use the bougie 40 French bougie. There was music actually with the video, I don't know. Anyway. And always I go away from the gastroesophageal junction, the angle of his. I keep a little bit from the fundus. I fix it to the diaphragm and over suture the first third of the suture line, the proximal third of the suture line. I measure from the DJ flexure because SASI is described to measure from the ileocecal, but anyway, I always measure the whole bowel.
Can you conclude, Dr.
Okay, we nearly finished. The length from the DJ flexure 3 meters, but always measuring to have more than 2.5 meter distally. Okay, we close the defect and okay, yes, it can run. This patient came for, the same patient came for lab coli, and we did video from her anastomosis here from her SASI, how it looks like after 1 year. Okay, thank you very much.
Thank you, Dr. Sami. By this, we close our this session, and the next session will be about the top abstract. It will be held or chaired by Dr. Hanan and Dr. Ghannam Al-Ghannam, please.
Assalamu alaikum. I'm glad that we are catching up time-wise. Inshallah, we'll have an excellent session. It's a top abstract session. Each talk is 5 minutes. So please, dear colleague, stick to time. It's getting late. So our first speaker is Dr. Al-Hassan Al-Maghribi. And the topic is gastric mucocele following Roux-en-Y gastric bypass in a patient who underwent butterfly surgery.
Assalamu alaikum. Good evening, ladies and gentlemen. It's such a great pleasure to be here with all of you, my mentors and professors and seniors. Today I'm going to talk about a rare complication of post-revision Roux-en-Y gastric bypass post-butterfly gastroplasty, which was done outside of the country. So I have a 51 years old lady with medical history of diabetes, hypertension, and disc prolapse sciatica. She did an open butterfly gastroplasty in August 2016 in Egypt. At the time of surgery, the patient was weighing 114 kg and BMI 39.4. 2 months later, the patient complained of solid food intolerance and her weight decreased up to 83 kg. Laparoscopic cholecystectomy was done in 2019, also at Egypt for chronic cholecystitis. Endoscopic dilatation was done twice for the stenosis at the level of the gastric pouch and the butterfly surgery. Her symptoms did not improve despite the 2 dilatations she did, and she still have the GERD symptoms, heartburn. In June 2023, in other facility, this lady, she did an upper GI scope, showed no hiatal hernia, only clear pouch with easy passage of the endoscopy, no gastric ulcers, and there was H. pylori was found, so eradication treatment was done. Despite the eradication, unfortunately, this lady, she still had the symptoms. For those who who are not familiar with butterfly surgery, this is the surgery and how it's being done. It's cutting stapler both sides of the stomach. These are some papers and articles talking about the butterflies. They are claiming that it's much better weight reduction, and in food, solid tolerance is much better than sleeve gastrectomy. So back to our lady, in 2023, she appeared in my clinic showing severe GERD symptoms with dysphagia to solid food. Her weight was at that time 93. She was depending only on juices and high caloric diet, high sugar diet. Barium swallow was done, showed smooth passage of the contrast along the course of the esophagus, stomach, no filling defect, only mild gastroesophageal reflux was noted. This was the endoscopy, and we can see down there, the opening there, this is the site of the butterfly. And there was another opening at the left side, which was a gastrogastric fistula at the same time. So this was the CT showing the gastrogastric fistula and the site of the butterfly surgery. So in 2023, laparoscopic Roux-en-Y gastric bypass was done for the solid food intolerance and the GERD symptoms she was having. Unfortunately, during the procedure, there was a severe dense adhesion at the stapler line and the splenic vessels up there in the fundus. So what we did, we tried to go above the mesh and the stapler line, and we create our pouch, and we did our Roux-en-Y gastric bypass. 14 days post-operatively, she came back with heart pain, dizziness, and sweating, palpitations. So we did CT scan, showed nothing. She was having only collection subserosa in the stomach, excluded stomach, 3 by 4 by 4 centimeters. She was treated conservatively and discharged home. 5 weeks later, she back again with intolerance to solid food again. So we did a CT scan. We saw this collection, which was in the excluded stomach. So obviously, this is the trouble we stayed with, leaving the mesh behind. So can we turn on the video, please? So again, back to OR, we found this dense adhesion. All of this was dissected. This is the excluded stomach. You can see up there the mesh is adherent to the liver, back. And if we concentrate down there in the stapler line and the fundus, it was totally adherent to the splenic vessels. So we start doing our best for adhesolysis. Can we move the video for the sake of the time, please? So all of this was not that much, just a little bit back. Yeah, so we tried to do a lot of adhesolysis, but unfortunately, we couldn't reach there, and we couldn't dissect the stomach and the stapler line away from the stapler, from the splenic vessel. So what we had, we opened the stomach, the excluded one, and we tried to go inside it, and we found the fistula opening, which was draining the mucosal of the stomach. So, and there is some pus. So we dilate this fistula. So we have now two openings, the site of the butterfly at the mesh and this fistula. And again, we couldn't remove the stomach. So we dilate the fistula and we make another fistula, and we close the stomach and lift it in peace. Okay, we are fine. So next slide, please.
Can you conclude, please?
Sure. So in conclusion, revisional surgery is a difficult and prolonged procedure that need proper planning, plan A and B and C and even D. Unexpected complication can happen from revisional surgery. Gastric mucosal is a very rare complication and difficult to diagnose. Do no harm, be safe. Thank you.
Thank you, Dr. Hassan, for interesting case. The next
I
talk
think
is
yeah.
technical aspect in OABG post-sleeve gastrectomy for recurrent weight gain, presented by Dr. Al-Wahhaj Khugair. Dr. Al-Wahhaj, 5 minutes, please.
Assalamu alaikum. Thank you for having me and staying late. I will be brief. So we have loads of evidence that OAGB is 3. So we did extensive evaluation for her. Swallow showed that she has, if you can see, a dilated fundal pouch, slightly dilated sleeve. The endoscopy even showed that they can retroflex easily inside the whole sleeve. So we decided to go for a conversion to an OAGB. The question is whether to trim or not to trim this fundus. If I can get a quick show of hands, who would resize the fundus during a conversion to OAGB for a first sleeve? Okay, who would just leave it be and do a bypass? Oh, excellent. So in this particular case, I'm used to trim all my pouches. Can we play the video, please? Sorry. So we found that she had a bit of a dilated fundus. So we used adhesions. Under the guidance of 36 French bougie, we started to resize the pouch. We use stick loads, black load. I always use reinforcement in all my revisional cases. That took me around 3 fires to take the whole fundus out. There was no hiatal hernia, and so there was no major issues with this step in this surgery. And then we carried on doing our traditional OAGB, so a long pouch just below the crowfoot, less than 200 meter BP limb, 2 layers closure, and a leak test, and that's it. So for the sake of time, I'm going to pass this one. So unfortunately, post-operative patient did not tolerate already well. We thought this is initially due to edema. We waited, we used some medication, but she did not improve. A swallow showed complete hold of the contrast. There is not a single drop going down. We took her for an endoscopy, showed severe stricture at the mid of the pouch, and they could not pass the scope inside, so we took her again for surgery. So we thought that it could be related to acute twist, acute kink, or something like that. So what I did was I released all the adhesions anteriorly, laterally, posteriorly, just to allow maybe the bougie will pass on after that. Unfortunately, with multiple attempts, the bougie did not pass. And at that stage, I thought that, okay, the decision is to go for a Roux-en-Y gastric bypass just above the level of the stricture. So just below the level of the left gastric pedicle, we just made our release, or took down the previous anastomosis, of course, and we did that standard Roux-en-Y gastric bypass. We made sure that we have enough common channel after doing this. And of course, we closed our mesenteric defects, and we concluded. So post-operatively, she did have a bit of ileus, but we did a swallow. It went out smoothly with no problems, no leak. She was discharged home in day 5. Unfortunately, 5 days after surgery, which is 14 days from the index surgery, she came back with sepsis. A CT scan showed dilated bowels and evidence of air pockets collection at the gastric pouch. So suspicious for leak. We took her again for surgery, and this is what we have found. Please play the video. A lot of adhesions in the liver bed in the gastric pouch. The whole bowel was dilated. This is why we ran the whole bowel looking for any internal hernia, although we closed the defects. That did not show any internal hernia. Mostly that was reactional. Then we went to the gastric pouch and to see what's going on. So we tried to separate the tissues. There was a phlegmon tissue over there, and by dissecting this, we have found, unfortunately, there is a leak, not from the gastrojejunostomy, but from the stapler line of the previous re-sleeve. So we did an intraoperative endoscopy immediately at that stage, and that has confirmed that the presence of a 3 centimeter length opening,
Conclude,
leaking.
please.
Yes, okay. So because the patient was severely septic, we did just damage control. So feeding jejunostomy, drains, injured the tube, and we went out. Unfortunately, she had a very unpleasant postoperative period when she was in ICU for some time. But fortunately, with careful waiting, after we treated sepsis, drainage, and abdominal pain, actually she improved. So we did a scope back, the CT scan back, all has resolved, and we did not have to do any other surgery. Endoscopy was done, completely healed. She was discharged home after 51 days, but again, we saw her, she was in complete health. So to conclude, OAGB is a good option. You may re-sleeve the sleeve, but however, you should know things may go wrong. If things went wrong, please be patient, as patience here is paramount. Thank you very much.
Thank you, appreciate it.
Next talk is by Dr. Omar Bamelan. He's here. Yeah. And the topic is insight in gastric bypass reversal to normal anatomy. What are the outcomes? Again, please, 5 minutes.
Okay. Good afternoon, everyone. My name is Omar Abdelkader Bamelan. I'm a general surgery resident. Today, inshallah, I'm going to present to you our paper titled as Insights on Gastric Bypass Reversal to Normal Anatomy. What are the outcomes? We're going to focus on a very specific niche of bariatric patients, which are patients who underwent Roux-en-Y gastric bypass or one anastomosis gastric bypass and then went reversal to normal anatomy. So I have no disclosures. We're going to start with the background. As we all know, Roux-en-Y gastric bypass and one anastomosis gastric bypass are effective bariatric and metabolic procedures. Usually the studies are showing that post-operative satisfaction in these procedures is correlated with the total weight loss and the resolution of obesity-related comorbidities. Therefore, we wanted to study the patients who underwent complications after the procedure and required further modalities to manage the complications. So what we did is we did a retrospective analysis for 20 years of patients who underwent Roux-en-Y gastric bypass or one anastomosis gastric bypass. We did an electronic medical record check in which we checked the patient's perioperative, operative, and post-operative data, and then we communicated with the patients to assess their current quality of life and to assess their current status and to also fill up the gaps that we found during their history. So our aim was to understand their current status, what happened to them, what is happening to them now. So the result is that we found 30 patients within the 20 years who underwent the reversal to normal anatomy. 3 patients were excluded due to insufficient data and due to lost contact. So the majority of the patients were females, 27 were included into stats. So the pre-reversal data, as we can see, the majority of the patients were females, middle age, and 1/3 of them had type 2 diabetes. The pre-reversal BMI was in the normal range. However, as we can see, the standard deviation is slightly increased, which has been changed. As we can see, the most common indication in the Roux-en-Y gastric bypass group is dumping syndrome. In the one anastomosis gastric bypass, we've got malnutrition. In the reversal group, we can see that time from bypass to reversal is quite a wide range. In the Roux-en-Y gastric bypass, we've got 7 months up to 7.5 years, while in the one anastomosis gastric bypass, we've got 10 months up to 5.5 years. So this is a long gap which affects also the outcomes and the assessment that is currently being undertaken. The mean OR time is comparable in the two groups, in which we have 1.5 hours and 2 hours. The intraoperative complications, we had no intraoperative complications, thankfully. The post-op complications, one patient had bleeding, which was in one episode of hematemesis, which was resolved conservatively through a pantoprazole infusion. The length of stay is comparable in both groups. However, if you have a Roux-en-Y gastric bypass patient, the possibility of the patient staying 1 day longer in the hospital is higher than in the one anastomosis gastric bypass group. The post-operative, we can see that we have a steady, significant weight gain in both groups. The patient satisfaction was excellent due to the fact that we've got the alleviation of the indication of reversal. So that's why. We've got the follow-up period of 2 years. And of course, we had, thankfully also, we had no complications post-operatively and no 30 days admission. As we can see, these are the charts that can showcase the steady increase in weight post-operatively. And then we can see the quality of life assessment that has been undertaken cross-sectionally. We can see that the majority of patients, the mean was a fair quality of life. However, the overall satisfaction was excellent. The overall alleviation of symptoms was excellent as assessed by the patients. So we have got two discussion points, which is the weight, most importantly. The second is the recurrence of obesity-related comorbidities and the regain that is going to happen in a multidisciplinary manner. So this is in a multidisciplinary manner. So this is an invite to everyone. Please, if you have cases that are on the same page, that underwent the same procedure, let us know.
Thank you, Dr. Amar. The next talk is incidental fighting of GIST during laparoscopic sleeve gastrectomy, presented by Dr. Muhammad. Dr. 5 minutes, please.
Assalamu alaikum wa rahmatullah. My name is Muhammad Musab. So, the case presentation. This 57 years old female patient on case of rheumatoid arthritis, bronchial asthma. She was present to our clinic as case of morbid obesity or any previous history for upper endoscopy and admitted electively for laparoscopic sleeve gastrectomy. So, patient underwent laparoscopic sleeve gastrectomy and during the last stapling and was included in the resected specimen. The surgery and post-operative recovery were and so unfortunately we didn't take a picture during the OR, but this is the mass in the histopathology lab with spindle cell, and the size was 2 centimeter and mitotic rate up to 117, DOG1 positive and CD34 also was positive. Margin was negative. This is the histopathology. Patient seen during the clinic and visiting the oncology and classified according to them as low risk and no need for adjuvant medication like azimetinib, and she is only for site is the stomach and can be diagnosed by CT abdomen, MRI, endoscopy and FNA, which start at 2002 and it was including the tumor size, mitotic rate, and the tumor site. Then modified after that on 2006, and also they focused on its gastric or classified as TNM, which is tumor size and lymph node involvement and metastasis, and they not focus on the mitotic rate. So the management for GIST surgery is the primary capsule or rupture during the resection. Re-resection is generally not indicated for microscopic positive margin on final pathology. The rule for laparoscopic resection for GIST still expand. The laparoscopic surgery associated with low recurrence rate, short hospital stay duration, and low morbidity. A meta-analysis of 19 study, including around 1,060 guest cases. Laparoscopic approach was associated with less blood loss, low complication rate, and short hospital stay. There is multiple study, one of them which included around 1,415 and show around 0.8.
Please.
Okay. This retrospective 3052 bariatric surgery show 46 incident trauma, including 10%, around 5 patients, including guests. So my conclusion, this case exemplifies importance of surgery, being aware of the incident trauma and laparoscopic sleeve gastrectomy. That is also important. The last one, with increasing of laparoscopic procedure, more incidental finding will be encountered, therefore is important bariatric surgery. Thank you so much.
Thank you, appreciate it.
The next talk is, the topic is superior mesenteric artery syndrome and gastroparesis.
I do have nice case of superior mesenteric artery, although we discovered in our center in Neurospecialist Hospital in Mecca. So my case is, this patient is 28 healthy male patient. He's pain, early satiety, and weight loss more than 30 kg. They did endoscopy for him, and that showed dilated duodenum. And the scope was looping in the second part. They could not proceed more. Also, the patient, unfortunately, he was roaming around in polyclinics, diagnosed as irritable bowel syndrome, gastritis, and lactose intolerance. So they referred the patient to me as query superior mesenteric artery syndrome. In our clinic, the basic blood workup was acceptable. CT contrast confirmed the diagnosis of superior mesenteric artery. And we did endoscopy ourselves, which showed dilated stomach, reduced motility, and dilated duodenum. We fortunately could proceed from second part of duodenum, and compression of the lumen showed in the third part of duodenum. So this is the CT scan, which showed the angle is more than 35 degrees. So the management, the patient underwent nutritional support by our great dietitian, which is filled with high caloric, high protein nutritional diet. Patient has severe symptoms and weight loss. So our decision was for laparoscopic duodenectomy. This is the procedure. We start the surgery. I add the case on the list. We started the surgery late. So I start to use the scissor, make it a little bit bloody. This is the second part of duodenum, the anterior dissection, lateral dissection, and followed by posterior mobilization of duodenum to make it anastomosis, side to side duodenectomy, closure of the defect hands-on. But unfortunately has postprandial pain, fullness, inability to tolerate fluid very well, and readmitted twice for dehydration, despite patient was on domperidone and metoclopramide. So gastroparesis diagnosed for this patient. I started erythromycin for him, 250 milligram BID for 2 weeks, then tablet for the next 2 weeks. Patient dramatically improved after 1 week of starting erythromycin. 1 month post-op repeated gastrographin show improvement, although I'm quite depending on her to gain weight after 6 weeks and resume his work, and patient was happy and satisfied. This is the gastrographin, day 1 post-op. Can we operate the video, please? Staying in the stomach with no single movement. Let's go, this is the second video.
Please conclude.
So we will conclude, but we are as bariatric surgeon, we are the incidence of superior mesenteric artery syndrome post-bariatric surgery is less than 1%. Not because this is the incidence and our surgery is safe. This is rapid weight loss post-op. because this syndrome is not in our brain as a bariatric surgery. For following the patient, nose restriction, endoscopy is normal. I think we should have to, in mind, the superior mesenteric artery. If we start to do CT scan for them, we will diagnose. I think our risk of superior mesenteric artery is more than just less than 0.8%. So the take-home message: surgery is required if conservative management is failed after 4 to 6 weeks. Duodenogenostomy is the gold standard for long and excellent outcome. Early intervention being necessary in severe cases. Avoid gastroparesis, which is common after gastrogenostomy, versus duodenogenostomy, 30% versus 5%. Thank you so much.
Thank you, Dr. Bara. The next talk is 5 minutes, Doctor.
Hello, everyone. It's a great honor for me to speak before you today. The topic sleeve gastrectomy using different calibration budget size. Sleeve gastrectomy is a widely used bariatric procedure. Calibration budget size plays a key role in the weight outcomes and complications. They study active analysis of patients undergoing sleeve gastrectomy. Resection line placed 2 cm proximal to the pile 6 and 38 range. Date collection 1 year post-operative weight loss and complications. In this table, this is comparative analysis. BMI was 45.8. TVL after 1 year, 55 patients. BMI was 44.8. TVL was 20. BMI was 43.1. TVL was 24.2. F1 leak and high incidence of nausea and vomiting. In the second group, we have 2 bleeding, moderate dyspeptic symptoms, and the last group have 1 bleeding rates. 36 and 38 range offer a balance between weight loss and reduced complications. Selection should, in conclusion, 34 French provide the highest weight loss, but with more side effects. And
Thank you. So the next talk is sleeve gastrectomy effect on the liver by chemical profile by Dr.
Great honor for me to speak before such a distinguished audience at this Congress. Today I would like to on the liver biochemical parameters in patients with morbid obesity and non-alcoholic fatty liver disease. So bariatric surgery is most effective method. With morbid obesity are at high risk of functional and structural liver disorders like steatosis and steatohepatitis, and also markers before and after LSG in 60 years old patient, male patient, with diagnosed with grade 3 obesity and laboratory confirmed by laboratory measuring biochemical markers including the cholesterol, triglycerides, ALT, AST, and alkaline phosphatase. They are reflecting liver health and potential of their damage. Liver biochemical markers were measured at various times, day, first week, first month, and the first year. In these clinical markers within the first month, so positive after LSD, and the improvements remained stable. We can say that our observation demonstrates that laparoscopic sleeve gastrectomy has a significant positive impact on the liver biochemical parameters and not only weight loss. These improvements suggest, but also benefits liver metabolism. And further research with larger patients cohorts give to us more information and deep understanding for this mechanism. I think so.
The next talk is the prevalence of some cardiovascular risk factors, obesity.
My name is Noor Al-Abdel-Latif, a senior medical student at King Faisal University, and I'm very happy to share with students. So, starting with a question, imagine being in your 20s and already on the path of developing a heart disease. Cardiovascularly, Saudi Arabia has higher obesity prevalence than the global average. And you may wonder, why medical students? Medical students, the future of healthcare, are even at greater risk because of unhealthy diet of Dr. Iman Sheikh. We interviewed 313 students at King Faisal Universities using a valid questionnaire containing demographics, medical and family history, lifestyle, and diet. And then we personally measured height and weight for BMI, waist circumference, also pulse and blood pressure. We found out that 90% consumed unhealthy food, despite also including fruits and vegetables in their diet. The shocking part was that 66.5% of students did not. Our study findings are consistent with other studies who also found out that students frequently consumed unhealthy food. In conclusion, our study highlights the presence of significant cardiovascular risk factors among medical students, including obesity and low loss of our dear Dr. Abdul Sattar Khan due to myocardial infarction before our eyes in College of Medicine. It's running a targeted program to promote healthier behaviors and to reduce cardiovascular risk factors effectively, not only among medical students.
Strong message for a serious problem. Thank you.
Thank you very much. Thank you.
So, anyway, للستودنت اللي ما يوقف تدخين.
Thank you very much.
Thank you. Okay. Alhamdulillah, we are good with time. It's by Dr. Hitaf Al-Gudu. That's correct? Yeah, and the topic?
Assalamu alaikum. Hello everyone. I'm Hitaf Abdul Gaddoum, a 6-year medical student at Imam Abdul Rahman bin Faisal. So, anal symptoms and disorders after bariatric surgery and overlooked entity. Sleeve gastrectomy and Roux-en-Y disorders after these bariatric surgeries remain insufficiently studied. So, given the established connection between the altered bowel habit and the emergence of anal disorders, a new onset of benign anal disorders may represent a significant postoperative complication with Roux-en-Y gastric bypass and sleeve gastrectomy. So, a questionnaire was disseminated through an online link to all patients who underwent bariatric surgeries between 2000 criteria, all patients with a previous history of benign anal disorders, also patients with irritable bowel syndrome, also female patients who had 3rd or 4th degree tear underwent sleeve gastrectomy, while 25 patients underwent Roux-en-Y gastric bypass. 57 of them were female, while 42. So as we can see, the Roux-en-Y significant decreasement in BMI in comparing to gastric sleeve. Here to show the altered bowel habit constipation post-operatively for sleeve gastrectomy, while here significant increasement in diarrhea post-operatively. So diarrhea is significantly higher after Roux-en-Y rather than sleeve gastrectomy. Here, to show the incidence of new onset of benign anal disorder after the bariatric surgery, and comparing the sleeve gastrectomy and Roux-en-Y gastric bypass. So for fecal incontinence, 12% in Roux-en-Y. For perianal fistula was 2% in sleeve gastrectomy, while in Roux-en-Y 8%. For anal fissure, 12% in sleeve gastrectomy versus 20% in Roux-en-Y gastric bypass. For significant higher incidence of new onset benign anal disorders, postoperatively, also and diarrhea and fecal incontinence. Also Roux-en-Y associated with a higher incidence of anal fissure, hemorrhoid, perianal fistula, and perianal.
Now the last session, 17. It's the International Federation of Surgery for Obesity, Middle East and North Africa, EFSUMINA.
Pleasure to have the team with us, Dr. Osama Sana, and
I'd like to present this session, session 17 on bariatric accreditation, representing the EFSU MENAC chapter. Be chairing this session, and Dr. Aid Al-Qahtani, Professor Aid Al-Qahtani will be co-chair for this session.
All right. Gives me great pleasure to co-chair Shower, who had a valuable contribution to this Congress and to bariatric surgery academia in general. Dr.
Great. Good afternoon. And let's see, these are not my slides. And while I wait for the slides to pop up, thank all of you for staying. I think this is a really wide, quality assessment and improvement program for Saudi Arabia. And this is really critical, are performing at a high level. Certainly in this room, we have evidence that wherever they have bariatric, I know they're there because there we go. Okay. So what I'll do in the next few minutes is share the U.S. experience, and I'll share Saudi Arabia develop an even more effective program for quality assessment nationwide. So the U.S. program is called MBSA-QUIP, which stands. So how did this come about? Well, this graph shows you the volume of bariatric surgery in the blue columns going back to the early 1990s up to, 2016 or so. And it also shows you the national data on complications and mortality. And you can see that the laparoscopic approach was introduced in the late 1990s. And you can see that the complication rates were around 12%. We're talking about major complication rates, and mortality was greater than 1%, so pretty high. Now, fortunately, with the introduction of laparoscopic, less invasive operations, we began to see a reduction in complications and mortality. But around 2003 is when there was a mass entrance of surgeons adopting laparoscopic bariatric surgery in terms of equipment and monitoring and so forth. So we did see, although it's not clearly evident on this graph, we did see an increase in major complications, especially mortality. And this created a great crisis in America. We were seeing on the front page of the New York Times, the Washington Post, Newsweek, patient dies after bariatric surgery. And of course, this is an outlier event, but it gets lots of attention. For this reason, the leadership of the ASMBS took it upon themselves to develop a nationwide quality assessment and improvement program. So this was in 2003, and this was launched by the American Society for Metabolic and Bariatric Surgery. Back then it was called ASBS, and the program is the BSCOE, or Bariatric Surgery Center of Excellence program, and they started by creating standards for hospitals and surgeons, and the goal, of course, was to enhance patient safety, improve quality of care. They developed a bariatric surgery longitudinal database called BOLD, B-O-L-D. And to be accredited, surgeons had to undergo a site visit where a panel of experts would come visit the hospital and verify that all the standards were being met. Now, this program was managed by a third-party independent organization called the Surgical Review Corporation, and they managed this program. This is the initial ASMBS program. Now, just a few years later, in 2007, the American College of Surgeons got into the act here, and they launched a similar program. And the American College of Surgeons has many other quality improvement programs in different subspecialty areas. So their programs participated in two competing quality programs merged together. The one program run by the ASMBS and the other by the standards, which were based on standards that came from each of these quality programs and hospitals, okay? And reaccreditation requires an actual site visit by an expert surgeon who. So this is what we now call the MBS AQUIP, which is a program of quality improvement in the United States for bariatric surgery. It also includes many centers. For MBS AQUIP was formally launched in 2015 after a couple years of developing and merging the two in the United States and Canada. And today, there's almost 1,000 centers accredited day outcomes, which includes more than 200,000 patients on an annual basis. So they can compare it with the national outcomes to make sure that they are within lines with benchmark, because the compliance or the percent follow-up beyond 30 days is quite insufficient, and I'll talk about that later, is what's called the patient use file. And this is this large aggregate database that's intended data to do research, to identify trends and try to solve problems based on the journals. And some of you, I'm sure, are very familiar with some of these publications, many of them which have been landmark papers in terms of a report that comes every 6 months to a center. This is actually from my center recently, one of the centers actually, the laparotomy and Roux-en-Y gastric bypass, which are the most common operations in North America. And you can see these different outcomes that are tracking. Expected rate, that's 1, 2, 3. Column number 4, the expected rate is based on the national data. And the far column on the right will tell you whether you're meeting standards or not. And in this case, we are meeting all the standards. One other important point is that centers in a fair way. Some set the risk of each center so that we're comparing apples to apples.
1 minute, please.
Okay. And here's the most important thing at each center. This is the review process. Review your data, institute the plan, and then with time, 6 months, a year later, assess the results. So we're constantly trying to improve the results overall. And I'm going to skip through this because this is just a little bit more detail on $10,000 a year. There's also cost to pay for the independent clinical reviewers. There's a cost to support the salary of the bariatric coordinator. And there's also, I think the impact in the last 10 years has been profound. And this is results of just one study published in 2019, a very dramatic improvement in national outcomes. For example, mortality reductions and readmissions. You see decreases in end organ dysfunction. It's clear evidence that this type of process is working. And it's actually not only this MBS AQUIP program, it's certainly in the United States considered one of the very best quality improvement programs in surgery, and that's compared to other specialties like improving efficiency, improving costs, saving lives. But the benefits of surgery, weight loss, improvement in comorbidities. We need improvements in the risk adjustment process, performed gastric bypass, so we can identify best practices so we can share that information to surgeons. So reach your goal. You're always constantly trying to improve. We have complications of bariatric surgery, and I don't think we'll see that, at least in my lifetime. I hope we do, but not in my lifetime. Thank you very much for your attention.
Thank you. Thank you. I think we'll have a panel, Masala, of whether it did add any value for them to have accreditation.
Because as Dr. Shower has shown, just as United States is about accreditations criteria. Where's the, okay. And with regards to the North America, I will go quickly. And let's see what happens in Europe. I don't know what, we don't have an supranational authority in Europe accredited to define criteria for bariatric society. In Italy, for example, they are defined by CCOB. And in any case, IFSO, that is the only supranational, the standard for the Center of Excellence in the European chapter. In Italy, we have 8 centers, a Center of Excellence. Well, basically looking for the surgeons of excellence and the institution of excellence. For the surgeons' qualifications, there are some parameters, also point 11, but it's not shown in the slide. And of course, the surgeon must have a great experience with bariatric surgery and makes a certain number of cases per year. For institutional criteria that must be stressed is having an intensive care unit inside your hospital, having an operative endoscopy available all day long in your hospital. These are the main criteria for European Center of Excellence recognized by the IFSO. And how does it work? You can make the application to the IFSO European chapter for the accreditation authority, the situation, the state of the number of complications and the rate of early discharge and the number of papers published in last year. And but once again, this is a scientific award. It is not a government. Basically, 3 levels. We have affiliated centers, accredited centers, and excellence centers. Basically it depends on the side, your center of nutritionists or psychiatricians, or at least at this level. Of course, when you got the excellent centers with more than 1,000 per year. Very recently, inside the executive board of the society, just last the quality of the Center of Excellence and the criteria the Center of Excellence should offer. And why? Of course, numbers are important, but we do not consider, at least I do not consider, excellence for education and research. That is basically the university centers in which we have, of course, no less than 150 at the hospital, and we have to publish at least 5 papers per single year. This is important because this is a center for education and research where you are more focused on the number of cases produced per single year, and in this case they must be no less than 350 per research. So in conclusion, in Europe, the accreditation for surgeons, in Italy, the Italian society is responsible for defining criteria. Said to me, but I must remind you that Italy is one of the very few countries in the world where considered responsible for a criminal offense. And this is very peculiar, is very specific for Italy and very 2 or 3 other countries in the Italian, of course, and other European recognition of the criteria that the scientific accreditation criteria are defined by any national society.
Thank you, Dr. Musalla, for giving us a clear picture of the accreditation system in Europe. Now I'd like to welcome
of health bariatric surgery centers. About Ministry of Health. So as we know, the obesity percentage is an overweight around 68%. So we have to have a proper way of, quality and also accreditation. In 2018, we were having only 10 centers. Sorry, the alphabets in Arabic. I don't know why it changed here. And in 2019, in 2023, we have 24 centers. And 2024, 26 centers. We are can I go back in the previous slide? Sorry. Sorry, can I go back? Back to the first. Thank you. Yes, the one before. All over the area in Kingdom, there is a lot of accredited centers. There is 2 types of accredited. So I'll explain in the coming slide. So yes, they are tertiary care, and B for non-tertiary care. So I will explain what is different in coming slides. The indication organization, leadership, and human resources and physical resources. So very important, go back to each director. We didn't open any center without director. And also to have all the support, try to all the centers have bariatric surgery, quality care coverage, and continue, and also long term. We have a limited data to our centers. We do it ourselves, but we are toward to make a national registry, but still data is simply done by Excel sheet, but still we have the data on all operated patients in every centers. Director also, we have to assign director. Without official assigning a director, the hospital will not even visit the hospital. So it's very essential to have a coordinated bariatric surgery coordinator who collect data, who now we are about to recognize our guidelines done by the Ministry of Health. We do also, any hospital want to get accredited, they should have, but it's not required from the hospitals. All our surgeons, they are accredited by the Saudi surgery in these centers. There is the most two important things we usually look for: psychologists and also nutritionists. This is visit any centers. We always speak with the nutritionists, bariatric surgery, then equipment. We always look for the equipment. They are safe. They have all the equipment, needed equipment like tower. We look also to the outpatient department. There's a facility and safe waiting area, need wheelchairs, so we have a special scales for that, and also the beds, examination beds. And so we visit the inpatient department. We look for the beds, for the nursing part, for the care is one of the most important points. Also we visit, and we be sure that there is ICU consultant and specialist. The beds can accommodate the patients. This is very important point. Anesthesia, they should have also anesthetists who do only bariatric. So we request a team who just follow with the bariatric centers. We gather them and in different area and do clearance. This is very important for all patients. In Center of Excellence, we do accreditations, guideline, data collection. We are looking for a national registry, readmissions, thrombosis. So we are collecting these data from each center, collecting in our hospitals. Our Ministry of Health data. Indicator the education of the patient. We look for seminars to educate some partners and company partners like ERAS and management of super obese patients, these problems. Orientation program, pathways, we do also the pathway, job description for staff in obesity centers, supplies, also we support the supplies for the required operated in the all areas in our centers. We did some comprehensive courses for each these centers. We did also a national, first conference. We gathered the obesity and diabetes together last year. So this is the most important slides. So we try to keep the major cities in the kingdom, and we upgrade these centers to grade A, even if they have some deficiency. And majority of the centers, we upgrade them to A. They are independent, and they will not require to transfer their patient to other centers. Like they can do revisional surgery, certified bariatric surgery, and sleep medicine facilities, consultant ICU, and all other specialty. A, they should do numbers of revisional, minimum 50 cases. So they can be accredited as Center A. B, they are not required to evaluate these centers and upgrade them. In the end, this is in Arabic. We send them in Arabic and English. Then we evaluate. Here we evaluate the center. We visit the ICU, recovery room, radiology department. We check for the CT scan capability, fluoroscopy. All these very important. We issue. I will finish in 2 minutes or less. Certificate will be issued. Year will be renewed. It will not be renewed until we see the data. If the data is similar to the previous year, it will be renewed, and we give them an update. In conclusion, because morbid obesity is a disease that globally affects the patient, it can cause of eradication. The aim of surgical solution should be permanent weight loss and perhaps even spiritual, also and marriage consult. So must be mentally, physically, for the rigors of surgery and permanent lifestyle changes. They will comprehensive center required a dedicated person, a strong fundamental infrastructure, and total and bariatric surgery is an accredited center compared to non-accredited center. Thank you.
Thank you very much. Our next speaker is Dr. Mohammed Al-Nami. He'll be.
May I have the slides, please? Good afternoon, everyone, and I'll try to my best to be fast and short. This is our data that are extracted from a single institute because we have 5 institutes involved in the registry. So, respected audience will be introduced to the Saudi National Bariatric Registry. What is SNBR? The Saudi National Bariatric Registry is a database of bariatric surgery in the Kingdom of Saudi Arabia. It was adapted and modified from as many as surgical centers and departments providing metabolic. It has been adopted and operated by staff managing the data through online web page with highly secure. The data collected include demographics. It has proven its role in monitoring the management and the progression of diseases. Bariatric registries are currently available in 25 countries, where majority are using the dental subjected to bariatric surgery. The importance of the SNBR in this country comes from the fact that obesity all age groups with subsequent untoward impact on health and community. 2021 to March 2023, about a year and a half, fitness for bariatric surgery. The type of surgical procedures were SADI, whether primary or revisional. The outpatient analysis, we used the chi-square, was used for categorizing significance of difference between the variables that are measured. Out the data set, and 15%, 15 points, about 95%, followed by gastric within 1 month, reported in 4.4 patients and 1.9% at 10 months. Explain those mortalities when we come to the procedure. Out of the total data, which have a female predominance, morbidities including diabetes, hypertension, asthma, and sleep apnea. During the follow-up, 68% for diabetes, 72% for hypertension, our center. These are the data from the laparoscopic sleeve gastrectomy. We had more predominance of younger than the reported data internationally. The excess weight regain was 27% over 1 year. Stable line bleeding in 3 patients. 2 patients had gastric leak, and 1 patient had poor M&M meeting, and 1 of them was related to delayed reporting with thrombosis. The follow-up of the sleeves were up to 75%. This is a glance to our gastric bypass morbidity resolution, better than sleeve. However, we had 1 complication and follow-up was 70%. The prime males, we had the age is at an older, me to 90%. 3 patients had stage 3 to 4 bilateral bedridden. About half of those patients were bedridden. And the score, according to Johns Hopkins mobility score was 6, capacity, endurance, and quality of life. 3 patients from the non-regular followers suffered. One patient developed port-site incisional hernia, no mortality in this group up to 1 year. Recent follow-up were maintained up to expected that metabolic surgery will be reliable and cost-effective as a large and standardized database that enabled a potentially invaluable information for policymakers and key would update the guidelines for such surgeries. Metabolic surgery play a major role in post-operative complications over the years of our experience. Thank you very much. And this is the, and this is the barcode that
conclude with the last talk now, and the most important, I think, so what is the role of the society, the future role of bariatric societies in bariatric accreditation?
Can you have questions and going around? I'll try here. Definitely there are a lot of things in and the impact. Yes, there is inpatient mortality reduction. There is no difference. In Saudi, Sibahi, there is some standardization, hospital standardization, which is making a difference in general. Anything, whether it's every single procedure, maybe I don't need accreditation. And if you look to the good here in terms of accreditation, insurance and financial advantage, no question about it, and predefined criteria for facilities and personnel and per practice, and you will be okay. Now, the bad is barriers to entry for new providers. And this, we've seen it. We've seen it here in Saudi Arabia. We see it somewhere. High cost and administration burdens or the patients as well. Potential for limiting access to care. Centers, nobody is providing the services for these kids. Smaller hospital may struggle to meet accreditation because of this requirement. The ugly environment. And again, unfortunately, there is conflict of interest between those people. And one or another, with conflict of interest, they say, sorry, I'm not happy about this hospital. I'm not happy about this because he doesn't like some other centers in the region or somehow exclusion of innovation and innovative techniques. Because if you wait for standard, maybe it will take 15 years to get these techniques to be recognized immediately. It needs a long time. So these are really major issues here. And if you look, unified accreditation and standardization, but not limiting our practice and service. And how to define this balance, maybe we can discuss it in the panels. Bariatric society, the practicing physician, and the hospital. Thank you.
Thank you. I think while we call the panel, Mario? Okay, Prof. Mario. And
all right, I think we're all here. We'll see accreditation happening with oncological surgery. Oh, I need the mic. Is it really worthwhile to continue accreditation? Why do you think bariatric surgery has the hype of accreditation?
The answer is that other specialties are following behind. In the US, cardiac surgery has had accreditation for almost 30 years. So bariatric surgery has followed, and there are other accreditations following. I think the proof is in the pudding. You see reduction in almost every complication and mortality. When I started, it's the same. It's not only because of accreditation, it's because good surgeons, good training, less invasive surgery, but accredited money that we're saving in reduction in if you save one leak, one PE, you can save, many, many thousands of dollars.
If we do standardization in every single, and any procedure has its own checklist and has a standardized approach, rather than having people to, maybe that will achieve the same.
No, it's not the same. Here, I'll use this. Measuring the missiles that Russia had in the United States, he used this phrase, trust but verify. Doing it, that they actually had the facilities and they're actually following the standards. It's one thing for a surgeon to say, oh, I do all this.
the Michigan database and they weren't happy with the centers of excellence, and they wrote that letter against accreditation.
All the centers in Michigan, I think there's 20 maybe, they all came together. It's been very successful. But I don't think that would replace what...
How to avoid bias and conflict of interest. And this is common, like somebody is evaluating, is not happy about this guy or that guy, is writing some...
Which happens every 3 years, there is a site review. Initially, the surgeon who is reviewing the center does not have a conflict of interest. And in other words, does not practice in the same region. And the committee decides, not just one surgeon, a committee decides whether it's up or down.
What problems that you face in your area in terms by the government?
Yes, you should consider that in Europe there is not just one country as in the United States, but we have, and especially to bariatric surgery. And this has an impact because any surgeon in his own or IFSO accreditation criteria. So this is the difference we have with the United States, and it makes
a set of guidelines for the practice guidelines. And we wrote a document, we call it the National Standard of Bariatric Metabolic Therapy, to establish a way of accrediting, verifying here a scientific body, or do we have a government regulator who may not, who may abuse it? So
repeating, it should be a third-party authority that is out from any conflict of interest.
Thank you everyone.
Everybody will come here to take photo. Everybody, but there is something we should eat as well.